new faces. And for us, this is the first time, this is a first for the Philippines actually, the first time that we're holding a scientific congress, an international scientific congress. So when we're gonna begin, we will have the, may I ask everybody to stand up for the parade of colors, followed by the Philippine national anthem. Thank you very much. You may all take your seats. So, like I said earlier, this is again a first for us. After the pandemic, we would like to welcome surgeons from the different walks of life in all over the world to gather here in Manila for our IFSO APC meeting. And to give his opening remarks, I'd like to call on Dr. Edward Oliveros, the current president of the Philippine Society for Metabolic and Bariatric Surgery.
Good morning. I'd like to recognize the presence of our two presidents from the IFSO, Dr. Scott Shikora, and from the IFSO APC, Dr. CC Wang, and of course, all of our VIP surgeons from all over the world. Thank you for being here this morning. Thank God we are here today in physical presence and not virtual presence. I'm sure we're all tired of the Zoom meetings, and it's a big change to be here in full physical appearance. I just like to tell you a short story on how we got here today. We started in 2017 when we bidded to host the Congress, but we lost to China. And then in 2019, we bidded again, but we lost to Sri Lanka. But because of the pandemic, it did not push through with Sri Lanka, and it was given to us in 2021. But with the support and persistence of Lilian Ko, Kazu Kazunori, and Mufi Lakdawala, we are finally here after 5 years. The PSMBS has come a long way. We were established in 2004 under our late mentor, Dr. Menandro Shozon, as the first president. And today, after so many years, we are recognized locally and internationally. I'm thankful to the board of the PSMBS for their support in making this event possible and a reality. But the truth is, I also thank Manuela and the staff of IFSO for jump-starting this process. They provided us with experience, wisdom, and most importantly, the finances in making this Congress a reality. So I won't take so long. Lastly, I just hope you have an enjoyable and memorable experience here in Manila. And as we say, mabuhay. Good morning.
Thank you, Dr. Oliveros. Indeed, it's a mabuhay. We also have an address from a representative of the Department of Health of the Philippines. Unfortunately, she is unable to visit us. She is the current OIC, Officer in Charge and Undersecretary of Public Health Services. Dr. Lorraine Ho will give her video recorded message to the IFSO ABC.
The Philippine Society for Metabolic and Bariatric Surgery, led by President Dr. Edward C. Oliveros, the International Federation for Surgery of Obesity and Metabolic Disorders, Asia Pacific Chapter, our distinguished guest physicians, colleagues, partners in UHC, gentlemen, a pleasant day to everyone. We would like to extend our sincerest gratitude for giving DOH an opportunity to share with everyone our continuous and expanding work at UHC, specifically on promoting healthy diets and physical activity to reduce the prevalence of obesity and diabetes among Filipinos. The prevalence of overweight and obesity among adults increased twofold and reached a record high in 2018, posing a public health emergency or concern in the country. This increase can be attributed to unhealthy lifestyle choices and lack of health supportive environments. Since the passage of Universal Healthcare Act in 2019, there has been a shift in emphasis in our country's obesity interventions towards health promotion and disease prevention and strengthening primary care, whereas traditionally efforts to improve health have been primarily focused on improving hospital services, for example. Such shows the increasing recognition of broader factors that influence health and health outcomes. In fact, when you look at the literature, medical care, including primary care, is estimated to account for only 20% modifiable contributors to health outcomes, while the remaining 80% are attributed to social determinants of health, which includes social, economic, and environmental factors. Allow me to take this opportunity to share with you some of our work at the Department of Health. For example, we've issued policies at the height of the pandemic on nutrition, physical activity, sports, and active transport. But we also released the national policy on eliminating industrially produced trans fatty acids for the prevention and control of non-communicable disease. And this is in line with the global effort to eliminate trans fat in our food supply by 2023. We also emphasize the role of supportive environments. So, partnerships with other government agencies are in place in order for us to put
还记得不知道？
healthy
我说大
food
便失禁嘛，
policies
大
in
便不是
schools
进
and
来便秘，
communities and
那就
promoting
是这个什么
safe
原
bike
因
and
呢？
walk paths and use
他
of
也受到
outdoor
同学的
public
笑话，这是
spaces
非
in
常
our
女孩子非
communities
常
to
苦恼的
encourage
事，
our people
他不知
to
道这
become
事。
more active.
而且呢，
To
你
this
看我们
end,
来讲，
we
我们的
develop
职
manuals
场
for
爱护，我
LGUs
们
or
手术都开
playbooks
得很
to
漂
help
亮。
implementers develop
我们的病人
policies,
的手术
trainings,
这个
social
道路环
behavior
大以
change
后，
campaigns,
大
and
便
other
一天十
activities
几
at the
次，然后
local
我的屁股都
community
擦的
level.
都擦烂
We
了。
have a playbook, for example, on
那
active
就是我们
transport,
来讲，外科医生
on
讲，
how to
这
set
个没什么好办法，怎
safe
么怎么
bike
的。
paths, and
但实
also
际上呢，我们
Calendaria
这一
para
块
sa
呢就
Healthy
缺少
Filipinas, which
像刘部
utilizes the
长这样
unique
的这个
positions
深
of
入的去
calendarias
研
and
究，
pushing
难
for
道是一点
food
办法都没有
nutrition in
吗？
communities.
局部刺激
These
症状的神经
activities
信
are
号
also
不断地
supported
大脑传
by
递，老是
other
想让自己
initiatives to
是不是有
improve
点办
health
法？
literacy
就
of
这些东西呢，就
Filipinos
没有人去
through
做
our
深入
Move
研
More
究。
Eat
所
Right
以
campaign
这样我
and
们的护理
celebrations
方面，
such as Obesity
这样跟我
Prevention
们护
Week
士长讲讲，也
held
这方
every
面做
first
点
week
工作，
of
这个方面
September.
工作
We
要
also have a Healthy
因为
Filipinas
讲
website
需要做的
where
工作太多了。
people
大家表
can
面上看
come
起来
in
都很
and
好，实际上
download
生活
information
非常痛
materials.
苦的那里边是。
The
所
Philippines
以
remains
所以护士
committed
长
in
就
terms
刘
of
畅护士长，
primary
我觉得在
care
这方面
to
啊，
build our
可以做
primary
大
care
量的工作。
facilities and
而
fill the
且
gap
我们说开便
by
秘门诊，到现在来
2040.
讲，外科也没
To
开起
this
来，内科也
end,
没开起
there
来。
will need to be
所以大家便秘怎么办？通
doubling
常
of our
会
primary care
做
facilities and
做
also
到什么药，各种各样的
increase
药
in the
进行
number
乱
of
用。
health
那我们
workers
就
who
是说
will be
这种
delivering
常用的
primary
药，
care. So
包
we
括这
often
番茄
get
叶、三
asked,
黄片、
ano
波
na
导
ang
这些
role
东西，
ng
有没有
specialista?
有
May
没有一些
hospital
比
pa ba?
更客观点
Definitely.
的
So
进
the
行分
DOH
析
will
的？我也
continue
看
our
过一些指
specialista
南
para
是，
sa bayan
但是来
program
讲呢，就
and
是
in
实
fact
际
will
这个指
upgrade
导
all
性
our
不是那么
regional
强势。
hospitals
所以
so
这
that
方
they
面我
will
觉得是
have most,
我们
if
来
not
讲，
all of
我
the
们医生
needed
也
specialty
也
care
可以花点时间
services.
去做一些更
Ensuring
深入研
improved
究，包括他们这个
nutrition
包
or
括他们这个
helping
针灸啊、
combat
涂三里的什
obesity
么
and nurture
新斯
Filipinos
里面的
back to
注射或者
wellness is a
其他的
role
药物的
to
注
be
射，
borne not
这
just
方
by
面特
you,
别
our
是
specialists,
西医，我
within the
觉得
medical field,
没有多少
but
口，必
definitely
须
by primary
西
care
医能做的东西
physicians,
真
allied health
非常限。
professionals,
还有咱们说
all
那个
have a
掏
role
粪
to
工，
play.
那掏粪
Further,
工呢都是
anchoring
来讲有我们
ourselves
这
on
个
the
子
theme
女，
of this
有
year's
时候给这个
Congress,
前辈、
teamwork makes the dream
给
work,
爷爷奶
it is
奶，
also clear
都
to
要做
us
这个
that
工作的
this
是。
bigger work
他大
entails
便
a
排不
whole
出
of
来怎么
government,
办？那
whole of
只有孙
society
子、儿子
approach
去掏了
and
这，
would require
对不对？
strong and
所以
unwavering
这个
commitment
工
from
作，
local
那
community
那就是说，
leaders,
那
national
随着
policy
老年
makers,
这个
your
老龄化，
knowledge,
那这个
experience,
工作
and
越来越
skills
需
as
要是。
practitioners and
所以工
researchers
作只要
with the
什么的工
support
作都伟
of
大的工
people's
作，只要能帮助别人的
organizations.
工作都
The
是伟大的
DOH
工作，
recognizes
不存
and
在贵贱的
appreciates
问
your
题是。
passionate
所以我觉
work
得这
and
是
tireless
非
effort
常
to
值得我
bring
们敬佩的，
globally
有人愿
competitive
意去做的工
quality
作是，
care to
对吧？
Filipinos
那
here.
我们开肠工
Being with
图，
all
那
of
可以
you,
逃不到，可以
colleagues
逃
here
大
today,
便
there's
还
much
是
hope for
对不
UHC
对？
and the
那我们不
country,
也照
and
不也
together
照样
let
做
us
吗？
work
是。
towards achieving a
我觉
healthy
得非常感谢
Pilipinas.
会长呢，
Muli,
一个是内容的
maraming
这精彩，
salamat.
第二呢，给我们提供一个思维的理念啊，我们要关注别人的痛苦，能够
Thank you
感受
very
别人的
much,
痛苦。
Dr.
所以
Beverly.
昨天
So,
门诊我就来一个病人，就是
as you
他这个
heard
道
from
路环大以
our
后，他
DOH
像徐主任讲，自想死
undersecretary
不
and
想活，
also from
儿子还
Dr.
是个什么书
Riveros,
记嘞，但是没有用
the，theme of
他
our
解决不了
Congress
这个
is
问
of
题，
teamwork,
一早上就要7、8次，
and we believe that
一节一
the
点一节
efforts
一点
of
是。
IFSO
实际上我
APC
们做什么工作，能
together
做什
with
么工作
IFSO
做不
in
了，
general
药物
and
都没法用。
also the local
所以
societies will be able
非常
to
感谢会长在这
achieve
个理念方面给我
greater
们提供一
greater
个
things
新的这
for
个方
metabolic
向
and。bariatric
另外呢，
surgery.
在这个在治疗方
Did
面
you
呢，
know that
做一
right
些基础
now
的研究，
we have
我
around
真的看
13
起来，
countries who are
咱们能实
participating
际
in
上
this
包括咱们在座的这
Congress,
个同学，
and
几乎会
these
成为各
countries
行各
are
科的医生，
namely
几
Australia.
乎哪个
Can I
科的
have a
医生
show
也
of
都会遇到这个
hands
问题，
from
因为
Australia?
人家认为
Oh,
你的医生
nicely
没有什么 么好办法吗？
represented.
也不知道，你自己
We
想
have
办法吧， 对不对？
faculty from
所以这个来
Brazil,
讲是一个公共知识。好，再次感谢会长
and
在
China.
对忙当中抽时间给我们做精彩的演讲，谢谢。
We also have representatives from Egypt,
行，是
from France.
下午还有一个
Welcome, sir.
那个自控会议
From
是吧？
India, from Indonesia,
下午2点钟开始，这个有时间的到来听一下。
from
因为
Japan,
这鼓楼医院和省人民医院
Welcome,
自控也是我们学习的榜样，是可以看
from
一下。
Kuwait, Malaysia, of course, from our country, Philippines, from Saudi Arabia, and
吃
from
不完的，吃
Singapore.
不完的能带走就
We
带
all
走，别
welcome
扔。
you in the first ever Congress, face-to-face Congress here in the Philippines.
这不是咱花钱买的，
yes.
这是老百姓从地里
Taiwan,
种出来的，
I'm
这
so
是。
sorry. And Thailand, I'm so sorry. And of course, the USA. So this is not an updated list. I'm so sorry. But before we begin our sessions, may I request everyone who's here to proceed in front. We'll have a quick picture taking prior to the start of our sessions. Please stand up.
Ah. 是你声音吗？哎呦呦，这怪酷。有点贴合，一个都改变了。郑州，郑州是一个官方的统计出来说，新冠自限性疾病。哦。贵州现在做手册不让出来。哦。那行，就是。实际上是好事儿，多进通知，11月起常态化核酸检测。还有一个呢，就是不搞全员核酸检测，是愿进。你愿意查就查，但是要自费。对。
Thank you very much. There will be a lot more picture taking later. So we will be beginning our sessions here, morning sessions in the Bonifacio ballroom and also in the Nara ballrooms. Also, please be reminded that the opening of exhibits will begin at 9:30 this morning. And with that, we'd like to 9:30 for the. So again, 9:30 we will have the opening of exhibits, but we will now begin our scientific sessions today at 8 o'clock. So I think we're a bit, 2-3 minutes behind, and we'd like to call on the chair for the next session. Thank you very much.
糖尿病是吧？糖尿病会变。啊，还没手术来着吧？不，他是手术完以后化疗，吸不住的。
For our morning sessions, we will be having the multidisciplinary management of bariatric and metabolic surgery. Our chairs would be Dr. Edward Oliveros, Dr. Montano, Dr. Caroline Montano, and also Dr. Jeffrey Domino.
Good morning. So I'm Dr. Carol Montano, and I'm the president of the Philippine College of Endocrinology, Diabetes and Metabolism. And I'm so thankful that our college has been invited to be part of this very successful event. So allow me first to introduce the first speaker.
反正这种保守治疗吧，反正这个原理上应该来讲量不会太大的事。
So
但
our
是能
first
出现晕厥的
speaker
话，也
is a
量也不
professor
少
of
的。
medicine of the Division of Metabolism, Endocrinology and Nutrition at
所以
University
来
of
讲，你看这个在
Washington,
夜里突发这个情况，还
based
是有点
on Medicine
对
Diabetes Institute.
有关大不
He
及
is
时
the
会出现问题。
director of the VA Phuket Sound Health Care System Weight Management Clinic Program. He graduated summa cum laude from Dartmouth College, majoring in
好，辛苦。
biochemistry. He obtained his medical degree from Harvard Medical School and the Massachusetts Institute of Technology. He had his Presidential Early Career Awardee for scientists and engineers given at the White House by the President and included 7 years of additional research funding. He has numerous awards, but I know you'll be thankful that we have him here as our speaker talking on the evidence of diabetes remission using metabolic surgery. So friends and colleagues, let us all welcome Dr. David Cummings.
So thank you very much for that kind invitation. Welcome everyone, and thanks for getting up early. It's an honor here to speak with you today about the use of metabolic surgery for type 2 diabetes. Now, this audience clearly knows very well that most people who have diabetes and undergo metabolic surgery enjoy complete remission of the disease. The most obvious mechanism of that, of course, is the secondary consequences of profound weight loss to improve insulin sensitivity. And there's no question that that plays a role. Much more exciting, though, is a very large evidence base developed over the past 15 years or so, demonstrating additional weight-independent anti-diabetes mechanisms engaged by surgery. The first of these is changes in gut hormones. This started a while back when I published a paper in the New England Journal with my group that implicated compromised ghrelin secretion as a contributor to the effects of metabolic surgery. Now, although it's become clear in the intervening years that ghrelin plays at most a bit role in the effects of surgery, if any, it did help. I think the paper was historically useful in helping launch the idea that metabolic surgery is an endocrine intervention and promoted the idea then that, for example, enhanced GLP-1 secretion may contribute to some of the benefits on diabetes. However, even GLP-1 only accounts for a small portion of the total effects on diabetes. It is added to by, for example, favorable changes in bile acids with consequences on metabolism, changes in gut microbiota with the same kind of benefits, alterations in glucose transport by the gut, and utilization of glucose by the gut, which becomes a major glucose disposal organ after certain kinds of metabolic surgery, similar to the liver. Work from my group has shown that changes in GI nutrient sensing in the proximal intestine confer benefits on insulin sensitivity. And very recent work from Randy Celia's work has implicated alterations in iron metabolism through their effects on the HIF2 alpha transcription factor to confirm benefits on both glucose and energy homeostasis. And there are many others. The importance of these weight-independent anti-diabetes mechanisms is that they justify considering use of these operations expressly to treat type 2 diabetes as the primary intent, including in lower BMI people, such as Asians, who may not lose very much weight after surgery, but still enjoy the full panoply of these weight-independent anti-diabetes mechanisms. So where does bariatric metabolic surgery fit now in overall diabetes care, including in people with only mild diabetes? Well, this group obviously knows very well that the position of bariatric surgery in medical care has been dictated for more than 3 decades by a set of recommendations conferred by the NIH in 1991, which restricted these operations to people with a BMI over 40 or over 35 with serious complications such as diabetes. Now, these recommendations were flawed in the first place, and they're seriously, woefully antiquated, but they have served the useful purpose of standardizing these kind of operations worldwide. And we can now say from 30 years of experience that in this population of heavier people, bariatric metabolic surgery is highly efficacious, safe, and cost-effective. Despite that, though, until very recently, you would not see any mention of it at all in these all-important treatment algorithms that get published every year by the various diabetes societies and dictate diabetes care worldwide. Why was surgery not mentioned at all until recently? Well, the problem, I think, was that until recently, there was a lack of relevant level 1 evidence from randomized controlled trials directly comparing surgical versus non-surgical approaches to diabetes. It's really hard to do those because very few participants are willing to be randomly allocated into such diverse treatment interventions as a major operation or plugging away with diet, exercise, and pills. Nevertheless, despite these Herculean operational challenges, the field has come to the fore and answered this knowledge void. Shown here is a forest plot depicting the main results from 12, it is now 13, randomized trials directly comparing surgical versus non-surgical approaches to diabetes. I've been a principal investigator on 2 of them. Our Crossroads trial in Seattle was notable for the extreme rigor of the lifestyle intervention, and the COSME trial with Shashank Shah and his team, notable for its inclusion of only South Asian participants and an enrichment of very low BMI people. I like this graph because we've organized it in the order of ascending baseline BMI, with the lightest cohorts at the top ascending to the heaviest at the bottom. The breakpoint for the average BMI of the study cohorts being either above or below 35 is shown there. Now, if you look at that, and 35 is the traditional position for qualifying for metabolic surgery if you have diabetes. Visually, the data look pretty similar above and below that line, and that's statistically true. So that provides us with level 1A evidence derived from a meta-analysis of only RCTs to say that the degree to which various metabolic operations are superior to any known medical lifestyle intervention is equally powerful whether your BMI starts above or below 35. So that seriously calls into question the use of that arbitrary threshold as a criterion for surgical candidacy. So we can now say, from the universally concordant results of 13 RCTs, that metabolic surgery is superior to any known medical lifestyle intervention for glycemic control, with results applying to people above and below a BMI of 35, and with results now published out to 10 years. As a heads up, I'm a principal investigator on the ARMS consortium of RCTs. We are now preparing what will probably be our most important paper to be timed for publication, hopefully at the time of next year's ADA meeting. This will report results on the largest ever cohort of people randomized to surgical or non-surgical interventions for diabetes, with results out to 15 years. And as a heads up, I can foreshadow that surgery still looks great at 15 years. So the bottom line is surgery wins on glycemic control over anything else. Fine. The trouble is glycemic control is a surrogate endpoint. Very few people actually die of having too much blood sugar in their too high a blood sugar at the moment. They die from the complications on their end organs of having high blood sugar over many decades. So a much more important question is, what are the impacts on surgery on heart attacks and strokes and microvascular events? And speakers to follow will talk about that. I'll just say, though, that I have the honor to be a co-author on a paper now under review with Asim Shabir's group, which is a meta-analysis of the impact of metabolic surgery on cardiovascular events, and surgery looks very good in these domains as well. These benefits have to be weighed against the risks of surgery. And for the patient, the question that they wrangle with, and I hear all the time in my clinic, is, hey, doc, am I likely to live longer if I have one of these operations or if I don't? And so to turn to this all-important question about the impact of surgery on all-cause mortality, I'd like to show you results from a paper that I was honored to be a co-author on with Asim Shabir's group, published last year in The Lancet. Now, I'm a shared or co-first author on this paper, but a big shout out goes out right away to the guy listed first, Nick Sin. He's a brilliant young scientist about whom I'm sure we'll be hearing more in the future, as well as my dear friend and colleague, Asim Shabir, the senior author. This Lancet paper was a longevity meta-analysis of metabolic surgery, a meta-analysis using an individual patient-level survival data constructed from prospective cohort trials and high-quality matched cohort studies, comparing people who either underwent metabolic surgery or those who did not, and importantly, were exquisitely well matched at baseline for everything you'd care about. It's a big study. Almost 175,000 participants studied for a total of 1.2 million patient years of follow-up. So this figure is the most important one in our paper. It shows the results for people in blue who had metabolic surgery, or those in orange who did not, and importantly, were beautifully well matched at baseline for anything you'd care about according to our pre-described criteria for quality. What we observed was that the folks who had surgery enjoyed a mortality benefit that was statistically noticeable as early as 1 year, and then it just got bigger and bigger and bigger every year thereafter for as many as 30. To put that in words, compared to their matched non-surgical controls, those who had metabolic surgery were associated with a decrease of hazard rate of death of 49.2% and an increased life expectancy of 6.1 years. Now, we did some important subgroup analysis, the most important of which is this one. Surgical group appears bigger among the folks who started with diabetes, and that's true. So putting that into words, compared to matched non-surgical controls, metabolic surgery was associated with a decrease in the hazard rate of death of 59.1% if you had diabetes, but only 29.6% if you didn't. Surgery increased the median life expectancy by a whopping 9.3 years among folks with diabetes and a respectable 5.1 years among those without. Translating that into number needed to treat data, we figured from these data the number needed to treat with surgery to prevent one death over 10 years was only 8 if you had diabetes. And it was 30 if you didn't have diabetes. Now, if you're familiar with NNT data, both of these are extremely favorable results, but this particular metric shows you for sure how much more survival benefit you get if you have metabolic surgery if you have diabetes than if you don't. That's presumably because diabetes is a killer and metabolic surgery remits it in most cases. This figure is a little hard for people to understand, but it shows you our estimate from these data, the number of people saved per year in the world with each 1% increase in the actual usage of surgery among qualified candidates. So to put that into easier to understand words, we calculate that for each 1% increase in the actual use of metabolic surgery among qualified candidates, you'd save about 12 million people next year, and another 12 million the year after, and so on. I submit to you, we now have relevant evidence from sufficient randomized trials and larger, longer-term studies with hard outcomes to inform and that's been a major objective of the Diabetes Surgery Summit series of initiatives I've been a leader on for some years, in particular with the other PIs on this, Francesca Rubino and Phil Schauer. Now, DSS initiatives are many, but the most important objective overall that we've had is to replace those old NIH standards with newer, modern, evidence-based recommendations. And we've worked with experts from throughout the world and agreed with high consensus that metabolic surgery may be considered to treat poorly controlled diabetes in patients with a BMI as low as 30 or down to 27.5 for Asians. And it's worth noting that A paper was just published by combined forces from IFSO and ASMBS that agreed with these statements and most of the other things from DSS. It may not seem like a very large numerical change to drop the BMI threshold for people with diabetes from 35 to 30, but it does include a lot of people. And I estimate there's about 300 million people in the world with diabetes who could consider metabolic surgery as an option under the DSS guidelines, but would not be able to under the old NIH. They would if, that is, these things are actually implemented. So let me show you now some countries I am aware of who have implemented DSS as their standards on some level of a national policy or similar recommendations. Bless your heart, Asim. Singapore, I believe, was the first. Then Saudi Arabia. Importantly, India and China, where most people with diabetes live. Taiwan, Australia, the United Kingdom, Chile, Argentina, Brazil, the Philippines. Thank you very much, Philippines. Thailand, Malaysia, Indonesia, Japan, South Korea, and Hong Kong, as well as recently Switzerland. How about my country, where it's really hard to change policy because there are so many different insurers? Well, already there are some increasing number of US companies large enough to self-insure that are dictating their policies based on DSS rather than NIH. Importantly, the United Health Group, the largest health insurer in the world, uses DSS criteria now in lieu of NIH. Medicare is actively considering it. And importantly for me personally, all the Department of Defense and National Veterans Administration hospitals in our country now use DSS criteria. That's important for me because I work at a VA hospital. So in clinic, I can already take a guy with poorly controlled diabetes and a BMI of 20 who's Asian and submit him for, say, a gastric bypass in consideration for his diabetes. Despite all this evidence and policy change, however, the actual usage of bariatric metabolic surgery among qualified candidates remains incredibly low and stagnant. Here's some evidence to that effect we put together for one of our DSS projects. It shows the actual percentage of people who qualify for surgery who have it. In my country, it's a little less than 1%. In the whole summary of these 44 countries, it's about 0.86%. And these numbers, as well as being low, are incredibly stagnant. So that's frustrating for all of us. Another DSS project we did to address this was convene a major international consensus congress to identify barriers to the uptake of metabolic surgery. Among the many we identified, but one of the most important was an entrenched and pervasive level of obesity stigma that makes people afflicted with obesity feel self-guilt and not even search for any treatments whatsoever. So we published this joint international consensus statement for ending the stigma of obesity, and we're very proud that it was published in Nature Medicine, and it has been formally endorsed by more than 100 medical, scientific, academic, and political organizations, as well as top peer-reviewed journals. I'd like to close with just 2 slides addressing the question of how should we prioritize metabolic surgery in the time of COVID. So what happens with COVID is the wave sweeps through your particular community. All elective operations are shut down for a while, and then there's a big backlog of people waiting for surgery when you start up again. How do you choose who to do first? So again, with the DSS project, we addressed this in a paper we published in the Lancet Diabetes Endocrinology. I'm the senior author on this. And the crux of the paper was a treatment algorithm, or a triaging algorithm to figure out who should be chosen for expedited surgery versus who can afford to wait. This is published and it's very detailed, so I won't go into the little nitty-gritties, but the important crux is this. We figure that when you're facing a backlog of people waiting for surgery, the priority should be given not to the heaviest people with that largest BMI, but those with the largest burden of metabolic disease, likely to kill them if you wait and likely to be ameliorated by surgery. So if you're faced with a woman with a BMI of 50 versus a guy with a BMI of 38, and she has no complication and he has 3, he should be prioritized even though he's much lighter. The most important thing of this work is that although that triaging algorithm is particularly germane shortly after the COVID pandemic goes away, there's no reason why it could not be used to make clinically germane and meaningful prioritization decisions long into the future, because the principles still apply. I've had the privilege to work with many talented people at the University of Washington over my career, as well as many cherished colleagues worldwide. I sincerely thank them for their hard work and you for your kind attention. And I'm finished.
Thank you, Dr. Cummings.
Sure.
Do we have any questions from the floor for Dr. Cummings? Okay. Dr. Cummings, you don't mind, I'll ask you a question.
Oh, sure. I didn't know there'd be Q&A, but go ahead.
In 2020, at the start of the pandemic, I attended many of your webinars connecting obese diabetic patients with COVID. So you in your lectures you saw that there was an increased risk of this obese diabetic patients in the hospital, in the ICU, higher mortality. I remember that. Now that 2022, now that we're all vaccinated, is it any different in terms of morbidity and mortality for obese diabetic patients? Is it any better or worse or same?
So I'm very familiar with the data on the increased risk factors of severe COVID among people with obesity and with diabetes and several other obesity-related complications. I am not an expert on the impact of vaccines on that risk. It seems hard to believe that the vaccine wouldn't be helpful, not because it changes the underlying risk if you get COVID, because it prevents you from getting COVID. And even if you get it, you're less likely to have a severe disease. But I'm afraid I just don't know the literature on the impact of COVID severity among people with obesity and diabetes who've had vaccine. I'm sure it's helpful.
Thank you.
Scott.
David, I hate speaking after you do because you do such a great job of putting everything together. Mine is primitive compared to what you stated. It was a great talk.
You're too
What
kind.
I really want to talk about is you sort of very casually mentioned the new guidelines that ASMBS and IFSO had worked very hard to do. And you rightfully admitted that it's very similar. There's very little, I'm sure, difference between ours and the DSS. I'm a little bit bothered because I think when you have competing entities out there, they tend to negate one another. We worked really hard on this, and it would be a shame to be viewed poorly in the outside world because now there's guidelines from DSS and who knows who else. I think we need to speak one language.
Agreed. I didn't mean to dismiss them in any way. I think maybe the fact that two different entities came to the same conclusions should be supportive, since it would be hard if we gave different messages.
True, that's my concern is it completely the same or will there be differences once you go through it with a fine-tooth comb?
It's a pretty new paper. I only have read it briefly, but I was impressed with the similarities
Well, that would be great then.
and not the differences. I don't think I can remember any differences, anything of substance. So I think we speak with one voice on this, Scott.
Okay, I hope we do because we worked incredibly hard to get rid of those 31-year-old guidelines. And in fact, it would have been nice to have a presentation here about it because we just did it within the past several weeks.
Right. I just saw it, within a couple of weeks ago. So I didn't spend more time on it, but 15 minutes is short and I didn't do it.
Yeah,
Okay.
thank you.
I was told I should entertain 2 questions. That was it.
Yeah, that's fine. Thank you, Dr. Cummings. Speaker. Where's the CV? Okay, I'll present the next speaker. He's the current IFSO president. He's also a professor of surgery from Harvard Medical School and director of bariatric surgery in Brigham and Women's Hospital in Boston, Massachusetts. I'd like to welcome Dr. Scott Sikora.
Thank you very much, Edward. I want to thank the organizing committee and the members of the Pacific Society for allowing me to speak today. And again, he does such a wonderful job speaking on medicine, surgery, no matter what. It's hard to follow him and to present a whole topic about metabolic surgery in 15 minutes. I'll do the best I can. These are my disclosures. None of them have any bearing on this presentation. And I think obesity is the ultimate metabolic disease because every organ system of the human body is adversely affected by obesity. And I can't think of anything that's benefited by it. Maybe cushioning for when you sit down, but I can't think much else. So here was, oh, right. So here you have a disease with so many other conditions that don't seem to be related to one another, which is the key to metabolic surgery as it was first stated by Henry Buchwald. Now, it's right to put the focus right now on diabetes because if you look at this map and look where the world's going to be in a few years, hundreds of millions of diabetics, hundreds of millions of patients with obesity and with diabesity. I don't know that we can afford to take care of all these patients. In addition, look at Asia, where you folks live. Asia is probably going to be hit the worst in the international view of all this. So this is something we have to work on and we have to work on now. So you have this dual combination of pandemics, basically, diabetes and obesity. And some people are throwing it together and calling it diabesity because how interconnected they are with one another. You already heard at least some of the newest data on it. I'm just here to mention that diabetes and obesity go hand in hand, and that as us in the surgical realm know, that bariatric surgery generally improves the diabetic patient and even puts many of them into remission. And as Dr. Cummings mentioned, something that we found interesting many years ago is that improvements are often seen long before there's much weight loss. You make rounds, the patient had surgery a day or two before and they're still in the hospital, and you notice that their blood sugars are normal now and they're not on any medication. Well, let's talk about medical treatment for diabetes. It never cures the patient. The best you can do is control their sugar. The medications, many of them have side effects. Some of them are quite costly. Many of them are injectable. Patients, well, we know they're not that compliant with taking their pills, so they're no better with their diabetic medication. So 1 in 5 of these patients still has poor glycemic control, and the disease continues on and on and on, the heart disease, the kidney disease, the potential to go blind, the potential to need dialysis. Now, this is, you have to really look at this for a while to understand it, so I'm going to cut right to the chase. In 2006, only 43% of diabetics in America were in decent control, meaning that their hemoglobin A1C that should be was below 7. 60% were above it. So now look in 2013, which is on the other side, we're talking 7 years later, a whole batch of new medications are out there to treat diabetes. And lo and behold, 45.8%, almost the exact same number, are still not in good control. What have we done in 6 to 7 years? Nothing. How about Best Medical? Well, this was the look-ahead trial. And this was a multi-center randomized trial that compared intensive lifestyle exercise with diabetes support medications on cardiovascular disease in a group of about 5,000 diabetics. And what they found was, despite best case medicine, best case exercise, best case medications, that while it did improve the markers in this group of patients, 33%, 1/3 of the patients in the control group still needed medication by 12 months or were back on medication by 12 months. So we've gotten nowhere with non-surgical treatment. What do we know about surgery? Well, you can't have a talk about diabetes and surgery without somehow mentioning Walter Porres in his original paper. At this point, we all know this because we've published multiple articles after that in many randomized controlled trials, as you heard about. But what Dr. Porres demonstrated was you got to operate soon. You can't wait. The longer you wait, the less the likelihood of getting the benefit, and that patients who are diabetic may not do as well as patients who are glucose intolerant. So if I had an hour, I could easily put together a scientific presentation on you covering all of these issues. But if I wanted to boil it down to the one slide, this would be it. If you have metabolic surgery, the likelihood is that you'll decrease the chance of developing type 2 diabetes if you haven't yet. You may delay the onset of developing type 2 diabetes. You may reduce the progression of the disease. You may put it into remission. I use remission. I don't use the word cure because I think you'll see for some people, the diabetes does come back, but it kicks the can down the road because you're giving them that period of time of good health. And also it improves the sister conditions, the hypertension, the sleep apnea, the GERD, and everything else. The effects are sustainable. A number of papers have demonstrated that if you follow these patients out a period of time, as I did in this trial by Stacy Breathauer, that many of them, in this case, about 25% stayed in complete remission, another 26% partial remission, and 34% improved. So almost 80% of candidates still demonstrated the benefit 5 to 9 years later. How about preventing diabetes? This is the Swedish obesity trial. And what they have been doing is following patients in their database for over 20 years now, probably closer to 30 years. And in this cohort, they looked at patients that had surgery and matched against patients that didn't have surgery. None of the patients at the time of enrollment were diabetic. That's the key here. They followed them up to 15 years and demonstrated that in the group that had bariatric surgery, that only 6% developed diabetes over that period of time, whereas those that did not have surgery, the matched controls, they had 1 in 5 went on to develop diabetes. Now, the Stampede trial by Phil Schauer is long in the tooth, it's small, but I still like it. One, because I love the name Stampede, but more importantly, because it's simple, yet it's elegant. They looked at 150 patients, 50 bypass, 50 sleeve, 50 medical. Best medical meant in this study that all of the patients had their diabetes managed by one endocrinologist, not a family practitioner in New York and an endocrinologist in Cleveland, one person. So they all got very similar medical treatment. And they then looked over a year's time, the primary endpoint was having their hemoglobin A1C below 6 off medication. And no surprise, the surgical arms beat the pants off the medical arm in all categories. Now, they did not power it to compare sleeve versus bypass, so don't even look for that. But if you look against best medical, surgery won out in every category. What about as time went by? Yes, a number of patients started to lose that benefit to their diabetes, but the medical group went back to 5%, almost zero. There was almost no benefit to the medical group to maintain, there was no way they could maintain their improvement in diabetes, where the bypass group was still about 29% and the sleeve group 23%. So why delay? Some of the health insurance companies used to ask us to wait until the patient was on multiple medications or had end-stage disease, and that's too late because at that point already the pancreas may not be salvageable. Multiple studies demonstrated that if you operate sooner than later, you reduce the risk of relapse, you improve the opportunity to put the patient in remission, you prevent them from getting the other comorbid conditions. And how many of you have had a patient die on your waiting list because you couldn't get them to the OR because of insurance or whatever else? And Walter Pori's also demonstrated that. Whether it's accurate or not, I can't say, but it certainly seems logical that if you look at the panels from normal lean, normal obese, glucose intolerant, that you could see to maintain the normal blood sugar level, the patient with insulin resistance has to keep putting out more and more insulin. But then there's that break point where they, it's not nothing's pointing, where they no longer cannot control their sugar despite getting a lot of insulin, and that's when they become the insulin-dependent diabetic. And that's the position that you don't have much chance of putting that patient back into remission. So you got to get to them earlier. And always remember that obesity and diabetes are not the only two metabolic diseases out there. There's a whole slew of them related to obesity that will get better or improve with bariatric surgery. So we have the opportunity to do a lot good. This is demonstrating that a year after laparoscopic gastric bypass, if you add up the improved and the resolved columns, except for depression, it's almost 100% in every category. There's nothing else in medicine that can boast data like that. And I'm sorry, I misquoted it. I'm going to change this slide to 13 randomized controlled trials, or I can wait for your next two, then I can go. What's that? Okay. So anyway, so we now have the data to back up what we've been saying for decades. And this just demonstrates that the number of cases going up yearly. In 2018 in the United States, we did 252,000 cases. The rest of the world did about the same, for a total of about 500,000 cases around the world. Is that too many or is that too few? Hard to say, but clearly we're operating on less than 1% of the patients who need our help. All right, let's just, in the last couple of minutes, talk about a few other conditions that I find interesting. One is heart failure. The risk of heart failure dramatically goes up when patients have obesity, multiple mechanisms. I'm just starting to learn a little bit more about the inflammatory issues that lead to heart disease and impaired cardiac metabolism, which seems to be the nidus for the heart failure. And then on top of that, you have the atrial fibrillation, you have the coronary artery disease. So these folks have a lot of things going on. Generally, it starts off with asymptomatic diastolic dysfunction, but over time, it leads to left ventricular dilatation with poor ejection fraction and reduced systolic function. And these patients get into big trouble, but because of their weight, they can't be listed for a heart transplant. This is data from the Utah obesity study being done by, what's his name? I just spaced on it. Anyway, 423 patients compared to 700 that did not have surgery. And they demonstrated what I found very interesting, not only improvement in cardiac function, but the muscle itself remodels from an inefficient model to a more efficient one, kind of like preoperative, pre-disease. And I thought that was very interesting to learn that the heart can actually remodel with weight loss. Now, heart transplantation is often contraindicated in these patients because of the obesity. And if you can treat the obesity, they may have been candidates for surgery, but sometimes their obesity makes them too high risk to have anything done. So studies have looked at that, and if you can get them to the operating room and do bariatric surgery, their cardiac function may improve to the point they either can be listed for a heart transplant, or in a few cases, the function improves enough they no longer need a heart transplant. And I've had a few of those patients. So there's not a lot of data on it, but it may be an important factor in the future. There are 13 cancers known to be associated with obesity. The two that are most prevalent are endometrial and breast. And as you can see here, the hazard ratios are high for each one of these cancers. And it seems that patients with obesity who have surgery compared to those that do not have surgery, those that had surgery, the diagnosis is made earlier. The stage of the disease is often lower. They are more responsive to treatment and they have a higher survival. Now, this is just, I know it's a lot to look at, but basically this looked at patients that had surgery, bariatric surgery, and at some point developed breast cancer or endometrial. And then you need to look only at the numbers in the parentheses, and you could see that they were statistically significantly better if they had bariatric surgery at some point before they had their cancer. And this just demonstrates that those that had bariatric surgery had a better survival. Last topic I want to cover is COVID, because Ali Alaminian from Cleveland wrote this paper that came out recently in JAMA. And what they demonstrated was that when patients came in with COVID, the rates were the same for both the patients that never had bariatric surgery and the patients that did have bariatric surgery. So it's no different in the rate of contracting COVID, but those that had bariatric surgery, 49% reduction in hospitalization, 63% reduction in the need for oxygen, 60% reduction in severe infections. That's pretty compelling. So in conclusion, bariatric metabolic surgery has been proven to be the best treatment for a wide range of metabolic diseases, from type 2 diabetes to cancer to heart disease, and many, many, many that I didn't mention. Bariatric metabolic surgery should be considered for patients with obesity and these other conditions, and it's illogical to restrict its use using 31-year-old guidelines and an overall reliance on BMI. I think we rely too much on BMI. Thank you very much.
Thank you. Thank you so much, Dr. Scott Shikora, for sharing us your thoughts and lectures. May I just have one question? You've shown slides and studies regarding the years that they have remission for type 2 diabetes. But in your practice, in the study, it is only around 6 years. But in your experience, sir, like how many years would they develop this remission from type 2 diabetes?
Sorry.
Remission, sir? Yeah. Because we are now seeing, after the pandemic, we are seeing younger type 2 diabetic patients, and the triggering factor is really obesity. Will they have remission? In your experience, sir, like those you had operated 10 years ago, are they still are they still not taking any medicines for type 2 diabetes?
Some aren't, as I showed you on the slide by breath hour, that about 25 to 30% were able to maintain it. Another 25 to 30% were maintaining it, but not fully. So they were on medication, but less than before. And this group of about 20% had relapsed. I think it depends on weight regain, and I think it also depends on the status of their beta cells. So how soon did they have their bariatric surgery in the scheme of the progression of beta cells from healthy to unhealthy?
Early intervention, really.
I guess.
Scott has kind of given me the opportunity to address this with a paper. Probably the best paper I know of is by David Arterburn and my colleague in Seattle. It was a study of nearly 5,000 patients with diabetes who had gastric bypass and were then followed for 13 years. The remission rate was typical, about 70. And then the question was, of the 70% who achieved remission, what percent will have relapse over 13 years? And about 1/3 relapsed during the 13-year period. At the time, the press was very hard about that because they said, they're like, oh, we thought you cured diabetes. You're lying to us. What they failed to understand is that 2/3 did not remit over 13 years. And the average disease-free period among those who remitted was 8.5 years, given what we know about the benefit of even tight glycemic control versus loose glycemic control for a short period from the UKPDS and DCCTE things. Imagine the benefit of having no diabetes for 8.5 years. We don't have the data yet, but that's certainly going to confer benefit on long-term mortality, cardiovascular risk.
May I have one more question? Hello.
Yeah. Go ahead. Dr. CK has a question.
Thank you. Hi, President. Love to hear your talk. I think we have doing bariatric surgery more than 20 years now. And since 20 years ago, we start to talk to endocrinologists that they should accept the concept of bariatric surgery. But according to this few years, we did not see we have any change in the mindset. We did not get the referral from the endocrinologist. The reason, I think, because we have different mindsets. They think that they are maintaining the patient in good health and without complication, but they think surgeons are making complications. But it's really worth it for them to change it or not. Maybe, I think in the future, next 10 years, maybe they still don't do that. The problem is that the medical factory is trying to invent some new medication like GLP-1 agonists. The results can achieve about 20 to even 30% for the weight loss. How do you think that the bariatric surgery is only one part of the history, or you are president for many, many years?
Well, two comments. First comment is there's so many people out there that need something that we shouldn't be looking at those and saying, you know, those patients should have surgery. There's so many patients that there's plenty for medical therapy. The GI people are coming up with newer endoscopic procedures that also are achieving fairly good results. There's so many people out there who need our help that I think we all can be very busy helping them in the way we know best. I have a cynical comment about our relationship with endocrinologists. If a cardiologist sends me a patient and I do surgery on them, they're going to go back to the cardiologist yearly. They'll go to their primary care doctor yearly. They'll go see their orthopedic surgeon yearly. But if we put diabetes in remission, there's no reason for them to go back to an endocrinologist. So is some of the issues we have with them turf battles? You know, whose patient is it? Who's going to be the one keeping the patient? And there may be a reason why at least some of our colleagues are hesitant to send us their patients.
You know, I think this is a really important thing, what you said, and I agree with about there's room at the table for both. Fewer than 1% of people who qualify for metabolic surgery have it. Fewer than 1% of people who qualify for weight loss medications take them. So the vast majority of people out there with obesity don't get either. And it shouldn't be you versus me or us versus each other. It should be all of us as a united front allied against the common enemy, which is obesity, and that enemy is winning. And so it should be surgeons, endocrinologists, dietitians, exercise physiologists, educators, politicians on the same team working against an enemy that so far is beating us. It'll take all of our efforts to get any dent into that.
We in our group, we have endocrinology, we have medicine, we have GI, and we have surgery all together. We meet weekly and discuss common patients. And if a patient goes on medication and it doesn't work out, they refer the patient to us for surgery or maybe to GI. So when it works, it can work quite well. And our volume went up actually in that system. So working together with the medical people, the GI people, whoever else could be a benefit, and it clearly would be for the patient.
All right. Thank you very much, Dr. Escora. Let's give him a big hand. Thank you for a very great presentation and a good discussion as well. So to continue with our first session, and indeed, this is a multidisciplinary management of bariatric and metabolic surgery. Our next three speakers are actually a part of the team, as they mentioned, and they are. One of them will be we will have a message coming from an endocrinologist, a cardiologist, and a clinical nutritionist. So it's a good resource. These are good resource speakers, and we would like to hear from them. And then let's see the next speaker. Okay, so the next speaker, he's a Filipino endocrinologist, a professor of the Philippine College of Medicine, Department of Biochemistry and Molecular Biology, clinical professor in Division of Endocrinology and Diabetes and Metabolism of the Department of Medicine at the Philippine General Hospital. He's presently the president of the Philippine Association for the Study of Overweight and Obesity, presently the treasurer also of Philippine College of Physicians, a council member of the Asia and Oceania Thyroid Association, and the past president of the Philippine College of Endocrinology, Diabetes, Metabolism, and head of the steering committee of the Philippine Clinical Practice Guidelines on Screening and Diagnosis of Obesity among Adults. Let me present to you Dr. Nemencio Nicodemos Jr.
Thank you very much. Before I begin, I would like to thank the organizers of this Congress for this kind invitation to be part of the faculty and in this prestigious Congress. My task this morning is to discuss the current state and management of diabetes in Asia. Over the next 15 minutes, we will characterize the twin burden of diabetes and obesity, or what we call as diabetes in Asia. We will discuss the consequences of diabetes among Asians, and lastly, explain the recommendations in the nutritional and medical management of patients with diabetes in this part of the world. Data from late 90s up to early 2000s revealed that Asians tend to develop diabetes at body mass indexes that are not really very high. As you can see in this data, wherein they compared several countries in Asia, which includes the Philippines, you can see that the prevalence of diabetes in our country and in other Asian countries is already big compared to the prevalence of people who are considered obese at that time. But what is the importance of looking at people with obesity and subsequently developing diabetes as a result of obesity? This was recognized as early as 1973 by Sims and his colleagues when he wrote and actually coined the term diabesity, which means that it is a diabetes that occurs in the context of obesity. And therefore, obesity must be pre-existing for these patients to develop diabetes. More recent data in Asia showed that if you look at people who are developing diabetes, in this cohort of more than 900,000 individuals in Asia, from Bangladesh, China, India, Japan, Korea, Singapore, and Taiwan, what is clear to see is that 4% of Asians develop diabetes. But I would not put more emphasis on that, but what I would like us to concentrate is that if you look at Asians whose body mass indexes fall in the category of obesity, you will see that the more obese Asians are, the more prevalent diabetes will be. And in fact, among Asians who are obese by BMI category, 36.1 have diabetes. And so 1 out of 3 Asians actually have diabetes. And when we put together the data segregating males and females, you can see a similar prevalence among men, but seemingly the women in Asia are more prone to developing diabetes. Another interesting feature of diabetes in Asia is that when you look at the age, we know that age is a factor for developing diabetes. And so, consistent with data around the world, the older the population, the greater the number of patients who develop diabetes. But when you try to compute the prevalence of diabetes, that is diabetes with coexisting obesity in Asia, there seems to be a trend that is decreasing. You can see here that data for people younger than 50 years old shows a prevalence of diabetes of 40.5, whereas adults more than 60 years old have a prevalence of diabetes of only 33.9. That is because the denominator is decreasing as far as obesity is concerned in this cohort of patients. But we're not interested just in the number of people who develop diabetes, isn't it? We're more interested in what are the consequences when people develop diabetes. And one such consequence will be death. And a cohort of more than 1 million Asians in the same countries that were part of this Asian cohort consortium, monitoring patients for about 12 years, they were able to show that the risk of dying from any cause among patients with diabetes in Asia is almost doubled. And that is true regardless of the body mass index of patients in Asia. More than all-cause death, let us look at cause-specific mortality in Asia. And this is the same data from this more than 1 million cohort of patients. And what you will see is that if you look at the table comparing the body mass index and the risk of death, depending on the cause, what is clear is that Asians die from cardiovascular disease, coronary heart disease, ischemic stroke, hemorrhagic stroke, and diabetes in itself. In fact, if you look at the hazards ratio of diabetes compared to the other causes of death, it gives you a very large figure, meaning that Asians tend to die due to diabetes itself among those patients, particularly those who have diabetes. But interestingly, underweight is a very important subgroup. You see here that even patients in Asia who are underweight have higher rates of death due to diabetes. And these underweight patients may reflect the severity of diabetes and or the presence of complications due to poor management of the disease. And of course, we know that poor management is manifested by underweight among these patients with diabetes. Another very interesting finding in this more than 1 million cohort of patients is when you look at the other very important causes of death, particularly complications related to diabetes, you will see that renal disease leads the causes of death among Asians with diabetes. But a very interesting disease, respiratory diseases, is very much significantly associated with body mass index. And thus the association of diabetes and the risk of death due to respiratory disease was stronger among Asians whose BMI is more than 23. So we should consider that. That is something perhaps that may be unique to the Asian population. A lot of Asians die due to diabetes, due to renal diseases, but that respiratory diseases seem to be very much correlated with heavier weight and higher body mass indexes. So what are we doing here in Asia in order to address this problem? We have a consensus statement on the medical nutrition therapy for diabetes, which has a very interesting acronym, COMMEND, in adults. And this is a South Asian perspective. Here, a group of doctors from South Asian countries, from Bangladesh, Bhutan, India, Nepal, and Sri Lanka met to actually come up with this consensus statement. And according to the COMMEND, we should be assessing patients with diabetes using the 4 M's. What are the 4 M's? Metabolic, mechanical, mental, and monetary considerations. Under the metabolic, we should be screening for all of these conditions, making sure that we control not just their blood sugar, but also their blood pressure and their lipid profile. And you can see there are other diseases associated with diabetes. Mechanical is a problem that a lot of our patients complain about. Sleep apnea, osteoarthritis, chronic pain are some of these very common mechanical problems that we must also assess among our patients with diabetes here in Asia. Mental, I'm glad that our first speaker was able to talk to us about the importance of looking at the stigma of obesity, and that we should recognize that our patients with diabetes also have cognition problems, experience depression a lot, and other problems. And finally, a very interesting feature that we must be always asking about, particularly in Asia, is the monetary aspect. Of course, we know the differences in our capability to pay, and even our healthcare system here in Asia is very different from America and even in Europe. And we have to consider that greatly among our patients. in this consensus statement, they put a premium on medical nutrition therapy because it is both therapeutic and preventive. Medical nutrition therapy can treat diabetes as we know it, but it can also prevent obesity. And therefore, for diabetes, medical nutrition is very important both as a therapy and as a preventive measure. And one very practical way that we can give our patients advice that is easy to remember, and I always use this among my patients because it's very visual and they can easily remember it, the plate method or the portion control that we must always educate them on. It is something very visual, easy to remember, and something that our patients can really appreciate from a practical standpoint. What are some of the recommendations as far as the medical nutrition therapy is concerned that may be unique in this consensus statement in South Asia? We know that the American Diabetes Association does not provide any recommendation on carbohydrate intake. But in the commend consensus statement, they want to reduce the current carbohydrate intake by 10 to 15%. Why? Because we know that Asians love carbohydrates. We are rice eaters. We have a lot of dishes wherein we have carbohydrates. Noodles are very much staple here in this part of the world. As far as proteins are concerned, the ADA recommends 15 to 20% of total energy coming from proteins, but because in Asia, we tend not to eat too much protein, the recommendation is to try to increase the current protein intake by 10% to a maximum of 1 gram per kilogram body weight per day. That is again something unique in Asian population. And lastly, as far as saturated fats are concerned, we know we have a lot of trans fats here in Asia. I guess the urbanization really caught up with Asia such that a lot of people like to eat chips, like to eat in fast food restaurants. And so we have a lot of trans fats going into our system. And one of the very important recommendations is to try to minimize visible fat intake. Now, after we have assessed our patients, we must monitor them, right? You do not stop at just giving advice. So what do you assess and monitor among Asians with diabetes? Food and nutrition-related history, anthropometric measurements, biochemical data, medical tests and procedures, and lastly, nutrition-focused physical findings. And what I would like to emphasize is that when you talk of food and nutrition-related history, this is perhaps something that's unique to our population, right? We know we have different beliefs and attitudes, especially food preferences here in Asia. Even the motivation to lose weight is also quite different here in Asia. The food environment, including access to fruits and vegetables, especially now that prices are going up, it may be actually difficult to get fruits and vegetables because they are more expensive than the not so healthy food, so-called. And of course, when you talk of nutrition-focused physical examination, communication is the key. We must know what motivates our patients to improve their diabetes control and their weight, and we must also look at their appetite as well. Now, how do we simplify the way that we give advice to our patients? In this consensus statement, they say that counseling in diabetes is as easy as ABC. ABCDE actually stands for asking permission to assess the patient, be systematic, communicate with empathy, de-stress the patient, and engage all stakeholders. And I'm glad that this Congress is full of different stakeholders that are really involved in the care of patients with obesity and diabetes. In terms of content, it is also as simple as ABCDE, and the content should include agreed upon goals and targets, behavior change, cycling of weight, which must be prevented, diet and nutrition therapy, which are very, very important, and exercise, which must be emphasized. We've been talking about medical nutrition and lifestyle, but what about pharmacological intervention? Recently, an Asian perspective and expert recommendation was published, particularly on the use of a unique anti-diabetes agent, your SGLT2 inhibitors. And among patients with type 2 diabetes and abdominal obesity, what is the current recommendation from the experts? That weight loss is an essential component and goal for patients who are overweight, obese, and with diabetes, and that lifestyle must be first considered among these patients, and we must achieve and maintain weight loss, that you must limit the glucose lowering to agents that promote weight loss, and that in overweight patients, the use of glucose lowering agents to promote weight loss are preferred, such as your SGLT2 inhibitors. And SGLT2 inhibitors, therefore, are recommended to promote weight loss and reduce visceral adiposity among Asians because they promote weight loss as monotherapy or in combination, and that more than 2/3 of SGLT2-induced weight loss is attributable to the loss of body fat. And finally, that this treatment reduces waist circumference and ectopic fat deposition in the non-adipose tissues, improves adipose tissue function, and health-related quality of life. In summary, what have I discussed with you, dear colleagues? Number one, that there is a coexistence of diabetes and obesity or diabesity, which affects a significant number of population in Asia. It is associated with higher all-cause mortality and cause-specific mortality among Asians, and that consensus and expert recommendations emphasize medical nutrition therapy, exercise, and pharmacological agents such as SGLT2 inhibitors to promote weight loss for the management of diabetes in Asia. Maraming salamat po. Thank you. And for our colleagues here who are not from the Philippines, I do hope that you enjoy the Filipino hospitality. Thank you very much.
Thank you, Dr. Nemi. Any question from the floor with regards to the lecture? If none, I do have one question, Dr. Nemi. First, it was a good lecture since you presented the assessment way, and you're also the nutritional and the ABCDE approach. My only question is, when will surgery now be indicated, knowing that these methods has been done so many years? And a while ago, our two professors mentioned that there is a really role for surgery and the effect. So in between, where will the surgery come in? Thank you.
I know that that question will actually be answered because the speakers who came before me were actually talking about metabolic surgery. But then again, because in my talk, I was just limiting it to medical nutrition therapy and pharmacological interventions, I did not discuss that really obviously, but we would still follow the current recommendations for the indications for metabolic surgery. I know that here in the Philippines, we still do not have our own as far as the recommendations, but I'm happy to say that we are now making the clinical practice guideline, and part of the second phase of the clinical practice guideline would actually be the intervention. And definitely, we will consider metabolic surgery in the clinical practice guideline in the Philippines.
All right. Thank you very much, Dr. Nemi. Again, let's give him a good applause. Thank you.
Okay. Our next speaker is part of the multidisciplinary team She's a vegan cardiologist who specializes in echocardiography, cardiology, and IM. She practices at the Philippine Heart Center, National Kidney and Transplant Institute, St. Luke's Medical Center, Quezon City, and Providence Hospital. She's also the medical affairs specialist of Pfizer Philippines. I now present Dr. Ana Adora.
Hi everyone, it's nice to see faces and not like on Zoom. I want to thank the organizers for inviting me today. So my talk is actually on the effects of bariatric surgery on cardiovascular disease. I just have to disclose that I work for Pfizer as a medical affairs specialist. So before I go to the meat and potatoes of this short lecture, I'd like to go over the effects of obesity on the cardiovascular system. I feel like some of us internists don't recognize obesity as an independent cardiovascular risk factor and just treat the separate comorbidities independently. So when you have obesity, you have early and accelerated atherosclerosis. And this is because of insulin resistance. It's also because of the inflammation. So that inflammation induced by obesity increases the likelihood of LDL oxidation, and this promotes atheroma formation. So that accelerates atherosclerosis. It also leads to endothelial dysfunction. So we have diminished bioavailability of your nitric oxide. And again, that accelerates your atherosclerosis. And also the other comorbidities that are associated with obesity accelerates the atherosclerosis. So this would be hypertension, diabetes, your sleep apnea, and dyslipidemia. We also have heart failure. So with obesity, the more prominent form of heart failure is what we call HFpEF, or heart failure of preserved ejection fraction. So the EF would be likely greater than 50%. So this was mentioned by Dr. Shikora earlier. So this would be more of the diastolic dysfunction type. So these patients would come in with maybe shortness of breath, especially when they have elevated blood pressure. And then maybe because of their size, some doctors would attribute this shortness of breath because they're not physically fit or because of their obesity. But this is actually already a sign of diastolic dysfunction. And also mentioned by Dr. Shikora earlier, this could be a precursor to systolic function. This could eventually lead to decreased systolic function later on. So diastolic dysfunction often precedes the heart failure of reduced ejection fraction. We have heart failure because of various changes. So we have your hemodynamic changes. Obese patients have increased cardiac output. They have increased blood volume and decreased systemic vascular resistance. There's also a mechanical effect of that abdominal fat. So it increases the intrathoracic pressure, which increases the pulmonary artery pressure. So your right ventricle would be pumping against a higher pressure. And I mean, long term, it could lead to some sort of right ventricular dysfunction. And then, of course, altered metabolic profile. And obesity also leads to a lot of arrhythmias. So actually, obesity is the most common non-ischemic cause of sudden cardiac death. So for every 5-unit increment increase in your body mass index, you have an increase of risk of sudden cardiac death by 16%. And then also the structural changes in the heart could lead to atrial fibrillation. So I feel like these are things that may be overlooked or not recognized. I'd also like to point out other considerations. So we also have microvascular disease or small vessel disease. So you might have a normal coronary angiogram, but reduced systolic function. And this could be because of your microvascular disease. This could also compound problems if you have obstructive CAD. And then of course, the diagnostic challenges. When we encounter a patient, especially with a really high BMI, it's very difficult to do the standard diagnostic procedures that one would do to evaluate coronary artery disease. So it's hard to make them run on a treadmill. Actually, it's technically difficult to perform the echocardiogram itself because of the massive tissue that the ultrasound waves have to go through. So you might want to consider doing a stress echo with contrast, maybe a dobutamine stress echo, or other alternative options. Also, these patients with obesity have a higher rate of morbidity and mortality after bypass. So more complications after bypass. Also, they have higher rates of post-operative atrial fibrillation and post-ablation atrial fibrillation, likely because of the structural remodeling of the heart, leading to electrophysiologic changes. So these are all of the effects of obesity on cardiovascular disease. So which leads us to the question, what are the effects of bariatric surgery on cardiovascular disease? So after 2 decades of experience, we would have enough data to determine the effects, right? So my main reference for this is the meta-analysis, the most recent meta-analysis published in ESC, Bariatric Surgery and Cardiovascular Disease. There were 4 other SLRs, but this one included the most recent data. So there were 7 studies included, and it showed, the meta-analysis showed that there's a 42% lower incidence of myocardial infarction after bariatric surgery. CAD was analyzed, but not chosen as an outcome. Again, as mentioned earlier, there are diagnostic challenges to diagnose CAD and obesity. Also, CAD can be asymptomatic and difficult to report in large cohorts. So the outcome chosen for this SLR was myocardial infarction. Also, heart failure. Again, there are no RCTs, so this is a mixture of retrospective and prospective cohorts. And the majority of the surgeries done on these patients were their Roux-en-Y. So there was a 50% lower incidence of heart failure after bariatric surgery, and this was statistically significant. And then for stroke, we had a lower incident rate of all types of stroke after bariatric surgery, but then they did a subgroup analysis, and the protective effect is actually more pronounced in ischemic stroke. So there's a reduction of 63% compared to medical treatment. For atrial fibrillation, there was a non-significant reduction in incidence of atrial fibrillation after bariatric surgery. This was likely affected by one study, and it was a study with the shortest follow-up period, so 2.5 years. It also just goes to show that the electrophysiologic changes might be harder to reverse and also take a longer time, or likely irreversible. So for cardiovascular mortality, there was this 41% reduction in cardiovascular mortality after bariatric surgery. And all-cause mortality, bariatric surgery was proven to reduce all-cause mortality by 45% compared with obese subjects in the control group. So just to summarize, the pooled analysis showed significant reduced hazard ratio for all outcomes except for atrial fibrillation. There are some remaining questions though. So the anti-diabetic medications, the newer ones like your GLP-1s, your SGLT2 inhibitors, the effects were not accounted for. Although one could argue that the control group was likely also on these medications, and maybe for a longer time, as they did not experience reversal of their diabetes or weight loss. And then also the protective effects of bariatric surgery due to the remission of diabetes versus the intrinsic effects of the surgery wasn't really determined by this study. And there, again, was no data from RCTs. I'd also like to go over some structural changes in the heart after bariatric surgery. So as you can see here, the images on the left, you can see the parasternal long axis view and a short axis view of the heart. And then at the top, near the probe, there's a really thick epicardial fat layer. And then after the surgery, you can see that the epicardial fat layer was significantly reduced. So there are multiple studies that have been proven to show that there's a reduction in epicardial fat after metabolic bariatric surgery. We also see a decrease in your left ventricular mass index and wall thickness. So those with left ventricular hypertrophy become concentric remodeling or maybe even normal. We also see an increase in your mitral inflow velocity ratio and a decrease in your left atrial size. So these are just echo parameters that we look at to determine your diastolic function. So that just means that after bariatric surgery, they have an improvement of diastolic function and a reduction in your LV filling pressure. And there were no remarkable changes in ejection fraction, but also because the cardiovascular problem in obesity is largely because of the diastolic dysfunction and filling problem, not really a output problem. So final thoughts, metabolic bariatric surgery reduces all-cause mortality, CV-related mortality, and the incidence of CVD in obesity as compared with standard care. And it's a viable option in subjects with CVD and obesity. In fact, in the 2021 ESC guidelines for cardiovascular prevention, it is now a class 2A recommendation for high-risk obese individuals. Thank you.
Thank you, Dr. Ana. Any question from the floor? If not, I just had one question, Ana. You presented a while ago the paper wherein there was really a reduction of cardiac problems after bariatric surgery. And one of the presentations you also mentioned that majority was gastric bypass. Have you encountered any other studies that specifically identifies the type of bariatric surgeries that really improve cardiac, decrease cardiac problems in post-bariatric patients?
For majority of the studies in the SLR, it was really Roux-en-Y. That maybe 100% in some of the papers, all of them were Roux-en-Y. So restrictive and also malabsorptive surgery. Some of them had just the restrictive, but most of them were really the combined type.
Okay, thanks. I think Dr. Go ahead, Dr. Dave.
Thanks for that good talk, Anna. So in this field, a lot of us make a big deal about the weight-independent mechanisms by which metabolic surgery can improve diabetes, and that's the consensual view, although there's one loud outlier. I was aware of the data that you presented, but I've never seen any evidence that the benefits on cardiovascular disease of surgery go beyond, have any mechanisms beyond just the benefits of weight loss. I don't suppose there's an answer to this question, but are you aware of any? Like if you had people who actually lost 30% of their body weight with diet and exercise, would that have the same effect on HFpEF and coronary artery disease, stroke, atrial fibrillation, and so on?
I didn't quite get I couldn't hear the question.
Okay, simple question. Are you aware of any weight-independent mechanisms by which metabolic surgery improves cardiovascular disease beyond just the secondary consequences of losing that much weight?
In my literature search, I wasn't able to come across anything that really separated or identified weight loss as an independent factor to reduce the cardiovascular risk in or coronary artery disease in the patient.
Okay, thank you.
You're welcome.
Thank you, Dr. Ana. So we're now going to our third research speaker. He's a practicing surgeon with particular interest in surgical metabolism and nutrition. He is the head of the Weight Intervention and Nutrition Services of St. Luke's Medical Center, Quezon City, and an associate professor in surgery on the same institution, a member of the editorial board of the Journal of Surgical Metabolism and Nutrition. So currently, he is the president of the Philippine Society for Parenteral and Enteral Nutrition, or PhilSPEN. Let's all welcome Dr. Jesus Fernando Insiong.
Hi, good morning, everyone. Thank you very much for this opportunity to be able to talk to you. You see a lot of familiar faces. So, my background in surgery perhaps has changed the way I take a look at things. And just to give you a brief history, I got into nutrition really because of bariatric surgery. So more than 2 decades ago, when we were pursuing careers in surgery, I first got into surgery because of my interest in weight loss surgery. But now I guess practice has changed. So let me speak to you about the value of nutrition support when we encounter problems when it regards to our surgical interventions in our patients. The incidence of obesity is really a problem all over the world. And if we try to take a look at recent data that IFSO has published, the number of surgeries being done is really increasing. And perhaps, it's increasing at least maybe 5–10% a year. And even when we try to take a look at the US data, where perhaps they've published a lot of data with regards to bariatric surgery, they do almost 250,000 cases in a year. Gosh, compared to the Philippines, we're Cub Scouts. But that being said, because it's being done, we also know that it is addressing a lot of the problems of our obese patients and, of course, diabetic patients all over the world. And if you try to take a look at the complications of bariatric surgery, take a look at that. That's really very impressive. 0.08 mortality rate from bariatric surgery. So it's a very safe procedure, a very good option we can offer to the candidates of or obese candidates and even diabetic candidates, patients that we see every day. So here's the breakdown that was recently published. I was really amazed that we're seeing very, very few patients who actually succumb to the disease or succumb to the complications of bariatric surgery. And if we try to take a look at overall complications, it's really still very low. But anastomotic leak is at the top of the list, right? And you see again, early complications, perhaps combined surgeries are still very low. Highest, again, anastomotic leak and perhaps pulmonary embolism there. And even the mortality rates is still below 1. So we have a procedure that we can offer to specific patients needing a different type of intervention. However, when the complication sets in, that's when we really call and do our interventions to our patients. So imagine a complication rate of 1. So when Edward or perhaps Jeff over there do 100 cases, they will only call me once to help in and manage the case. So in terms of income, there's a huge difference between the two. So in fact, the complications is associated really with the number of anastomosis that we did or that they did in these patients. And that's where things really differ. When we encounter anastomotic leak, take a look at that. At the end of the slide, that's when specialized nutrition support actually comes in. And that's where it becomes very important for us to be able to manage these patients, although not very common, but this will cause death of your patients if you're not able to identify this and manage your patients. So because of the surgical complications associated with metabolic surgery or bariatric surgery, that's when we see the problems or the headaches in the hospital setting. It's good that, it's not very common. It's good that a lot of our patients will actually survive or the leak will actually heal. However, we should know how to do our interventions in terms of nutrition to these patients. You will see early enteral nutrition. That means feeding your patients through the gastrointestinal tract, because this will change clinical outcomes of your patients. In reality, when you do bariatric surgery, when you encounter the complications, you do not usually have the access to feed through the gastrointestinal tract, right? In enhanced recovery after surgery, you remove the tubes. There's no feeding tube anymore in your patients. And so when you encounter the complications, you're left with nothing else but parenteral nutrition.
But we want to be able to feed our patients through the gastrointestinal tract. And this is just the list of the benefits of feeding through the GIT. You're able to preserve a major immunological organ in the body. It is responsible for more than 50% of your bodily defenses or your immune system. It produces more than 75% of your serum IgAs. Therefore, when you have a patient with anastomotic leak, the goal should be feed them through the gastrointestinal tract so that the complication will heal. And if you try to take a look at this study, for those patients that had an anastomotic leak, they gave either TPN or jejunostomy feeding. If you're able to have access to the gastrointestinal tract, the leak or the fistulous tract actually healed faster. None of their patients died. Everybody survived. And healing was in a matter of around 6 to 8 weeks. However, if you use TPN, then you increase the healing time of these patients. Therefore, when you encounter a complication, I'm sure you would want to go in right away and correct the complication. While you're in there and doing your revision, please consider inserting a feeding tube through a jejunostomy already in your patients. So there's a lot of treatment strategies when it comes to the treatment of fistula or perhaps an anastomotic leak in your patients. Number one would always be source control. Okay? And that's why we, as surgeons, would do our surgical intervention as soon as possible before we encounter sepsis in our patients, right? So you want to drain the fluid collection, or perhaps pus in the intra-abdominal cavity. And what's highlighted in this slide is actually optimization of nutritional status. Remember, before you did the weight loss surgery, a lot of your patients, you wanted them to lose weight, right? To be able to decrease the size, perhaps, of that liver so that you had better access to the upper GI. However, when you have a complication already, the game changes. You want to be able to maintain what we call lean body mass. And that's the nutritional targets over there, which may not be exactly the same as what you advise your patients in the post-operative period as they start to recover from the bariatric surgery. That's because when your patients already develop a leak and there's an intra-abdominal infection, you enhance the surgical stress response. So there's a lot of inflammation already happening. It's good if you recognize the leak earlier on when there's tachycardia already, there's difficulty of breathing in your patient. Within 2 or 3 days, you're able to recognize this and do your corrective surgery. However, for people like me, we usually get these patients late. And so there's a lot of inflammation already. There's changes in how we're utilizing bodily fuels. And that's causing the problems that we see in our patients. This is the simplest model, let's say, of body composition. One side is fat mass, mostly responsible for energy. The other side is lean body mass, mostly protein, our skeletal muscle, our organs, which is responsible for survival. And that is what we're trying to preserve. A 10% loss of your lean body mass, that's where you encounter complications already. You increase infectious complications in your patients. At 20% loss of lean body mass, that's when you already see a decreased wound healing. And that's when you see further complications with regards to your wound and even complications in the lungs. And eventually your patients might succumb to the infectious complications that you encountered because of that abscess in the intra-abdominal cavity. And that's why there's a lot of talk recently with regards to what's really the role of sarcopenic obesity in our patients who are encountering complications from bariatric surgery. This is just one study. These are critically ill patients who had intra-abdominal sepsis after a major surgery and the relation of sarcopenic obesity. So those patients with sarcopenic obesity, that's where they saw a lot more complications as compared to those patients who had a preserved lean body mass. So what is this impact when it comes to our weight loss surgery that we're doing when we offer them bariatric surgery? Perhaps in the future, we'll be seeing more evidences. Because currently what we see now, even if you had sarcopenic obesity, short-term complications when it comes to bariatric surgery is really not being changed. However, is there an impact in the long run after 15, 20 years, or when your patients become critically ill? Does sarcopenic obesity change their outcomes? If you try to take a look at this slide again, when we do metabolic surgery in our patients, there's a consistent decline in weight. There's also a consistent decline in fat mass. However, along with that, you also lose your fat-free mass or your lean body mass. So does this affect our patients in the long run? I don't know yet. Perhaps I cannot say as of this time, but maybe there's some importance in the future when it comes to the value of measuring body composition. It was mentioned earlier, BMI is really unreliable, right? If you take a look at BMI of your patients and take a look at, let's say, abdominal CT scan at the level of L3, your skeletal muscle mass or the skeletal muscle index is not the same, even in patients with the same BMI. And from the clinical nutrition point of view or medical nutrition point of view, when you have sarcopenia in your cancer patients, in your major surgical patients, it is always associated with poorer surgical outcomes. I don't know when it comes to metabolic or bariatric surgery. So does this have an impact in the future? Perhaps that's something that we should be looking at. Thank you very much.
Thank you, Dr. Inchong. Any questions from the floor before we end the session? Okay, so if none, we would like to call our speakers because we'll be going to give the certificate, after which there will be a group picture for the speakers. And I'd like to call if Dr. CC Wang is around to present the certificate to the speakers. So may call on Dr. David Cummings. You have your certificate from the IFSO APC. Is pleased to confer on Dr. David Cummings this certificate of appreciation as faculty during the 7th IFSO APC meeting and for his great contribution to the success of the event. Given this 3rd and 4th of November, Manila, Philippines, signed by Dr. Edward Oliveros, Congress President, and Dr. CC Wang, IFSO APC President. Congratulations, Dr. Cummings. Next, we would like to call Dr. Scott Shikora, also the same certificate of appreciation as faculty during the 7th IFSO APC meeting for the great contribution of this event. So again, thank you very much, Dr. Shikora. May I call on also certificate to Dr. Nemencio Nicodemus Jr. For his certificate of appreciation. But I believe he's already on the other session, so we will move on. May I call on Dr. Ana Adora, certificate of appreciation as faculty during this 7th IFSO APC meeting. And last but not the least, may I call on Dr. Jesus Fernando Enchong. This certificate of appreciation as faculty as well during the 7th IFSO APC meeting. Thank you very much to our speaker. There you go. Okay. So we'll move on to the next session. So we'll be calling our chairs. May call on the chair, Dr. Ahmad Ali, and his co-chairs, Dr. Ray Melchor Santos and Dr. Miguel Mendoza, to take over. And Thank you very much for your attention. Yeah. So while waiting, announcement, the 9:30 session for at the Nara room is about to start. And at 9:30 also, there will be a ribbon cutting at the exhibitors booth.
Because we are behind the time, so we are going to this section about the sleep plus procedures. Sorry about that, Dr. Ali. Today he cannot make up because of visa issues. So I was assigned to chair this section with my co-chair, Ray Santos and Miguel Mendoza. Okay, and today we have five speakers, including myself, and but because the Chinese doctors cannot make it, they have to quarantine after going back, so they would talk online. And we have another two surgeons, including Kasama and Mufaza Lakawala is here. So later we would have some discussion with very renowned panelists and to discuss on the stage. Okay, so.
Yes, thank you, CK. I'm Dr. Miguel Mendoza. I'll be co-chairing this session together with Dr. Ray Melchor Santos. So to start this session, allow me to introduce to you our first speaker, and who'll be giving the opening remarks and who'll be talking about the sleep plus mechanism and its future. He is known to everybody. He's from China Medical University Hospital in Taiwan. He is the superintendent of the BMI Center of China Medical University Hospital, Taiwan, and also the founding chairman of International Excellence Federation for Bariatric and Metabolic Surgery. He has devoted his life to minimally invasive surgery and bariatric surgery for the last 20 years and invented innovative bariatric and metabolic surgery such as banded plication, loop DJBs with sleeve gastrectomies. His center was also designated as the first international center of excellence for bariatric surgery in the Asia Pacific area in 2009. Ladies and gentlemen, it is with great pleasure and honor to introduce our first speaker, Professor Chi Kun Wang.
Okay, good morning. Because I have only 10 minutes, so I have to go very quick through that. I'm going to discuss with you about the mechanism and the futures. We proposed the name of Sleep Plus about 3 years ago. So that time we published in the papers about talking this new concept of Sleep Plus. And we also think that it needs some time to make this procedure to become more popular. I want to mention about why we need to talk about these new terms. I think we nowadays, the bypass and sleep has been the most common procedure in the world. And of course, gastric bypass is coming down, and sleep gastrectomy take the main stakeholder for the bariatric procedures. But in fact, in myself, I also do a lot of gastric bypass. There's a lot of problems for these procedures because of the dumping syndromes, and especially in East Asia, there's some marginal ulcers patients cause some perforation, bleeding issues, and strictures, internal hernia, iron deficiency anemia, and also some vitamin deficiency. The long-term issues for these procedures make us more troublesome in management of the patients. The second is the risk of remnant gastric cancer, because in East Asia, especially Japan and Korea, most of the surgeon is so afraid, and even the patient and society don't endorse these procedures. About sleep has been taken very majority of bariatric surgery for these 10 years, but in fact, the long-term result for the weight regain and some inferior diabetic remission is also was be observed now. So some patients come back for revisional surgery much more than the gastric bypass procedures. So according to this concept, so if we can add some small bowel bypass to the sleeve gastrectomy to get more beneficial results for the long-term weight loss, maintenance, and also the comorbidity like metabolic syndrome and diabetes remission, I think that would be better options compared with sleeve alone or direct going to the gastric bypass. In fact, the duodenal switch has been part of that, but we did not accept this procedure in Asia because of long-term complication of nutrition. The SEDIS has been endorsed by IFSO and ASMBS. And the other new procedures, in fact, it's novel, but it's coming to the bariatric surgeon's hand and in some different country and area. So this is a very interesting papers published from China. They're doing the sleep and sleep plus and versus gastric bypass to compare the weight loss and also the GI hormone change. And very interesting is that if you adding the small bowel bypass in the sleep gastrectomy to compare with gastric bypass, it has lower renin levels. Compared with sleep alone, it has higher GLP-1 levels. So it means that compared with sleep and gastric bypass, sleep plus has strongest hormone modulation in GI hormones. So I would say the present and the futures for the sleep plus. I think this is a new terms used to include all the procedures that add a small bowel bypass to the conventional sleep gastrectomy. Some of these additional procedures was done as revisional surgery right now, like a sleep where again they can aiding the SEDIS to become for revisional procedures. Right now, we also doing some jejunal bypass for those with sleep weight regain or those who cannot get through diabetes remission. Most of these procedures are still novel and are still in trial phases. So that the most available data has shown that it's at least not inferior to the gastric bypass. I think the procedure safety and superiority definitely would need long-term comparative studies. And this is the later we have to discuss. We separate to three categories. One is sleep with duodenum, jejunum, or duodenum ileal bypass procedures. Another one is about sleep with jejunal bypass procedures. The last will be the sleep with gastro-jejunal or gastroileal anastomosis. So right now you can see there's a few procedures in the world that has been performed by some surgeons. So in the next few speakers, I think that would be make us to look into these results and also how they do it. So in the last, I would say, always remember that your present situation is not your final destination. The best is yet to come. So let's welcome the speakers and panelists to give us their wonderful speech and points of view about Sleep Plus. Thank you very much.
Thank you very much, King. Well, after that overview on sleep gastrectomy and sleep plus procedures, we'd like to call on our next speaker, who's going to talk on sleep plus GJ bypass related procedures. Dr. Xiao Cheng Su. He's a director of Bariatric and Metabolic Surgical Center, affiliated hospital of Suzhou Medical University in China, Vice President, Specialized Committee of Diabetes and Obesity Surgery, China Association of Research Hospitals, Fellow of the American College of Surgery, a member of IFSO, ASMBS, and SAGES, and the head of the Obesity and Diabetes Surgery Group of the surgical branch of Jiangsu Medical Association. I'd like let us welcome Dr. Xiao Cheng Su.
Dear friend expert, it's a great honor to join 7th IFSO APC meeting 2012, and really regret not able to attend the meeting in person because of COVID virus. My report today is short-term outcomes of sleeve gastrectomy with transit by partition. I'm Xiao Cheng Su from China. We know that transit by partition is invented by Dr. Santero in 2006. He invented this procedure originally from DS change the anastomosis side from duodenum ileal anastomosis to ileal anastomosis. And now update is common channel to 2,230 centimeter. Dr. Sandero published his paper about 1,020 cases with great weight loss and diabetes remission. The weight loss at 5 years up to 74% actual BMI, and diabetes remission up to 87%. It's great. It compared to sleeve gastrectomy and RYGB. TB is much better. For this is 74 and SG 61, RYGB 68. Dr. two-part research, 4 years research compared TB to DS and RYGB. We can see that TB and DS with similar weight loss and better than RYGB. Midterm weight loss result for TB from several others with good weight loss, more than 70% actual BMI weight loss. Also have great diabetes remission, more than 80%. In addition, TB has some function to relieve GERD. Up to 70% of GERD get relieved. So why we selected TB as our research or daily procedure? Because it might solve sleeve gastrectomy's GERD problem, because it relieves gastric pressure. It also has better weight loss compared to sleeves. And more, it has less malnutrition compared to CDs and OAGB. So we have 3 types of transit bipartition. The first one is invented by Dr. Sandero. We still use it. We call it RYTB. And simplified by Dr. Modi, we call it a single anastomosis TB. It's much easier, save time, but with 5% by vomiting. So we modify the procedure with plus a bron in order to decrease by vomiting. This is our procedure. In most cases, use 5 troocars, but female, we use 4 troocars. We use 220 common channel and 40 centimeter for Ruxlin. This is a short procedure. We use 6 millimeter from pyloric to step line. Very standard sleeve gastrectomy use 36 branch body. And we do step line reinforcement. We cut ileum from ileal cecal about 260 centimeter and do gastroileal anastomosis by hand seal. We use 3 centimeter gastroileal anastomosis, and this away from pyloric for 3 centimeter. The reason we use hand seal because it not waste time, but decrease inflammation and decrease stenosis in the future. The second anastomosis is below the first anastomosis, 40 centimeter, and do jejunal ileal anastomosis. We close mesenteric defect, avoid internal hernia, also close Peterson space. So our standard for TB is BMI more than 27.5, and for type 2 diabetes, all patients with GERD A and B, we don't select for C or D. We did 315 cases so far. The mean BMI about 38, most of them are female, and diabetes about 50%. No true car hernia, we have like 2 bleeding, one's GI bleeding, 1 abdominal bleeding, and 5 partial for obstruction. Of them resolved by conservation. The reason of partial for obstruction might relate to wrong eating and not following the guideline. We finish like about 500 cases each year, and about 1/3 is TB. Weight loss is very good for 12 months follow-up, up to 100% EBMI reduction. And the diabetes remission reached about 96%. We did 3 animal models to testify TB. All 3 papers published in obesity surgery. The first experiment compared TB to SG and RYTB. So TB is better than SG in terms of weight loss and diabetes remission, and then not inferior to RYTB. The second experiment compare CD and CC. This is CD and this is CC in terms of malnutrition and GLP-1. In terms of GLP-1, CDs and CC is similar, although CDs is a little better. For the malnutrition, CC is better than CDs. So CDs with a significant malnutrition. And third experiment tried to see SGTB with the function to relieve the GERD. So we use 2 procedures. One is the standard TB, another is modified TB. We can see that levogastroctectomy with very severe esophagitis, thickness of the mucosa is high compared to TB and modified TB and the control group. So TB has some function to relieve GERD. So this is 1 year after TB. We can see anastomosis looks good without inflammation. In our all case numbers without a marginal ulcer. This is UpGI series, 1 year after surgery. We can see 2 channels. The first channel is the gastroileal channel. Then is the gastroduodenum, this channel. And this is 2 channels, both channels working. We host 3 times of China International Forum on sleep gastrectomy plus transit by partition. Famous surgeons in this area, Dr. Santero, Moji, Dr. Part, are invited. In this year's meeting, more than 20,000 national and international audience visited the meeting. 3 RCT research in TB in progress. Our RCT enrolled 186 patients so far. We hopefully to finish this enrolled by end of this year. Summary: SCTB seems to be effective and safe procedure. The benefit including removement stomach and biliary tract accessibility, also reduce reflex and relatively easy for reversion. The incidence of malnutrition is relatively low and mild. Of course, we need more RCT research to evaluate this procedure. Thank you for your attention.
Thank you very much, Dr. Zhu. May we call on our 3 panelists for this particular session, Dr. Asim Shabir, Dr. Sutep Udom Sawensuk, and Dr. Wei J. Lei to please join us here upstairs. Thank you very much. May I first call on Dr. Asim Shabir to give a reaction or question on the topic.
So I thank you very much, and a warm welcome to everybody to IFSO APC. It's nice to see so many familiar faces out here. So it's glad to be there in person. Thank you very much. Sleeve plus procedures, I think, are here to stay. It's just that how we will pace them up and how we will basically gather the evidence to put this. In Asia, certainly a lot of concerns about gastric cancer and about outcomes for diabetes improvement. So this is one of the procedures that look out for, and there are many other iterations. But however, I would urge those who do practice this to put in evidence if they want to globalize these procedures, at least for the Asian cohort.
Thank you. Dr. Sutep.
Thank you very much. Yes, I'm excited to see the evidence from the group of surgeons who are doing this transit by partition. It is a good idea to, sharing between the malabsorption and also keep some of the partition for the normal absorption. But the thing is that it's very difficult to find the point where we should land the patient or land the bowel at that point. Then I think the information should be very much producing the more confidence to follow that. The good thing is that they reduce or release the pressure of the stomach, so that would help for the reflux. Yes, of course. But the second is that the question would be going to what is the link of the bowel, and it's also vary from every genetic or any individual. Thank you.
Dr. Wei,
and
your
first,
reaction?
I would like to congratulate Professor Zhu for his nice talk and very beautiful data. And for sleep plus, I think because we know sleep is not adequate for metabolic disease, so we try to add something, and we can add on stomach, add on duodenum, or add on small intestine. But for me, I think most convincing probably is add on stomach, because you can preserve the duodenal path, and you also have the incretin effect. However, as we know, there's really no data to support this kind of new procedure. And today I heard the data from Professor Zhu, and especially the randomized trial. I think this is the first randomized trial to prove the partition with sleep. And he is getting to full collect his patients. So we're looking forward to your future. I think this study will add the level 1 evidence to this procedure. So this is my comment. Thank you.
Thank you. Do you have any question from the floor for Professor Zhu?
Can I ask the questions?
For our panelists, you have any questions for our panelists?
I
Yes.
just have a question for Professor Zhu himself.
I'm here.
Do you have any study to show that the absorption of vitamins in a bipartition are better because your limb length, the common channel, is about 250 centimeters, but because the food also goes into the duodenum and the proximal jejunum, I would assume that you have a lesser malnutrition complication even in short and long term. And my second question to you is that you claim that because there is an anastomosis to the antrum, there is a decrease in intragastric pressure that translates into a lower intragastric pressure around the tube, which will result in lower reflux. Do you have any evidence around that?
Okay. Thanks, Dr. Sam. So it's two great questions. For the first question about malnutrition, we started our procedures like actually 2 years ago. We have finished 315 cases, about 90 cases finished 1 year follow-up. So far, we don't have like a severe complication in terms of the malnutrition. Some patients we have mild anemia, short term of like a low protein. In terms of vitamin, not every patient follows the rule to eat enough vitamin. About 2 patients, they have like some like abnormal about like neural sign, but we encourage them to eat vitamin according to guidelines, so they resolve like a month later. So we don't have a big problem in this area. In terms of like reflux disease, actually from our animal experiment, we can see like a mucosa height is much less inflammation compared to like simple sleeve gastrectomy. And in our clinical, we have like enough data from our colleague and from my patient. We observe like 10 patients before sleeve gastrectomy. They have like reflex sign by endoscopic, and after surgery, we check the stomach again, and the sign of like reflex disappear. 8 of 10 of them, but still 2 of them, one is like is stable, one is mild like worsen. So from like data from our group and also from other groups, and at least another 3 groups, they relieve about 80% of the reflex. Of course, if like reflex is grade C or D, we don't recommend use like TB. And 2 of the colleagues, because they do revision surgery for sleeve gastrectomy because of reflex, 2 of them, they do revision. Actually, is conversion to TB from sleeve to TB. So the reflex resolved like 3 days after surgery. So it's very, very significant change very quickly. Thank you.
So thank you very much. Since we have some time constraints, we'd like to thank our panelists and of course, Dr. Zhu for that wonderful lecture. Thank you.
Thank you.
Yeah, I think this is very good discussion, and we have to proceed. So next speaker will be talking about sleep with DJB. I think Kazunori Kasama, those who don't know him, you should not show up here. You will not be bariatric surgeon, I think. And Kazu, in fact, He is the past president of APM BSS and also the past president of IFSO APC. And he's the director of Weight Loss and Metabolic Surgery Center, Yochuya Medical Cube in Tokyo, Japan. He will talk about the DJB. This procedure was invented by him, so it has been more than 10 years. Welcome, please.
Thank you, CK. And it's really my honor and pleasure to meet all of you again here in Manila. So this is starting from my slide, please. Not the first slide.
His PPT, you are ready?
So I'd like to talk about the sleep DJB. As CK said that the sleep DJB was used to start in year 2009 as a combination of sleep gastrectomy and gastric bypass to avoid the criticism of bypass the stomach for gastric cancer. Because our area and also China in Korea has a huge number of gastric cancer, so that I was worried about the gastric cancer in the remnant stomach, I mean the bypass stomach, because we cannot check the bypass stomach after gastric bypass. So because of the huge criticism of the Luema gastric bypass in Japan, when I started laparoscopic Luema gastric bypass in 2002, and then I started strip gastrectomy alone 2005. But I think, I thought that strip gastrectomy alone is not as good as gastric bypass in terms of the remission and the improvement of diabetes. So that I started to have the combination of a strip and gastric bypass to mimic BPDDS. Is it okay?
Kazu, you can speak more.
Oh yeah,
Problem.
yeah. So as maybe many of you know that the Japanese society is a very conservative, so that and also the many gastric cancer surgeons are there. So if the gastric cancer happened in the bypass stomach, it may cause a huge against the criticize from them and all over the society. So that now in Japan, we don't do a Luema gastric bypass to avoid such kind of criticism. So that the sleep DJB is now accepted in Japan. And so we are still struggling in PC. Okay. This is my first slide, right? Let me see my first slide. Oh yes, this one. Sorry for the delay. So this is my COI. This is my case mix disclosure. Still, the sleep gastrectomy is the majority of my procedures. So in this session, we have sleep plus gastric jejunal bypass and the sleep DJB and the sleep plus jejunal ileal bypass. But sleep plus DJB is probably easy to understand because we already have BPDDS and SADI. So what is the difference between these procedures? So anastomotic site, so SADI and the BPDDS are duodenal ileum anastomosis, but DJB is a duodenum jejunum anastomosis. And the size of sleeve gastrectomy is DJB is a normal sleeve. We just use 32 to 36 French Brésil, but BPDDS has a bigger sleeve. So this is a schema of the difference between four procedures. We have strip DJB and the Roux-en-Y fashion and loop DJB. So as you know that one of the most effective among IFSO recommended and recently ASMBS recommended procedure is the BPDDS and the SADI, but they have a short common channels. But sometimes King brings something evil. That's a protein malnutrition. As a matter of fact, I did my first BPDDS with Michel Garnier when he came to Japan. But that patient, she still suffer from not very severe, but malnutrition and anemia in 15 years later. And because the protein intake per day is quite different among countries, especially in Asia, we have less protein intake. And Japan is just 2/3 of the United States, and the other country in Asia or less than half of the United States. So that the too much hypoabsorptive procedure are not recommended in Asia. So through the IFSO APC chapter and the APMBSS and also ELSA activity, I always say that the metabolic surgery by Asian surgeons for Asian patients with Asian evidence. So that is the reason why I started sleep DGP. As I told before the slide starting, so this is my original DJB at the 2007. But recently, I have, this is my original, DJB. So long common channel and the slimmer gastric tube, avoid bypass stomach, a so-called Asian BPDDS. And my recently sleep DJB is count the total length of small intestine and then BP limb in the 1/3 of total length of small intestine, approximately 2 meters, and A limb is a half of BP limb, and the common channel is more than half of the total length of small intestine. Now we'll report the outcome in not next, this is the APC with from my colleague Dr. Ueno. And we also have the loop DJB fashion. Loop DJB is the same concept, but loop reconstruction done by Shike Huan and Wei Jie Li is something like an Asian SADI. So what is the effect of adding DJB? So we have some comparison between two procedures, and the sleeve DJB and the gastric bypass and the sleeve gastrectomy alone is almost same excess weight loss if the BMI less than 50. But if the BMI more than 50, the sleeve tend to have regain more weight than the bypass procedures. And this is a very nice study from Dr. Naito, and this is a multi-center study in Japan. And regarding the diabetes remission in overall patients, the sleeve gastrectomy and the sleeve DJB is quite same, not different. But when we use the ABCD score, which is invented by Professor Wei Jie Li, the lower the score, the more severe diabetes. So if ABCD score is more than 6, the remission rate is quite high in both groups, 95%. But if ABCD score is less than 5, which means the severe diabetes, so sleeve DJB provides a better remission rate than sleeve gastrectomy alone. And moreover, when the patient uses insulin, the remission rate is almost double in the sleeve DJB procedures than sleeve gastrectomy. So this is the data from our colleague Dr. Ueno. He will have a presentation in the oral session, this IFSO-APC, and the effect of elongation of the BP limb in sleeve gastrectomy with DJB on glycemic control. This is a propensity score matching analysis, and we just show some summary of his study. And the length of BP limb is the standard BP limb and 100, and long BP limb is 240. Operation time is not that different. And the post-operative outcome, the total weight loss is also same, but the difference were the number of patients using non-insulin medication, and also number of non-insulin medication also smaller in BP limb, long BP limb group. So, and also the number of the patients using any diabetes medication is much lower in long BP limb group. So this is a conclusion of his study. The complication is not different. Total weight loss is not different. The remission rate is not statistically different, but the total medication use decreased in a long BP limb group. So that the long BP limb provides a little bit better the outcome in terms of diabetes improvement. So I'll show some techniques. Okay, so some of the surgeons worry about the duodenal dissection, but it's not that very difficult. We sacrifice all the vessel of the greater curvature, and so that the surgical field is very good, and put some hole on the top of the duodenum, and put a stapler. At this time, the curved tip stapler is very useful, and cut the duodenum from the 1 centimeter from the pyrocline. And we'll find the trite ligament. And this is almost same with the usual the lumen gastric bypass, so that I will skip this one. And we count the total length of small intestine. As you can see here, this is the white marker at 10 centimeters from tip of grasper. And make a hole using a white camera stapler. And also the counter length of alimentary tract. We skip this one. It's a same with lumen gastric bypass. And also make a jejunostomy, like a lumen gastric bypass. And the mesenteric defect closure, of course. And this is a duodenojejunectomy. I prefer to use a hands-on double layer anastomosis. And I'd like to use two color of stitches. One is white and one is blue to identify which stitches are there. And posterior cell muscular suture, and then make a hole. Usually I make a hole, this is 2.5 to 3 centimeter. It's quite different from lumen gastric bypass, because the lumen gastric bypass, we have to make a smaller anastomosis. But we preserve a pyloric ring so that we can make a bigger anastomosis. So that our stenosis ratio of this anastomosis is 0%. But lumen gastric bypass, I have almost 8 to 10% of stenosis after lumen Y, so that this wider anastomosis is useful to prevent such kind of complications. And this is landing suture. We using 4 stitches. Skill is a little bit demanding, but I think it's a less leakage and less dissection of duodenum. And finally, we do a leak test, and also the gastropexy and the Peterson space closures, and put no drains. And we have 5 years result, and starting from BMI 38.5 and 5 years to 28.4, very durable. And excess weight and total weight loss is around 30% in 5 years. And the remission rate at 5 years is 72.7%. Even in, this kind of patient have very severe diabetes. And this is a medication used for type 2 diabetes. But we have relapse rate from 1 year, it's 10% at 5 years. And this is all Japan data from Dr. Author. And in comparison with the Roux gastric bypass, mobility is less. And so that this is the conclusion. Sleep DJB is reliable in long term and mimicking BPDDS and the study in Asian way. And more effective than sleep gastrectomy and less complications than Roux gastric bypass. But a little bit technical demanding, but able to overcome with practice. Thank you very much.
Thank you, Kazu. Would you please sit down as a panelist? We have another two, Tan Chun Hai and also Professor Antonio Torres. Would you come up on the stage? Okay, before we ask question to Kazu, I have the wish that Antonio, you can give the first comments about the sleep DJB comparing with your SADIS procedures.
Okay, well, thank you. Good morning, everyone. For me, it's a pleasure to be here sharing, this important topic. First of all, I'd like to congratulate Dr. Kasama for your extraordinary work regarding what I would say is a more physiological procedure comparing to the other procedure connecting directly the bowel to the stomach. Probably going to work. We have data that are working, but we have to admit at least it's less physiological than your approach. Passing through the food for the natural anatomical conduit through the stomach, to the parores, to the duodenum, and to the bowel. I'm not discussing SASIS, SAHIS, and other approaches, even by partition, but we have to admit at least that conceptually, from the conceptual point of view, is more physiological. Another issue, another comment, your results are outstanding. As ours, as Dr. Wang said, the Asian studies are going to be, it's a proximal duodenojejunal bypass, in terms of, sharing the information with the younger people, is yes, to increase the length of the biliopancreatic limb and to adapt the length of the common channel to the BMI and the nutritional needs of the patients. That's in summary of what you did. And you start 2009. I remember when we started 2007, we were coming from a standard Scopinaro procedure, open approach in our country, earlier 90s. So I think I don't have anything more than congratulate you, Dr. Kasama, very nice work. I think your population, metabolic patient, this is an extraordinary idea. And I think I can just only to pointing out the importance of your work there. Congratulations.
Okay, very nice words to Kasama, I think. And Dr. Tan, I think that is you are more new generation surgeons. How you look at these procedures compared with conventional procedures?
I think Professor Kasama has done a great job in Japan by introducing this sleeve DJB, because I think it is unique in Japan, Korea, China, India, that the incidence of gastric cancer is so much higher than the rest of the world. I think that's the reason why you said that we're doing this, especially for diabetic patients in Japan. I also want to ask whether is there any cases in which you have done a room-wide gastric bypass and detected a gastric cancer. I know in Taiwan, Professor Lee had one detection of a gastric cancer case many years after a gastric bypass. And if there's any cases, whether you can show that by doing this sleeve DJB and still able to continue to surveillance the remnant stomach, that you can catch this gastric cancer early compared to missing out and catching it on a later stage. That's my first question. My second question is that I'd like to congratulate you on very technical, demanding surgery, and you make it look so easy, and there's a bloodless surgery. And how did you overcome and maybe teach to the younger generation how you overcome the learning curve and how you practice to so that you can do this with ease?
Thank you. So regarding a gastric cancer, I don't have any gastric cancer in the lower gastric bypass still. But my case of lower gastric bypass is just less than 300. So that, yeah. And I have one case of our gastric cancer after sleep DJB. And we have a very small our gastric cancer 1 year after sleep DJB. And she was insulin user, and if I did sleep gastrectomy alone, she could not have any remission of diabetes. And if I did lumen gastric bypass on her, I couldn't find our gastric cancer. And of course, that's in Japan, we could treat her in ESD, the endoscopic submucosal dissection. So that I think this is one of the case which provides the superiority of C+ procedures.
May I have a comment and a question to you, Kasama, is regarding your approach in measuring all the bowel in all the patients. In your not so heavy patient, BMI medium 38, probably you're not going to be, I would say, in inverted comma, dangerous. But in our patient, BMI over 50, sometimes to measure in every patient all the bowel, sometimes it's dangerous because we can damage the bowel. So my question to you said that is, do you consider it going to be mandatory or compulsory to measure all the patient after your experience? You will say, okay, if the patient has around 39, maybe 200 going to be enough, or you are still advising all the surgeons, young guys, to measure all the bowel in all the patients?
Yeah, that's a very nice question. Yeah, you tell the truth. Actually, if the patient have a very severe, heavy patient like a BMI of 50, 60, the counting or the small intestine is sometimes dangerous. So that for that kind of patient, I do a loop DJB and then make a BP limb just around 250, like I learned from the CK and the WJ about that procedures.
I think it would be advisable to do that, not to advise, to count in every patient all the bowel.
Right.
It takes not only time, but it's going to be very nice for the not very skillful surgeons, to measure all the bowel in all the patient. But anyway.
Yeah. So in the beginning, it's very useful to count all the total length of the small intestine, but I think there is some average according to the ethnicity. Like in Japan, the average of the total length is just 650. So that 2 meters is enough for BP limb.
I have another question for you, Professor.
Yes.
So
Tonight, the time is too much. I think Kazu can open another class in the lunch. Okay.
Yeah.
So let's give. You want to ask question?
If I have time.
1 minute. 1 minute. We are too behind. Sorry.
Kazu, quick question for you, and I should know the answer, but I don't. Have you or anyone else completed an RCT of sleeve DJB versus just ordinary sleeve to see how much, if any, added benefit comes from the duodenal bypass?
So no RCT between sleep alone and sleep DJB. No, but
It would be interesting.
probably the RCT between lumen gastric bypass and the sleep DJB. Pravin Raji published.
Okay. Yeah, I was interested in the physiology of how much is added by the duodenal bypass. Okay. Thank you.
Thank you. Give big hands to our panelists and speakers. Thank you so much.
Thank you very much, and congratulations. Excellent discussion. So for our next speaker, He is a professor and chief surgeon, director of the metabolic and bariatric surgery of the first affiliated hospital with Nanjing Medical University. He's the vice president of the China Society for Metabolic and Bariatric Surgery. He's the director of the IBC China chapter and president of the IEF China chapter. He will talk about, through a video presentation, sleeve plus jejunal ileal bypass related procedures. Ladies and gentlemen, from China, Professor William, video presentation.
Good morning, ladies and gentlemen. It's my great honor to give my topic in the IFSO APC meeting. I'm Hui Liang from Nanjing Medical University. The application of the bariatric surgery to treat obesity and metabolic disorder has been lasted over half a century, despite lots of the bariatric procedure have proposed. Majority of them were abandoned because of the severe complication or lack of the effectiveness. We can find the IFSO and the SNBS data. Sleeve-gastrectomy and the Roux bypass remains the major two procedure performed by surgeons. However, exploration of novel bariatric surgery is still ongoing, and some of them have been endorsed by IFSO and the SNBS. For example, SEDIS, OAGB, and intragastric balloon, and so on. Despite so many bariatric surgery available, there is no standard criteria to select the correct bariatric surgery for patients. Is there a perfect bariatric procedure available yet? The ideal bariatric procedure should meet the following requirement, including acceptable surgical difficulty, least postoperative complications, favorable weight loss, and hypoglycemic effect, least malnutrition, reversible, and so on. To overcome the pros and the cons of sleeve-gastrectomy and the Roux bypass, because no perfect procedure. So concept of sleeve plus procedure were proposed, including SEDIS and SIPS, sleeve-gastrectomy plus duodenal-jejunal bypass, or sleeve plus jejunal bypass. Though meta-analysis concluded that this procedure achieved better weight loss and cause fewer complications than RGB. Their application remains few because of surgical complex or lack of solid evidence. So why we choose the sleeve plus jejunal procedure? Because this procedure includes male absorptive and restrictive procedure, lack of dumping syndrome because it preserves the pylorus, normal absorption of duodenum, diagnostic therapeutic access to the ampulla of water and gastric remnant. So I think this may be very important for Asian patients. And this procedure technically easy and reversible. The first report comes from the Alamon team in 2006. The authors preset a new restricted and malabsorptive operation for treatment of morbid obesity called vertical isolated gastroplasty, VIG. At 12 months postoperative, BMI was 23. With the excess weight loss was 19%. There are few complications and the operation is safe. By 2012, Alamon team had reported the correct operation, sleeve-gastrectomy with 3 meters of jejunal bypass. And Dr. Hans reported the result of combined sleeve-gectomy and modified jejunal ileal bypass in bariatric surgery. A standard sleeve-gectomy was combined with modified jejunal ileal bypass, divided the small bowel 75 centimeter distal to the duodenal jejunal flexure, anastomosing it to the ileum 75 centimeters proximal to the ileal sacral valve, leaving a total usable small bowel length of 150 centimeters plus 25 centimeters duodenal. Together with the restrictive element of sleeve-gectomy, the procedure allowed for maintained excess weight loss with very few malabsorptive complications. After 2 years, the median excess weight loss was 79%, and this was maintained with excess weight loss of 77% at most recent follow-up. The change in excess weight loss over the duration of the study that demonstrated that the weight loss in the first year is maintained up to 8 years. But there are still many questions to be answered. Is sleeve JJB safe? Will jejunal bypass provide extra weight loss or prevent weight regain compared to sleeve alone? How long should we bypass the intestine? Will bacteria overgrow in bypass the jejunum? And so on. This is our surgical techniques, include a standard sleeve-gectomy. The step line was reinforced. The jejunum was transected 20 centimeters distal to trazy ligament. 200 centimeter jejunum was measured, and side to side jejunal anastomosis was made. The anastomotic and mesenteric defect was closed, and we do the case match study and publish our data in obesity surgery, followed 1 year and 3 years. First, we do the standard sleeve-gectomy. This included 3 main procedures, steps: mobilizations, resection, reinforcement. We use the hybrid reinforcement. We reported that this technique can decrease the bleeding and the leakage after the sleeve-gectomy. And then to find the trazy ligament, the jejunum was transected 20 centimeters distal to the trazy ligament. And then measure the 200 centimeters jejunum from the transected. And then do the jejunal anastomosis. The sister grasped the distal jejunum at 2 meters, and then opened the jejunum. Side to side jejunal anastomosis was made. And then closed the common open, Strafix continuous suture. And then closed the mesenteric defect. And pull the bypass jejunal to the right side, and the continuous suture from the bottom to the JJ anastomosis, and use the unabsorbable sutures. And this is our complications. We have done more than 1,000 cases. The mortality 1 case, and the bleeding in 16 cases. Included that abdominal bleeding were 9 cases, and the GI bleeding was 7 cases. Leakage found in 2 cases. And we compare to the Roux bypass, the complication is similar. This is The outcomes after the sleeve JJB reported from 2006 till to the last year. The case is not so much, and followed up is 3 months to the 3 years, and the weight loss is very good, and excess weight loss is about the 19% to the 80%. The diabetes remission in our center is about more than 85%, but after 3 years, it's about 45%. And the major complication is the bleeding and the leak. The hormones change. What happened in the sleeve plus jejunal bypass or sleeve with the GI bypass. This is the diabetes race from the China, and underwent a sham operation, sleeve with jejunal ileum loop and the sleeve with jejunal loop, followed by the postoperative high fat. At 24 week after surgery, compared with sleeve, the advantage of sleeve JJ and the sleeve JI for glucolipid metabolism was still evident. Sleeve JI had a better performance in lipid metabolism and the GLP-1 saturation of rates than that did sleeve JJ. So, to exclude the bias of the age and the pre-operative BMI on weight loss, we further performed a case-matched study based on gender, age, and the BMI. And we followed up 1 year, 3 years, and we published our data in obesity surgery. The baseline lipid profile were comparable for the pairs sleeve JJB and the sleeve JJB RYGB. At 1 year follow up after surgery, sleeve decreased the TG and increased the HDL, while sleeve plus JJB improved all the lipid profile. However, the postoperative lipid profiles were not statistically different between sleeve and the sleeve JJB. And RYGB also improved all lipid profile, but the effects of the RYGB on TC and the LDL improvement were better than sleeve JJB. A total of the 36 pairs of sleeve and the sleeve JJB, as shown in table, patients in sleeve JJB group had a higher TWL and excess weight loss compared to sleeve group at 1 year followed up. Sleeve JJB group had a higher TWL compared to sleeve group after 3 years followed up. Because these patients in the 1 year is about 36 pair, but after 3 years is only 31 pairs. So this data showing that sleeve JJB, the weight loss in sleeve JJB group was better than that in sleeve alone. There were no statistically difference regarding TW and EWL at 1 year and 3 years after surgery between sleeve JJB and the RYGB. This data indicated that the sleeve JJB exhibited a superior effect on weight loss comparing to sleeve-gatomy alone, but similar to Roux bypass in weight loss. Compared to the Roux bypass, the complication of sleeve JJB was similar in 1 year. How about the nutrition deficiency and the complaints after the sleeve JJB? The nutrition status, including hemoglobin, vitamin D, vitamin B12, folate, and albumin was evaluated at 1 year followed after surgery, as shown in table. Sleeve JJB patients exhibited similar nutrition status compared to sleeve alone. However, RGB patients had a higher rate of the anemia, vitamin D deficiency, vitamin B12 deficiency, and hypoalbuminemia than sleeve JJB patients. And interesting, out of the 26 patients who had a postoperative anemia, 24, about the 92% were female. Sleeve JJB only increased the incidence of the malarious flatters compared to sleeve alone. Compared to the RGB, sleeve JJB patients were more likely to complain of the novel GERD after surgery. However, RGB resulted in higher incidence of the diarrhea, dumping syndrome, and fatigue than sleeve JJB. And how about the lifestyle change after the sleeve JJB? We collect data on patients' postoperative lifestyle, including the consumption of rice or wheat-based diet, dining time, snack intake, and exercises. There were no significant difference between positive and negative group in TWL. We found that patients who controlled the intake of rice or wheat-based diet achieved better weight loss at the 3-year follow-up than those who did not. Rice or wheat-based diet contain carbohydrates and result in fast gastric empty and hunger, which may lead to extra food intake. However, it is necessary to remind the patients to supplement their diet with vitamin B if they this rice or wheat-based diet. And a type 2 diabetes remission rate was 38% for sleeve JJB, and 40% for sleeve gectomy, and 50% for Roux bypass at the 3-year follow-up. 5 patients experienced the type 2 diabetes relapse, 1 in sleeve gectomy group, 2 in the sleeve JJB group, and 2 in the Roux bypass group. There was no significant difference regarding the pre-operative and post-operative HbA1c and free blood glucose within the pairs of the 2 cohorts. We found that the type 2 diabetes remission was similar between sleeve JJB and RGB. We also evaluated the major complaints at the 3-year follow-up, as shown in table. Sleeve JJB resulted in a higher incidence of malodorous flutters than sleeve alone, compared to the Roux bypass. GERD symptom of heartburn were more likely to be complained of by patients after sleeve JJB. Furthermore, RGB seemed more likely to be associated with diarrhea and malarious flutters than sleeve JJB, though there were no significant difference. There has a very long bypass bowel in sleeve JJB, so some surgeons consider the bacterial growing in defunctionalized loop. Multius study of the patients who underwent laparoscopic for any reason after the sleeve JJB. A 5 centimeter segment at the proximal end of the exclude limb was resected. Luminal liquid and tissue samples were taken from this segment for aerobic and anaerobic culture. The pathologic examination of the bowel wall was performed to evaluate trophism and signs of the chronic inflammation. Other variables were liver function and and postoperative status. 11 patients underwent laparoscopy. The median time after sleeve JJB was 14 months. There were no complications from the procedure. None of the patients showed a histological alteration or sign of a chronic infection. The liquid and the tissue culture was negative. The liver tests and the laparoscopic morphology of the liver were normal in all patients. In the past, evidence was found to suggest that many of the etheric and systemic manifestations that follow the JIB were related to an inflammatory process within the bypass bowel, rather than to the surgical induced short bowel syndrome with malabsorption. Invasion of the exclude segment by fecal flora was associated with histologic demonstrable inflammatory response of the mucosa. A possible explanation for this observation is that the anastomosis in sleeve JJB is proximal enough to prevent most bacterial colonization. This was not the case with JIB, where the anastomosis was very close to the ileocecal valve or directly into the colon, which permitted the reflux of bacteria into the defunctionalized limb from the section, where the bacterial load is 1 million times higher. The stomach and the proximal gut are practically germ-free compared with the terminal ileum, colon, and rectum. Now let's answer the question we asked at the beginning. Is sleeve JJB safe? Yes, I think it's safe comparable to the sleeve-gectomy. Will jejunal bypass provide extra weight loss or prevent weight regain compared to sleeve alone? Yes. In sleeve JJB, the weight loss was better than the sleeve alone group, and similar to the Roux bypass in the weight loss. How long should we bypass the intestine? This data we show the 2 meters bypass, but the other surgeons show the 3 meters bypass. They are safe. And I think the 2 meters are safe because the average length of our intestine is about 6 meters. But the whole intestine length measure is necessary for 3 meter bypass. Will bacteria overgrowing in bypass the jejunum? No evidence shows that, and no patients complain the abdominal ache. So my conclusion is sleeve JJB had higher weight loss than sleeve-gectomy and similar weight loss to gastric bypass at 1 year and 3 years follow-up. RYGB exhibited better resolution of the metabolic syndrome in short-term follow-up. Sleeve JJB increased the risk of the Melrose flatus compared to sleeve, but avoid dumping syndrome compared to the Roux bypass. Sleeve JJB none have showing symptoms or sign of liver damage, severe enteropathy, or malnutrition attributed to the jejunal bypass. So sleeve JJB is an effective and safe bacterial procedure. So that's all. That's all my presentation. Thank you very much. Thank you again.
Thank you very much, Professor William from China. And we will be overextending our time here. It's fortunate that we have a coffee break after this session. So this will be a working break. For those of you who would like to get your coffee and come back, this will be a working break in order to accommodate one more speaker in a discussion for this panel. At this point, ladies and gentlemen, it's with pleasure to introduce to you and call our panelists for today's session. And we have Dr. Praveen Raj from India. Praveen, please join us here on the stage. And also Dr. Simon Wong from Hong Kong, and also Dr. Masayuki Ota from Japan. Thank you, gentlemen, and welcome to Manila. So we have heard Professor Wee Liang talk about sleeve and the jejunal bypass procedure and comparing to the JIB, as well as we've heard almost the whole day other sleeve plus procedures like the sleeve plus gastro J and the sleeve plus DJB. So may we hear from our panelists comments about this procedure lectured by Wee Liang. So Praveen, would you like to start?
Yeah, so good morning, friends. So it's a wonderful conference. So congratulations, organizers. And a beautiful presentation and data. I think we have, I think more than 1,000 patients experience from Liang on his experience, and he specifically looked into bacterial overgrowth into the blind loop. But however, this is purely my personal thoughts. I've not been doing the procedure because I think when we look back history always teaches a lot of lessons. We had the jejuno-ileal bypass, jejuno-colonic bypass that were done in the past. In fact, that was without any restriction. And then we went on to have so many complications because of the interruption of intrahepatic circulation, liver failures. So at one point of time, even bariatric surgery was to be abandoned when Professor Edward Mason came back with the concept of restriction. But now we are going back on the same concept of a jejuno-ileal bypass, leaving long loops of blind loop, which we may not know results in the first or because the data was at the end of 1 year and 3 years. I think we need to wait way more longer. We do all know as gastrointestinal surgeons the impact of blind loop. And here we are adding a restriction in addition to the malabsorption. We just have 200 centimeters of bubble on which it works. So I'm definitely concerned on the long-term implications. So until we have more long-term data, I would be very skeptical in advocating or doing the procedure of myself. But however, wonderful results from Liang. Hope the results continue in the long term too.
Thank you very much, Praveen. Simon, any thoughts?
Yes, I feel pity about JJB because people always compare it to JIB, and even when you think about or you look about the literature about JIB, they are blaming the side effect is due to the blinding. But as a matter of fact, most of the complications of JIB is from the severe malnutrition. So there's no really hard data showing the blinding is the only one to blame. So now you use a surgery procedure which have a less severe malnutrition status, less length of so-called blinding, and in fact the outcome we look at it is actually not bad. It's superior than sleeve, and it add the diabetic or high gut theory. The only thing is that the lack of foregut exclusion from this procedure, which may affect the effect of bile acids and also cholesterol control. So, but I think this still have a lot of place in the new wave of bariatric surgery in this sleeve plus procedure. So, although we always say need to wait for longer follow-up, but up till now it's almost 5 years for this procedure, and we still don't see lots of cases with the so-called bacterial overgrowth. So I still think it's a myth on this bacterial overgrowth issue.
Thank you, Simon and Professor Masayuki.
Yes. First, I tell Dr. Liu, congratulations, the very excellent presentation of laparoscopic sleeve JIB. So I realized the mechanism of sleeve JIB. So again, and I also realized the benefits of this procedure compared to the sleeve gastrectomy and Roux-en-Y gastric bypass. But I think the comparison between sleeve JIB and duodenal switch or sleeve DJBs, I think is necessary in your future, I think, because that effectiveness of diabetes is, I think, is not excluded, I think.
Thank you. Yes, we have a question from the audience.
Yeah.
Yes, sir.
Ria Reza from Australia. I really appreciate that amazing numbers that was presented from our colleagues from China. I had to reverse a couple of these. First, I have a problem with naming the procedure, because if you actually counting 20 centimeters from DJ flexure, cutting it, and then another 200, you're not in jejunum anymore. If you agree with me, it's very likely the texture of the small bowel changes to the ileum. So technically, you're doing an ileal bypass. That's for the definition of the naming rights. And the ones that I had reversed were done in South Africa without the sleeve part. And the reason for reversal for one of them was that this lady is actually BMI 49-50, and she came with severe excoriation of her buttocks, because the pH of what she was passing was so irritating to her perineal region that she just she had a very bad quality of life. So we had to reverse it. And then I gave her a sleeve, and she lost what the sleeve patients lose. So let's just make any comments about the naming, which I don't really think is going to be the ileum. And if you had experience with the acidity, well, the pH and excoriation of the skin in the bowel motions.
Yes, from our panelists, anyone would like to answer that?
Sorry, I don't have any experience on this kind of experience. And I think it's interesting. I think I say this, some people with a very distal bypass, they may have these problems, but we never measure the pH on the pool.
Yes, anybody else from the panelists?
I think David had questions. You can.
Yes.
This is for Simon. You, in trying to defend the notion of a blind loop in some of the modern procedures that have that, you liken it back to the old JI bypass, the one from 30 years ago, and said that you think that the complications of that were mostly from malnutrition, not from overgrowth in the blind loop. So are you sure about that? Because I thought the main things that killed that operation was cirrhosis of the liver. And I'm not aware that that's a complication of malnutrition. Am I wrong?
So cirrhosis, yes, maybe, but as I mentioned, the overgrowth problem is not really the only one issue of the development of this problem. And JIB and JJB, the length of malabsorption and also the length of blinding is shorter. So what I mean is we need to open-minded, don't just always blame the overgrowth as the sole factor. And as actually we have difficult to prove this overgrowth even in previous study, in most recent literature that we see.
Yeah, and I remember in CK Wong's procedure he does with a blind loop, there's no problem with overgrowth or any issues so far. It might just be the length. But I think the old-fashioned GIB did have problems in that regard. That wasn't just malabsorption, the old one from 30 years ago. That's all.
Thank you for your questions.
Because the time is very far behind. Personally, I do this procedure much, and so I would like to give a little comment about this. About the name. In fact, the inventor gave the sleeve with jejunal bypass. I give the name with PJB
proximal jejunal bypass. Dr. Liang gave the jejunal bypass. It's very similar procedures, but we have a little different in the bypass parts. So I think eventually if it become an important procedure in the futures, I think there will be a new name for that. But right now I cannot conclude that what kind of name that we should give. But the total length of the bow, I think is very important. If you just bypass 2 meters, if the patient have 8 meters or 9 meters, in fact, the common limb is still very long. You will see the patient's weight loss is not sufficient. It's the loss who have only 3 to 4 meters common limb. This is my first comment. The second is about the long-term complication of blind loop. Yes, we worry about that too. But till now, the 10 years more from the inventor, they did not see the blind loop syndromes. For myself, 5 to 6 years, I did not see that too. So some surgeons worry about that. You can do resectional sleeve JJB. It means you cut the blind loop during the operation. Then it becomes you shorten the bow length only. You don't have blind loop. That's the way that you can avoid that. Or you can revise it back if the patient develop blind loop syndrome or some malabsorption. But eventually, if you have 3 to 4 meters common limb, we did not see any malnutrition issues in this kind of patient. That's my small comment. Okay, thank you.
Thank you very much, CK. In the interest of time, we have to cut this session short. Let's give a big round of applause to our panelists, Dr. Praveen Raj, Professor Otta, Professor Simon Wong. Thank you very much. And of course, the comments from CK Wang. I now pass the microphone to our co-chair, Dr. Ray Santos.
Thank you, Ike. Now for our last speaker, he's going to talk about sleep plus related complications this time. Dr. Mufasal Lakdawala. He's popularly known as Dr. Muffy, is India's best-known laparoscopic surgeon specializing in bariatric and gastrointestinal surgeries. He is a co-founder and chief surgeon of the Digestive Health Institute and director of surgery at the Department of General and Minimal Access Surgical Sciences of Sir H.N. Reliance Foundation Hospital and Research Center in Mumbai. Over the past 2 decades, he has helped thousands of people get rid of obesity and obesity-related issues like diabetes. He has given a new lease of life to countless patients, where many of them found it difficult to even walk. They now run marathons, travel the world, and pursue their passions. Dr. Muffy is honorary surgeon to the Vice President of India, and he also counts as his patients several eminent celebrities spanning all fields. In his 20 years of practice, he has won numerous awards, like the Best Surgeon in the World Award by the American Society for Metabolic and Bariatric Surgery in 2019, and the World Master Educator Award by IFSO in 2019 also, and has performed more than 50,000 plus life-saving surgeries in India and internationally. Ladies and gentlemen, I'd like to introduce again Dr. Mufasal Lakdawala.
Thank you. Thank you very much. So you've all heard of the good things, and we've discussed a few of the bad things with the sleep plus complications. I thought we do know that we've got this all on the rise, and sleep gastrectomy as a procedure is on the rise. But in Asia, we do know that weight regain and diabetes remissions are a concern with just sleep alone. And that is why it's important to add the sleep plus operation. Well, like CK said himself, that he's coined this term not too long back, considering that there was some element of duodenal bypass which played a role, whether it's foregut, whether it's hindgut, whatever. These are the various procedures. You can call them by whichever name you want to, JJB, DJB, SAGI, SADI, you name them, and they'll all have different connotations with the people who are promoting them. The most important thing is that you are doing something with the intestine along with something with the stomach. And so I would like to cover overall complications. So we do know that bariatric surgery is associated with overall complications. So I'm not covering the anesthesia risks. I'm not covering the DVT risks and various other things. But what would be associated with the complications of causing leave would be with any other bariatric complications like hemorrhage, both intraluminal as well as extraluminal, that you would get with the sleeve. Along with duodenal dissection, we do know that duodenal dissection is not the easiest thing. When you have skillful surgeons like CK, And Kazoo and all do it. It looks very simple. You don't damage the gastroduodenal. Ask someone who's damaged the gastroduodenal while dissecting the duodenum, and he say he never wants to do that procedure again. So that's where the JJB or the JIB comes in, or the proximal PJB, as CK calls it. The leaks. Well, leaks are a threat with any other bariatric surgery. And we do know that that's probably the most lethal complication that is associated with bariatric surgery. Sleeves with the sleeve leaks, of course, are a completely different ballgame. You will have pronounced leaks. And the problem with a jejunal bypass added to sleeve leak, if there were to be one, would be that you're adding insult to injury and you're adding more and more problems that come in. The duodenal leaks are, again, a completely different ballgame, very, very difficult to heal. When you're doing a proximal GIB, you have to be careful that if you get a leak there, again, it's a biliary leak as compared to any Roux-en-Y configuration where there is no bile in that part of the anatomy. Gastric stenosis, if you've not done your sleeve properly, you'll blame the entire procedure. So you have to be very, very careful that you prevent these kind of things that is reported at an incidence of 1 to 3.5%. Malnutrition, we've all spoken about it. Depends on how much you bypass. So when we talk about the SADI-S, we talk about leaving a common channel of 250 to 300 centimeter, depending on where you belong to. The duodenal switch, of course, you're getting very, very, very insistent, and I would believe in Asia that most of us don't really resort to the duodenal switch, which leaves only 100 centimeter common channel or even lesser. When it comes to the DJBs or the PJBs, of course, the malnutrition is a concern. Anything more than 100 to 150 centimeters, when you've not measured the complete bowel length, will be a concern. So anybody who's doing this procedure, my recommendation would be, please measure the entire total bowel length. I know it's irritating. I know it's a little time consuming, and especially in an obese person, but please measure the total bowel length before you do any sleeve plus procedures, because that will help you, unless you're doing a PJB where you're just bypassing 30 centimeters on. Marginal ulcers, of course, we do know that marginal ulcers are a bigger concern when it comes to the Roux-en-Y gastric bypass, because the length of pouch you leave. But of course, with the DJB, it is much, much less. But it's still that the sleeve gastrectomy, proximal jejunal islet bypass, very, very less chances. We do see it in the SAGIs, where there'll be much worse complications. So if you're doing a sleeve plus procedure like a SAGI, please be careful that you might still see the marginal ulcers. Dumping syndrome, much less, as we've already heard it, as compared to it. But again, if you're doing a SAGI, you'll see far more dumping syndrome because your anastomosis is proximal to the pylorus, and you will see a lot of dumping out of there. Duodenal anastomosis beyond the DJ flexure anastomosis will not be that much of a concern, but any gastric anastomosis, you will see that as a concern. Well, if you look at the laparoscopic duodenal switch, and I just want to enumerate the various complications from the leaks to various other things like the pulmonary embolism, various other things. Just look at the nutritional complications. That is something that you need to pay an attention to. The food intolerance, gallstones, various other things. So I think gallstone removal is just part and parcel of the SADI-S or the duodenal switch that we do. Weight loss, of course, we are not discussing that. We've already discussed that. But if you look at just this, pay attention to the albumin, vitamin D, vitamin A, because these are all fat-soluble multivitamins that will fall deficient when you go into a smaller and smaller common channel limb. With the SADI-S, again, fantastic results in terms of weight loss, and Antonio will speak later about it. But again, ferritin, vitamin D, iron deficiencies, all part and parcel. So if you're doing these procedures, please be aware your patient is going to be in lifelong jail of taking multivitamins, supplements, both fat soluble as well as water soluble, protein as well, of more than 100 grams of intake. Nephrolithiasis, hyperoxaluria, well, that comes as a part of the territory of bypassing a lot more of the channel. Again, with the DJB, Kazoo and CK very clearly showed it. Again, if you look at this, calcium deficiency, iron, hypovolemia, chronic diarrhea, which can be part and parcel if you have a common shorter channel rent, because we already said that we've got around an average length of around 6 to 6.5 meters in Asia. Please be very careful when you're bypassing more than a meter and a half. Gastric bipartition, the SASIs and various other things. Look at this transferrin, ferritin, iron supplementation. Remember, that's part and parcel of your sleeve gastrectomy, that iron and ferritin deficiency will happen. So all those people out there doing sleeves who believe there's no deficiency, well, there's an elephant in the room. Please do not ignore that. That deficiencies will do happen. Look at the group where they divided the sleeve gastrectomy with the bypass. Okay, the transit loop bypass, what they said had the largest set of complications as compared to just sleeve gastrectomy alone, or the one anastomosis gastric bypass group. When we compare the SASI again, what did they notice again is progressive cause of GERD, gastric content, obstruction. This is a procedure that CK spoke about, the proximal JIB, and not cover the good parts of the procedure. That's already been covered, but there is again the standard hemoperitoneum strictures, iron B12 deficiency, multivitamin deficiencies that you do see that come along with this procedure. So it's not free of nutritional complications, even if you want to believe that it's the new tool that we can deal with when we want to do away with the side effects of the Roux-en-Y gastric bypass. Well, that's not proven to be the case. Again, this study from Liang, where he compares the JIB in terms of sleeve gastrectomy, the weight loss and everything is fantastic. This is from CK's group again, comparing the Roux-en-Y gastric bypass to the TJB. What they noticed is that postoperative nutrition deficiency and complications of the Roux-en-Y gastric bypass, except for lipid and hypertension improvement. So if you look at this and look at the complications from Liang's group, what they compared is that the JJB had an increased risk of malodorous flatus, which he actually spoke about, and compared to the sleeve, and the GRD symptoms were much worse. So when you want to look at the elephant in the room, do not ignore the de novo GRD. And that's what I want to speak about. That's the biggest elephant in the room with the sleeve plus procedures, because that's the problem with the sleeve, the Achilles heel of the sleeve. We do know there's an early onset. Ideally, with loss of obesity, you should lose this obesity. But what causes? Lack of gastric compliance, increase in luminal gastric pressures. Even if you do a diurnal anastomosis, remember that pressure is going to remain. And the final shape of the sleeve. These are twisting of the sleeve. These are all that things that increase GRD with the sleeve. How do I play this video? This is the classic picture that you see with the sleeve with grade 3 reflux and various other things. And a movement of the sleeve upwards into the chest wall. Well, all papers showing intrathoracic migration upwards. I just take 2 minutes more of your time, please. This is what we want to show about the prevalence of Barrett's esophagus in pediatric patients undergoing. If you just look at this data, post-operatively, you do see an incidence of higher de novo reflux. This is a 15-year comparison with manometries and various other things, and you are seeing an increased enhancement of gastroesophageal reflux disease. This paper is a meta-analysis of various things, and what it does prove is that whatever you do, you are going to get an enhanced GRD reflux after that. There is the only convenient to this is Salman Sabah's paper, which he says that you don't really see that much of a significant reflux. And so it's a relatively safe procedure to do just with the sleeve. But most other changes have shown, this is Praveen's paper, where he's shown that a Roux-en-Y gastric bypass stands leagues ahead of comparing a sleeve or a sleeve plus procedures. So if you were doing it for a reflux, please be careful that you do not do it. These are manometry, Demister scores, all proven concepts over a 10 to 15-year period, which have all shown that it's far better. Well, the hernia complications, Kazu showed him suturing the effects of all of all who are doing a loop bypass also, please remember there are internal hernias that happen. That is a concept that remains. That's it. Thank you so much for.
Thank you very much, Dr. Murphy. Can you please join our panelists? May I call our panelists for this particular topic, Dr. Si Yong Dong and Dr. Jacob Kisson. Thank you very much. May we ask Dr. Si Yong Dong to give comments or questions?
Okay, thank you, moderators, and thank you, hello, friend here and online. I'm Zhi Yuan Dong from CC1's team. So we ought to be here and to the start in this section. So I have a little comment. Thank you, Dr. Murphy. I think it's the most important topic regarding about complication of surgery. Because if we pay attention to the complication, if we take care about the complication in order to reduce the complication during surgery, because the complication is suffering, the patient will suffering it, the doctor also will suffering from the complication and also patient's family, right? So it's important. It's also regarding every step during surgery, including assessment and the procedure, the type of procedure, and the manager out of surgery. So every step, if got some problem, the implication will happen, just like Murphy said in the slide. So I have a little bit data from my sentence. In our center, led by CC1, we have been doing this bariatric surgery almost 20 years. Also supported by Lee and CK1 and Lillian, and we have a lot of plus and Murphy. So we have have done about 40,000 cases in our centers. So we have some data, a little bit data from our center. We got 3 people dead of the 4,000, and 3 people bleeding after surgery, and 8 in the hernia after the bypass, and 2 like ulcer bleeding after surgery. It sounds like few or less complication out in our department. I think there are some reason. The first reason is maybe we are training a young doctor like me is so strictly, and I take a long time to training our young doctor like me. She want training and teaching me step by step. So in order to reduce the complication. And the second one, maybe we'll look back. If any complication happen, we'll look back and take session every month to find what reason, to find what happened in order to reduce the complication next case. And the other reason may be in 2014, CC1 proposed a concept about precision metabolic surgery. So this is regarding about precise assessment, precise anatomy, and precise like every procedure, and precise like managing out surgery. So that's why that's important, I think, about this topic. Thank you.
Thank you very much. Before we entertain questions from the audience, I'd like to ask first Dr. Jacob Kisson to give his comments.
Oh, thank you. I just want to thank the organizers of the meeting for inviting me here, and also Dr. Lakdawala for his amazing talk. Almost an impossible task to cover the various different complications that can occur from all these variations on surgery. Just with your volume of work, Dr. Lakdawala, where does the Sleeve Plus fit in with what you do now? Are you doing large volumes?
Yeah, so it's a great procedure to be done in Korea, in Japan, where there's a huge concern for gastric cancer. But in terms of my procedures, I do it mainly for weight regainers where I do the SARDS. I don't do the proximal jejunal bypasses. I do the Roux-en-Y gastric bypass. That's my procedure of choice.
Yeah, the other topic that I thought was interesting, there was leaks with sleeve gastrectomy DJB. Are they a unique problem to have? Are they difficult to manage?
Yeah, the duodenal leaks is a complete mess because the duodenum is not a good organ to have it leaked in the first place. A stomach leak always heals. If you're doing a Roux-en-Y, it's a Roux-en-Y configuration. Bypass it, put in a stent, whatever. But duodenal leak, you'd probably have to convert it into a proximal gastric anastomosis because whatever you do with the duodenal leak, if you try to suture it, it might not heal. It's about the vascularity, especially if you've taken the right gastric artery while mobilizing the duodenum and lifting it up. So that's my concern.
Okay, thank you. Can you have a question, sir?
Thank you, yes. Walid Bukhari from Saudi Arabia. Thank you very much for a wonderful presentation, all of the moderators and the presenters. Mufi, now the one ton of gold worth of question answered is which procedure for which patient? We know that your peripheral operation is the Roux-en-Y bypass. The sleeve gastrectomy for certain other surgeons. Which one is customized for which patient? Which one would you recommend? Because when we hear to your talk about all the complications, it's quite depressive, you know, and it will make you wonder what would I choose for which patient should I choose the sleeve? Which patient should I choose the bypass? Which patient would I choose a duodenal switch, SADI, SASI, whatever? I would like to hear the panel's comment on that.
Okay, Walid, I think CK doesn't like me. That's why he gives me all these complications to speak about. And just like you, Walid, at every Saudi meeting or every UAE meeting, you are the guy who's showing all the bad videos, as you will show out over here as well. So, well, my job was to illustrate the complications. They happen with all kinds of bariatric procedures. The idea is that you should do a procedure which is right for your people and for your area. I think when we try to mimic elsewhere, we go completely wrong. For example, I'll tell you, a gastric bypass is an absolute no-no in Japan. They would have huge issues with the gastric cancer surgeons coming up in arms against Kazoo. CK and AJ, they see a lot of problems with the marginal ulcers and with their central obesity, and that's why they've moved over to the PJB as a procedure of choice. They believe that the sleeve gastrectomy alone does not give that kind of diabetes remission that we are looking for in the Asian subset of patients. We do know that Asians are centrally obese. As compared to Middle Eastern, Saudi, I think a sleeve is a very, very good procedure. You're getting very good results. You do have diabetes, but diabetes is linked more to overall obesity rather than central obesity. In India, I don't have too many concerns with the with the gastric cancer. That's why my preferred procedure of choice is the Roux-en-Y gastric bypass. I do know there are lots of these SAGIs and SASIs being done in South America. I think their results are not results that have been mimicked by the rest of the world. IT, for example, was a procedure taken up by Arroyo de Polo, and a lot of internal hernias, a lot of skill sets required. So that's why that procedure didn't really gain traction as compared to the others.
Thank you very much. I think it's time to wrap up. So we are honored to be here that we hear from all the different procedures to talk and including the complication discussion. And please give the big hand to the panelists and also the speaker. And Mufi, please step over here. We need to give the certification to you. And Kazoo, please.
Yes.
Okay, thank you.
May we call Kazoo and Mufi to the stage. Will be giving the certificates of appreciation from IFSO as faculty during the 7th IFSO APC meeting and for a great contribution to the success of the event. Signed Edward Oliveros, President, Congress President, and CZ Wang, IFSO APC President. For CK Wang, for Kazoo, and for Mufi.
So in the interest of time, we will be compressing the coffee break for 10 minutes. You can go out, we can go out and stretch your legs, visit our booths, our sponsors' booths, and we will proceed. Around 11:55, we will proceed with the next session on the bypass procedures. Thank you very much.
And now you know I can't smile. Can't smile without. I can't smile and I can't sing. I'm finding it hard to do anything. See, I feel glad when you're glad. I feel sad when you're sad. If you only knew what I feel, I just can't smile. Feel sad, feel sad. So together,
Cek. Oh, ito. Cek. Ito. Taas. Game. Pare. Game. Yung podium do sa ano, sa camera. Check. Hello. Check. Hello. 1, 2. Okay na? Okay na ito yung podium. Yung wireless. Ayos sa'yo? Ito. Okay na ito sa'yo. Taas pa? Konti. Okay na. Okay na daw, pre. Ha? Check. Ito. check, check. Ito, two, 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 check. Sound check, testing, check. Wala. Walang music. Walang wireless. Wireless, meron. Wala rin. Teka lang. Nice pa. Podium lang. 8 lang. Ayan. Ito. Ito. Check. Hello, hello. Check. Check. Ito. May wireless ka? Okay na? Or wireless? Music. Check. Ito, podium. Okay. Music. Okay ka? Okay. Check. Check, check. Check, check, two. Check. Check, test. Check, test.
Okay. Man. 7:55. Okay, good. Good morning. We're now moving to our next session, and this is for the Roux-en-Y gastric bypass procedure session. For our chairs, we have Dr. Asim Shabir and Dr. Hildegardes de Neros for session chairs. Thank you very much. Take it away, Doc.
Hi, welcome back from tea break. If my voice can be heard outside there, you're most welcome to come in. We will start the session. Thank you. Okay, at least I managed to get a few in. All right, it's a great honor and pleasure to invite to the stage our session, our first speaker for the session on Roux-en-Y gastric bypass complications and metabolic outcomes. None other than the president of this Congress, Dr. Eduardos. He's the president of the Philippine Society of Metabolic and Bariatric Surgery, and at St. Luke's Hospitals run an active program as the division head of bariatric and metabolic surgery. He spent most of his life doing fellowships. As you can see, he's a top fellowship award winner. He's the fellow of the American College of Surgeons, Philippines, and the Philippine Society of General Surgeons. He's a member of many of the Asian societies. Dr. Eduardos, over to you for your talk. Thank you very much.
Thank you very much, Asim. Good afternoon. I'm sure everybody's okay from the tea break. So I'll be presenting on the Roux-en-Y gastric bypass and complications and metabolic outcomes. Okay, I'll just show you the statistics which everybody saw today in 2020 ASMBS numbers. You can see the gastric bypass is very low compared to the sleeve gastrectomy. It's probably around 30%, a little bit over. For the IFSO report in 2021, gastric bypass is around 36% compared to 50% with the sleeve gastrectomy. If you can see in Asia Pacific, the most for the gastric bypass, it's also low compared to the sleeve gastrectomy. It's around below the 20%. Okay, the complications divided into early and late. If it's early complications, around 1 to 5%. Usually it's technical according to your technique. Bleeding is the most common, but the most bothersome, the most worrisome is the leak. You can also have narrowing of the stoma or deep medical problems such as deep vein thrombosis or pulmonary embolus. These are early complications. For late complications, around 5 to 10%. It could be a stricture, marginal ulcer, internal hernias, and malnutrition. It can be from iron, calcium, vitamin D, or B12, and thiamine. The signs of a leak, which is the most worrisome, the most reliable is tachycardia. You can have increasing pain, fever, elevated WBC count, toxic looking appearance, lethargy, and hypotension. As I said, the early signs of a leak, you might have a persistent pulse, at least more than 120 per minute. This is the most sensitive. But then again, you may have pain, dehydration, or a pulmonary embolus. For the diagnosis, the most important is a clinical suspicion. If ever use upper GI series, it's around 70% in sensitivity, or CT scan, which is better, 90% sensitivity, or the best way to diagnose a leak is an operation. On CT scan, post-op, free air is abnormal more than 24 hours after laparoscopy. Free fluid should be minimal. And don't forget, even a normal CT has a 10% false negative rate. This is the most useful to rule out a pulmonary embolus. Now, operate always in the absence of proof. There's a saying in general surgery, never let intestinal obstruction, never let the sun rise or sunset in intestinal obstruction. For bariatric surgery, never let the sun rise or sunset whenever you suspect a leak. So it's a high index of suspicion because mortality increases with delay in treatment. A negative laparoscopy has a less risk than missing a leak. And signs of sepsis are signs of a leak. So timing is very important. If with a leak and sepsis, if you don't do anything, the patient will die without intervention. And the only chance for survival is controlling the septic source. Always resuscitate rapidly with fluids, antibiotics, vasopressors, or an operation because mortality increases with time. For the management of the leak, it's either an operation, you do a wide drainage repair, make sure you have feeding access with a J-tube, with or without a stent. And remember, whenever when you have stable patients, these are the only patients you can consider for non-operative management, which can be just percutaneous drainage and antibiotics or endoscopic with or without a stent. Some other things you might watch out after surgery is like vomiting. You might have an internal hernia, a stricture, obstruction from various causes, which can be like adhesions, or thiamine deficiency. If ever that happens, avoid dextrose, just give thiamine and vitamin B12. Others like gastrojejunal stricture, you may do an upper GI series, but it's not optimal. This may miss a stricture and may result in vomiting of the contrast. Esophagogastroduodenoscopy is preferable endoscopy. It provides definitive diagnosis, and immediately you can treat this with balloon dilatation, 8 to 15 millimeters. For the GJ revision, this happens for chronic strictures or failed multiple dilatations or chronic ulcers, despite high-dose PPIs, blockers, or Carafate. You also do it for early ulcer perforation. For late ulcers, high-risk patients, just patch it and drain. In summary, avoid mistakes. Always have a team effort in the operating room. Follow a routine, and this will lessen your chances for making mistakes. Always recognize and treat complications early because a negative laparoscopy is trivial compared to delay. Endoluminal endoscopic treatments can help. And if you're going to do a revision, these are complex, and make sure that you have significant experience or you call somebody to help you with that experience. Okay, let's just go to the metabolic outcomes to go through this very fast. If you notice in the IFSO report for the gastric bypass, their first year results are very good. For almost all BMIs, they have more than a 30% result. For hypertension, diabetes, and pain, it's significantly less after gastric bypass. If you can see the first two bars. Even sleep apnea, GERD, or dyslipidemia, they're significantly less after. I'll just look at a few studies. This one was in Asia, meta-analysis in 2019. The results were there's greater weight loss with the gastric bypass compared to the sleeve. For type 2 diabetes, hypertension, more or less they're almost similar. They're both improved and with resolution with the sleeve. Another comparing long-term outcomes after the gastric bypass, at least 10 years, more than 10 years from Paul O'Brien. They noticed with the gastric bypass, it has 60% excess weight loss. For the 5-year outcomes, the sleeve pass study, the gastric bypass is better than the sleeve. The BOSS study, the gastric bypass is still better than the sleeve, and even the STAMPEDE study. One more report which you know came out in Asia in 2021 by Dr. Ota. Gastric bypass was 13% of all the surgeries in Asia. Another meta-analysis comparing it with the sleeve. Excess weight loss in gastric bypass is still better than the sleeve. Resolution of diabetes type 2 is still better than the sleeve, including dyslipidemia and GERD. In conclusion, gastric bypass and sleeve have good weight loss at 5 years, but the gastric bypass has better excess weight loss. And the post-op GERD is less in gastric bypass than sleeve. This is another long-term outcome after 10 years, and they concluded gastric bypass has positive outcomes after 10 years. Now, this is an interesting study in 2021, comparing it to the SADI-S. In terms of complications, weight loss, and conversion, SADI had less compared to the gastric bypass. So they concluded that the SADI-S was a better alternative compared to the gastric bypass. In summary, the gastric bypass has positive outcomes in long term in terms of weight loss, reduction of comorbidities, and improvement in quality of life. Thank you.
Thank you, Dr. Edward. Are there any questions? We'll take just one question in the interest of time. We are behind schedule. If not, thank you very much once again. Thanks for the talk.
Thank you.
Thank you, Dr. Oliveros. Our next speaker is Dr. Yosuke Seki. Dr. Seki is a consultant surgeon from Japan and the chief of the division of clinical research in Yotsuya Medical Center in Tokyo. And he is a consultant surgeon, weight loss and metabolic surgery center. Has thousands of cases under him, experience in Ruwai gastric bypass. Please, Dr. Seki.
Thank you, and good afternoon, ladies and gentlemen. I'm Dr. Seki from Tokyo, Japan. It's very good. My flight from Tokyo wasn't canceled and can be able to be here and can meet all the friends here in the room after a long interval from COVID. My talk is about the weight loss failure after Roux-en-Y gastric bypass. So as everybody here knows, the weight regain is a kind of a natural history of after any types of bariatric surgery in the long term, more or less. And in general, it's a weight loss failure has two different meanings. One is the insufficient weight loss, and the other is the weight regain. And insufficient weight loss is defined as percentage of excess weight loss of, for example, less than 50%. And weight regain is defined as regain of weight that occurs after achievement of an initial success weight loss. For example, it's a percentage of excess weight loss more than 50%. But if you look at the literature, there are so many definitions about weight regain. And some uses the percentage of excess weight loss, and some use the nadia, and some use the total weight loss, some use just the BMI. So there is a definite needs of research to standardize its measurement. So it's an equivalence of weight regain. Because there are multiple definitions, so it's an equivalence. Oh, sorry. So the equivalence varies as well. So it's 17% at 2 years, 23% at 3 years, between 15% to 27% at 5 years, and only 4% between 3 and 7 years. So because of the cause of the weight regain is multiple, it's including the patient-specific factors like hormonal, it's a metabolic, maladaptive lifestyle behaviors, lack of follow-up support, mental health issues, and of course, the surgical specific factors as well. And the predictors. In older age, gender, male sex, longer duration since primary surgery, and the higher BMIs, and the mental health, like binge eating disorders, lack of control of food urges, alcohol and drug use, low self-reported well-being scores, and lack of follow-up visits, and etc. And the comorbidities, such as type 2 diabetes. So it's we need to evaluate holistically, like a psychological, dietary, and physical activity counseling. And of course, we need to check the anatomy using the EGD or the upper GI contrast, evaluate the gastric remnant size of the GJ anastomosis, and the gastrogastric fistula, and so on. So the management. So management needs to be in a multiple ways, and like a behavioral, dietary, pharmacological, endoscopic, and a surgical. And so it's because of the limited time, I only focus some of these 3 issues. So I think as long as I know, there is no randomized control trial about the weight loss medication use after bariatric surgery for weight regain. So this is one of the retrospective study containing the largest number of the gastric bypass patients, 258. And they assess it's an FDA approved medications at that time. And the result is, for me, it's beyond expectation. 54% lost more than 5% of the total body weight, and 30% more than 10%, and 15% more than 15%. And the topiramate, I think the anticonvulsant medication was the only medication that demonstrated a statistically significant response, according to this paper. So their conclusion is weight loss pharmacotherapy serves as a useful adjunct to bariatric surgery in patients with failed weight loss. So let's look at the efficacy of the high dose liraglutide. 60 patients
were involved in this study, including the 17 post-Roux-en-Y gastric bypass patients. And they divided into 4 categories based on the pre-treatment BMI level. And as you can see, after a mean or 10 months of liraglutide, high-dose liraglutide therapy, mean BMI was significantly reduced in all BMI categories. And also the significant weight loss regardless of the type of the bariatric surgery performed. In this comparative perspective study, they compared these 3 different modalities. One is the GLP-1, One is the GLP-1 liraglutide, and the other is the foot thickness suture using the pearl overstitch. And the other one is the surgical revision, resizing the gastric pouch with ring. And only the liraglutide and, and the revisional surgery group achieved the significant weight loss. And overstitch group had the minimal impact in terms of the weight loss after revision. And it's in overstitch group, all patients wanted another solution after 1 year because of the disappointed outcome. And it's in the liraglutide group and overstitch group had a minimal adverse events. But it's in a surgical group, more than 1/3 of the group experienced complications such as abdominal pain, internal hernia, ring erosion, stricture, and etc. So this paper is about the foot thickness suture using the pearl endo stitch with a big number of the patients for dilated GJ anastomosis. So according to this paper, 6-month weight loss was 9 kilos, 8 kilos at 1 year, 8 kilos at 1.5 years. So it's good. This paper, again, evaluate the 3 different endoluminal techniques in the revision of primary bariatric surgery procedures. So one is the endoluminal plication devices, mostly Apollo overstitch. The other is the second group is the other techniques like sclerotherapy, ablation therapy, and APC. And the third group is a combination of suture plus the sclerotherapy, ablation, and APC. So this is the result. Endoluminal plication devices show good initial weight loss during the first 1 year, but after that, the weight loss diminished and not sustained in the long term. So I think it's an endoscopic revision of the enlarged pouch is, I think it's a little bit, it's quite skeptical in the long term. So finally, the surgical revision. This systematic review compares the 5 different techniques about the failed Roux-en-Y gastric bypass. One is the distal Roux-en-Y gastric conversion to the distal Roux-en-Y gastric bypass distalization. The second is a gastric pouch resizing and a reanastomosis. Third is rebanding around the pouch and the revision to BPD duodenal switch and endoluminal procedures, and mostly the old generation device, Stomafix. So this is the 1-year percent excess BMI loss outcome. You can see the BPD duodenal switch achieves the greatest weight loss, up to 64% percentage of excess BMI loss, followed by the distalization, 54%, banding, 48%, pouch revision, 43%, and endoluminal, 32%. And at 3 years, still it's on a BPD duodenal switch, achieved the greatest weight loss up to 76%, followed by distalization 52%, banding 47%, and pouch revision 14%. And there is no long-term, medium-term data in endoscopy. And the complication, distalization group had a highest complication rates up to 12%, followed by endoluminal, BPD duodenal switch, band, and the pouch revision. So recently, it's we are more and more aware of the importance of the biliopancreatic limb over the A limb, and this paper, this retrospective paper summarizes their experience of the revision, distalization. One is the proximal conventional gastric bypass to long BPL, short common channel gastric bypass, and the very long limb Roux-en-Y gastric bypass to long BP limb, short common channel gastric bypass, which makes the A limb 150 centimeters and common channel just 1 meter. So it's weight loss, long-term weight loss outcome is quite good, but severe protein malnutrition occurs, and it's some of them needs the revisional surgery because of the protein malnutrition. So it's the authors conclude that this type of surgery should not be done routinely. So this is the data from Professor Wei-Jie Lee's group for ASEAN. So it's they say the intractable protein deficiency occurs in case the short common channel length of under 4 meters. And the after elongation of the common channel length to more than 4 meter, protein deficiency improved in all patients, according to their report. So their conclusion is that patient might develop protein deficiency after gastric bypass surgery when their common channel length measures under 4 meters. So I think their message is we need to be very conservative when we treat for Asian patients compared to the Western people. So in summary, no standardized approach for failed weight loss after gastric bypass. Underlying factors are multifactorial, including hormonal, surgical, nutritional, physical, and mental. Therefore, the patient should undergo comprehensive evaluations to determine the underlying etiologies. So management should focus on both preventive and treatment strategies delivered in the MDT approach to include dietary intervention, behavioral, lifestyle modification, pharmacotherapy, and surgical and endoscopy if indicated. Thank you very much.
Thank you, Dr. Seki. Is there any questions from the floor? Yes, Dr. Cummings. Yeah, you can.
Thanks, Suzuki. Small comment. You were correct in saying there are no randomized trials of asking whether any weight loss medication can add to the benefits of metabolic surgery. You probably know, however, that there is a randomized trial asking that question for diabetes control, the Gravitas trial done by Alex Mires at Imperial College. And they did have weight loss measures. So this was people who had gastric bypass or sleeve and then either didn't remit diabetes or it went away and came back. They were randomly allocated to get high-dose liraglutide, Saxenda, or a placebo. And contrary to my prediction, those who actually got the active drug showed improved diabetes outcomes and improved weight loss or maintenance of weight loss or loss of weight regain. I was surprised because the endogenous stimulation of GLP-1 is so enormous after metabolic surgery. I didn't think adding a little bit of Saxenda would do shit. Sorry, anything. But surprisingly it did. And so when my people have bad results after surgery, I add semaglutide. I assume it's a class effect and that semaglutide will be even more oppressive than liraglutide.
Thank you for the comment. Thank you.
Any other comment, questions? If none, thank you, Dr. Seki. Thank you, Dr. Seki.
Thank you very much. We move on to the next segment of the Roux-en-Y bypass, and these are series of videos. So it's RYGB in cinemas. We'll start from technique all the way down to some of the most commonly occurring complications. Our first speaker is Professor Simon Wong. Simon is the immediate past president of the APNBSS, the current president of the Hong Kong Society of Bariatric and Metabolic Society. He is a consultant surgeon with the Chinese University of Hong Kong, and I think an honorary clinical associate professor with Department of Surgery, Chinese University of Hong Kong. So Simon is going to show us techniques for RYGB. Simon, over to you.
Thank you, Asim, and ladies and gentlemen. I have only 5 minutes to talk about technique, so I think I will be going brief. So if you look at the consensus on how to do it, in Netherlands, you see their consensus as sleep 75 steps. So I'm not going to discuss all of this because of the time, and different people do it in different ways. So I'm only expressing my way of doing it. I use epigastric latency rejector with 2 sides pots. And usually we will break down our procedure into several phases, create a gastric pouch, do the BPD, create it, and then perform the GJ. And then some go after the AP, the elementary limbs, perform the JJ and close the defect. So this should be the steps that to create the Wu bypass. Some may move the lower part to the front, but I do it in the right way. But creating the pouch, so first of all, I will start with the golden triangle to free the angle of this area, which will make our pouch creation much easier and faster. And because of the lessen the peritoneal attachment. And then we will go to measure the pouch. Different people will measure it in different ways. Some use the second vessels that at the lesser curve, some using a balloon, and some will, for me, I will tend to use a measuring forceps, which has actual measurement here, but this is actually the same as you see the second K vessel is over there. So after the mobilization early in the OG junction, we use the forceps. So 5 centimeters is exactly where we start the perigastric dissection. I use perigastric dissection, but some people will use pass facilitator technique to translate the whole lesser curve. It's possible, but we avoid that because it would also translate the blood supply in some cases. So we move along the lesser curve and ask the assistant to grab the posterior wall stomach and slowly move towards the other side. And when you eventually enter the lesser set, and then you will see the peritoneal refraction in the space, and then we will start the first stapling. Unfortunately, I cannot control my speed. So this is about the way that usually we'll start with a 45 GIA and perpendicular to the lesser curve, and then with 1 staple fire, and then we'll go to the other posterior area for the further dissections. Depend on the build of patient, some will be easy, some will be a lot of fat behind the cardia. So in case it's a lot of fat, you may need some further dissection before you create second fire. So freeing the lesser momentum, freeing the lesser curve in the opposite side, close to the left crust of the diaphragm, that is your aim of directions. So try not to move away too much to the spin. And then you use the staple. Usually I guide it with a bougie. So to break along 40 to 38 French bougie to make sure the tube is nice and narrow, and then fire. Sometimes usually not 1 fire is not enough. So, but it helps us to open up the space, so easier to further dissection to make an accurate assessments of where we should transect, and then we further dissect it until we find the space that we create in the earlier on in the lesser angle of his, and then we will fire our second staple when we reach that point. Sometimes I put a gauze, of course you can see the gauze, but this one you can just see the space very well. So we will just shuffle the staple across, so it will make a narrow and nice gastric tube with the size of about 5 centimeters in the lesser curve. So, and then we move on to create a GJ. Usually it depends on different people, at different preference. I use 100 centimeters. So measure the from the DJ pressure, and we do the GJ first because it's easier to orientate the bow. So make sure it's long enough to the pouch, and then make enterotomy. And I think most people will do it the same ways. This one I use staple and osmosis, but of course it depends on your training. Some will use circular staple, some may do hand-sewn and osmosis. It's all depend on individual preferences. No right or wrong. So after this, you use a 45 staple across and put it in. And we will not use the whole staple, of course. Usually the size is about 2 to 2.5 centimeters GJ, and maintain the just less than 2 centimeters, and osmosis is our aim. So this is how we create the GJ by linear staple. Then we move to close the defect. I think this is straightforward, and a suture technique of from one side first, and then move to the other side, and then meet in the middle. And during the procedure, we will need to beware of catching the other side of the mucosa. But with this, we will quickly go through and close the defect. Before we close it, usually I put a bougie in to make sure the lumen is big enough. And then I can do a full thickness through and through suture, so we don't worry on catching the posterior wall with the bougie inside. And then do the suture afterwards. And then afterwards, we will do the transection of the small bowel, which is the BPD transection. So it's straightforward, make a window on the apron beam, and then do a staple. And so by this way, we will never disorientate the direction of the bowel or which part you cut. And your staple will be close to the pouch, so make sure there's no long candy cane creations. And then in the same time, we will do a lead test by injecting bifidobacterium brew, usually about 50 to 100 cc of say bifidobacterium brew injected. So everything is going up well, then we will finish the JJ. Next step, of course, created BPD, and then the ruling and JJ and close the defect. And we use this 4 step to measure again. Again, we use 100 centimeters. It depends on individual preference. So we run it to the distal bowel. As I mentioned before, some people will do total bowel measurement and some will not. Because we are in the study of measuring the length, so we quickly measure whole bowel length. So this one is 450, so it is adequate length. So we will create the JJ by a traditional way, but we try to move the urim in the C loop, so to make orientation right, and then bring the apron limb together. And this is straightforward with a 10 colored staple with enterotomy closure afterwards. And then you are done, almost done. But of course, there's lots of criticism not to close or whether to close the defect. I always close the defect. So usually we'll just hang up this JJ, and then we will be able to see the peritoneal mesenteric gap, and then we will start to close it. This one we use a V-lock, non-subbable one. So to use circular purse string type of suture pattern. So to close this defect, and then just tighten it up, and it's completely easier and no knots. So afterwards, of course, we have another defect, which is a Peterson defect to close. It here is just to make sure you look the orientation of the bowel, the transverse colon on the top, and sorry, what happened? Okay. So just some orientations. Oh, okay. Oh, okay. Okay, I need to stop, I think. Thank you.
Well, thanks, Simon, for this most speediest bypass probably done on the planet. That was an excellent show. Thank you very much.
Okay, so Step, you're next for the proximal loop obstruction. How to deal with it.
Thank you. Thank you, Chairperson. Once again, I want to thank you for the invitation. Thank IFSO, ABC. My talk will be focusing on probably the most uncommon complication, hopefully, which is at the proximal loop. Can I have my presentation? Oh, here you go. You can see it here. Oh, okay, thank you. So I go move to the, this is gonna be covered by Asim for the internal herniation, but I'm gonna go to this video quickly. This is the pseudo Peterson closure. So I'll skip this. Try to go to my video. The case that I'm gonna show to you was the patient who have bypass done, and when we start oral intake, the patients start to have to be vomiting, and we have a CT scan done. Actually, we have done the, sorry, not this one. I'm gonna skip this internal hernia for Asim. So we have a CT, the upper abdomen film done. It's showing the small bowel, the loop dilatation, and we have a CT scan done. We have to get in. You can see that this is a jejunostomy. We found this spot, and it seemed to be fine, but what I'm going to show to you, because before we start getting in again, we have the video of the first operation review, and we found something not normal. So this is what happening at the jejunostomy. Actually, obstruction at the elementary limb. This is what happened. You can see that from outside it seemed to be fine, but actually interruminal obstruction happening. So we need to undo the anti-obstructive stitch that we put to be protecting the obstruction. So what we have learned for this one is that the anti-obstructive cause obstruction. So that's very important. So we need to remove a stitch. Because we have the review the video, and then we found that this is going to be the point. Otherwise, I may advise to undo the whole thing and redo the jejunostomy. So you can see that these small stitches make the kink on the elemental limb. So let's see from this video. This was the first video when my fellow having this procedure done. So we separate the BPD and elemental limb, and then we measure the bowel. Sorry, can I control? We measure the BPD limb for us is 50 centimeter, and the elemental limb will be 150 centimeter. So this is my senior fellow who been already almost done with the training. Be able to complete the operation. But I want to go, can you move a little bit further to the part that it's happening? So the jejunostomy will be done and the defect will be closed. So we use the white load. So we review this video before we step in for the redo to treat, to collect the jejunostomy obstruction. You may fast forward a little bit to the point that we do the anti-obstructive stitch. Anyway, it will be there very soon. So it start closing the opening. Just wanted to show the stitch that caused the obstruction. So this jejunostomy will be approximated by hand saw technique. Then we put the, before we close the defect, the mesenteric defect, we take the opportunity to introduce the anti-obstructive stitch to make sure that there's no kink on this part. And it will be showing very soon with the non-absorbable suture. It will be shown very soon. This is the alignment of the alimentary limb before we close the gap. This is the opening, the mesenteric defect. Pull it up and then you can see this part. This is the point I will show to you. Let me have probably 15 seconds for showing this one. This did cause the obstruction. Why? You can see that it make a little bit distant from the anastomosis and trying to close this one. Actually, the kink, the interluminal kinking happening after this procedure. So right now we've been very much careful on doing this stitch. So you can see that next would be the point of obstruction that been created. You see that it pulled it up and then it make it kink. So that's why we went in, we just undo it and really make it the, we are not undo the whole thing, just remove this part. And please welcome to Rayong, Thailand in May 25th to 27th for APMBMS. Thank you very much.
Thank you, Step.
Thank you, Sutep. We've got Dr. Praveen Raj from India. He's going to talk to us about the candy cane problem. So, you need a formal introduction? Maybe I give you a little bit of it. He is the head and of the Obesity and Diabetes Surgery Center in Chennai, Coimbatore. We've been hosted by him many times. He's the joint managing director of the GEM Hospital Groups, the chief executive officer of the group itself, and the president of the Obesity Surgery Society of India. He's also the president of the International Excellence Federation for Bariatric Surgery, the Indian chapter, and section editor of Journal of Minimally Invasive Surgery. He's got many other authorships to his name and to his credit, a lot of clinical trials that is done, and one of the most well-published figures from India. Praveen, over to you.
Thank you, Asim and friends. It's great to be here. So I'll rush through. I think for those who are not aware, candy cane syndrome is one of the, the article is one of the underappreciated causes, but one of the many causes for chronic abdominal pain, food intolerance, nausea, vomiting, because of leaving a larger blind loop when you do a gastrojejunostomy. So that becomes dilated, food stasis happens, bacterial overgrowth. So that's what we call the candy cane syndrome. So why does this really happen? So technically, sometimes, especially when you do the jejunostomy first, you sometimes have tension on the anastomosis when you do the gastrojejunostomy. So to reduce the tension on the anastomosis, many surgeons sometimes go away, leave a larger brine loop to do the gastrojejunostomy, as you see in this particular video, because there's a lot of tension as he pulls up, because the mesenteric defect closure already done, there's a difficulty. So this going away sometimes make the anastomosis more easier as compared to doing at the end of the bowel. So that's the primary reason why a candy cane syndrome actually happens, leaving a larger blind loop, just to reduce the tension and anastomosis. So this is something, yes, it can be done. It need not be done so. It can be done at the end, but sometimes to reduce tension, to ease the surgery, to do it more easier. So this particular technique is done. So this is something we need to religiously avoid to prevent a candy cane syndrome, because prevention is the best cure. Because at the end of the day, patient keeps coming to you, you do endoscopies, you see foot stasis, you find it very difficult. So you really see a large loop lying out there. So this is what eventually can become a candy cane. But then just presence of a loop doesn't really mean it's a candy cane. Some obstruction within the loop because of external adhesions or a kink or an intussusception is the primary reason why a candy cane syndrome actually happens. Just not presence of a blind loop is candy cane syndrome, but a loop where food can stay, it can become dilated. So that's where it actually happens. So how can this be avoided? Yes, when you do the Lonroth technique, this is from a robotic gastric bypass. If you use the Lonroth technique, wherein you will do the gastrojejunostomy first. When you do the gastrojejunostomy first, without even dividing the bowel, then subsequently you can divide the jejunum last, what we call the Laundrot technique, which I personally do on my robotics and in my single incision gastric bypasses. So this can technically be avoided. So you just take it, it's basically a loop gastrojejunostomy. Once you complete your gastrojejunostomy, then maybe you can finish the jejunostomy and then divide the bowel, and then you can do a jejunostomy. So this avoids a candy cane. This is something we need to look for, divided as close as to the gastrojejunostomy possible, not to have a large blind loop out there. Although it's isoperistaltic, food stasis may not happen much, but then still avoiding this part is something we need to take care. So once you get it, once you've done a candy cane, once a large loop is left behind, then either if you are doing it, you're doing a reoperation for a potential candy cane syndrome, or if you have picked it intraoperatively, you feel this is too long, then probably yes, division is the best approach. Go ahead, divide the blind loop. Do not leave behind them. Although on a personal note, the candy cane syndrome or the food intolerance is not so common in your practice, but then still, we are actually doing a surgery to improve the quality of life of patients. So we need to do our best to ensure patients do not suffer from anything that is man-made. So this is something we create. So this needs to be divided if unintentionally or intentionally done. Of course, we have reports of candy cane being corrected using Apollo endostitch. I'm really not sure how this could be done, because when such a loop is there, you might actually end up making small cavities. But yes, we have reported that this can potentially be done using the Apollo overstitch technique. But of course, this is quite an interesting technique that can be done without the need of a surgery, using the Magus system, wherein we have the magnetic thing to connect. This was, of course, primarily done for metabolic reasons, but this has also been used for treatment of candy cane approach, wherein the loops are connected between each other. But of course, the biggest issue would be if we actually go to make a large pouch, the restrictive effect of Rodenbach gastric bypass would be lost. Weight regain might be a potential complication. So this has also been reported as technique, but the simplest is go back in, divide the entire part of the blind loop. So that is the way. So that is all I have from ROIGB in cinema. I take this opportunity to welcome you all for our 20th National Conference of the Obesity Surgery Society of India happening in Mumbai for March 2nd to 4th. Looking forward to having you in Mumbai. Thank you.
Thank you, Praveen. And thanks for the updated literature on that magnetic wire. I think got to go back and read it. That's really an interesting phenomena. Thanks.
I believe we have time now, and let's listen to Dr. C.K. Wang in his management for anastomotic ulcers.
Yeah. Okay, I think no need to introduction, right? Okay, so anastomotic ulcer. I think for gastric bypass, this is one of the most devastating problem for most surgeons, because the patient can experience pain, obstruction, bleeding, even perforation. The reason why it is marginal ulcer is because the jejunum discharge to the GJ was based in the acid 24 hours. So it caused the problem that different mechanism we set when we have pyros, and the duodenum is more resistant to the acid. Jejunum most is not. The second is when there is some problem like drug use, like NSAID or smoking, or because we use staple for the anastomosis, it can cause the mucosal damage. And the ulcer happens, then it becomes a chronic problems. So the acid levels can also arise from the dilated gastric reservoir. So if you have some dilated gastric pouch, or in the beginning has a big pouch, then you have also higher problems of marginal ulcer. And the marginal ulcer incident in our previous institute, we have done about 1,000 cases. Then if you follow up the patient with a routine pendoscope, after 1 year later, you will see how high is the marginal ulcer rates, 36%. Some is non-symptomatic, but some would become symptomatic. Then only about 1% become intractable, and about 0.1% need a reoperation. And some surgeons talking about how to treat this kind of refractory marginal ulcer. They do total gastrectomy. But for us, I think this is too aggressive and most of the patient cannot accept this kind of concept. So this is a previous video that in my previous hospital, I don't have new video for the marginal ulcer anymore because I almost did not do Roux-en-Y gastric bypass now. So this is how we perform the marginal ulcer intractable one for a reoperation. The patient have the gastric bypass, BP limb is 40, elementary is about 100. The patient presented with intractable marginal ulcer. We give the PPI, but the patient still have marginal ulcer with the pen. So when we go in with laparoscope, we have to do the adhesion analysis first. You will see the pouch and the jejunum part is very adhesion. So we are going to cut this part first. Okay, so this is the elementary limb. You see the ulcer, it's very big in the posterior wall. So we totally excise this part of the jejunum and including the ulcer. We also need to be careful that whether there's any fistula, but this case, they don't have the fistula and there's dilated gastric pouch. So we can come into the resect of the dilated part to decrease the acid productions. Then we are going to revise the pouch with including the total hands-on revision of the gastrojejunal anastomosis. Okay. So after, okay, after this, we are going to do the vagotomy to decrease the acid further. So this is anterior vagotomy. We use the harmonic dissect and then cut. And then for the posterior vagotomy, we have to open the pars flaccida in the lesser sac area. Then you can find the posterior vagus trunk. So we cut it also. Then we put the OG tube down. Then we are going to do the total hands-on anastomosis. Why we did not use staple anymore? Because staple is also one of the foreign body that we want to eliminate all the factors of the marginal ulcer possibilities. So the re-anastomosis, we use total hands-on with one layer anastomosis. We use the monocreal sutures. This has been reported on a series by our group. That's showing that after this, in fact, the remission rate is very high. We don't have the recurrence of marginal ulcer with this kind of revisional technique. Okay, so after this, you can do the air test. Then to be sure that everything's okay. So this is the series we reported total less 11 cases for these procedures. There's 7 cases are male, females 4 patients. The revisional surgery are done 100% with laparoscope. The surgical time is about 2.5 hours. The hospitalization about 4 days, and the blood loss very less. Then we don't experience perioperative complication or mortality. The symptom relief and improvement is 100%. So I think this is the best way to treat the intractable marginal ulcer with that. So my conclusion is the mechanism of gastric bypass can cause marginal ulcer. In the literature, it's about 20%, but in Taiwan's data from our center showing about 30% more. The acid base to the jejunum, I think the main reasons. How to prevent the marginal ulcer? This is my answer, C+. Thank you very much.
Thank you, CK. So the next speaker would be my co-chair, Dr. Asim. He's going to show to us the management of internal hernias.
Thank you. Thank you very much. Are we live? No, we're not live. All right. Are we? All right. Thank you. I have no conflict of interest. So should we repair? Should we not repair the mesenteric defects? Many people still argue we shouldn't. I think it's a baseless argument. This is literature as old as 2015, showed really some controversy that whether you repair or don't repair doesn't matter. I think what is important is if you repair it well, and always expect that the repair will also break down, so there will be recurrences and they will be small and patients would become symptomatic. This is the most recent RCT published in British Journal of Surgery. 401 patients randomized to either closure and non-closure of defect. Median follow-up of 59 months in the non-closure group. Basically about 67 months of longest follow-up and 67 in the closure group. Accumulated risk of hernia at 5 years rate in those that were basically not closed, 15%. So it's not 100%, not everybody gets an internal hernia, and they spontaneously do reduce. And in the closure group, still 6.5%, which is significant. And so if your patient complains of abdominal pain after they've had a bypass surgery, pay attention to them, pay heed to their complaints, and do offer them CT scans, which might help you pick up these internal hernias. And if they're still symptomatic, a diagnostic laparoscopy is no harm to them. Closure increased the operating time, but it's a meager 4 minutes. You know, it's the time you give your residents to close the skin. So I don't think that makes a huge difference. So there it is. That's what a sole sign looks like. All right. That's where the internal hernia is. The Peterson's defect is up there. Most of us don't do retrocolic anastomosis or put the colon retrocolic, so we don't have the retrocolic, the mesocolic defects. We do have mesenteric defects. Here's a patient of mine about 5 years out in gastric bypass. Yeah. Can we play the video? Yes. All right. No? Doesn't agree to play? I thought it was just playing a while ago. Can we open it separately? Okay, 2 minutes, 20 seconds left. Nonetheless, you go back, you look for where the hernia is. Do not try and pull it from the reverse side. If it is dilated, distended bowel, try and gently push it on the other side and retrieve it. Always go find your duodenojejunal junction. Can we go down and take it out and play it? All right. Maybe we can live with this if it plays. Cannot play media. Where's the other laptop that you loaded it on? My file is not supported in this computer. Lovely. Okay. So basically, I'm sorry, it was playing just down there and it just refuses to play here. I think the trick is if it's a distended bowel, it has actually herniated through a mesenteric defect. What you actually need to do is understand that this bowel portion is distended. If you try and pull from the reverse end of it, it will actually tear apart and you will not know. Always go back, find your DJ anatomy. You might have to gently squeeze it from the other side into the proximal defect and pull it gently, one by one, and it will come through. Once it comes, you close the defects as per normal, and always check your mesenteric defect. What I actually wanted to show, not only here, that the Peterson repair had broken down, but my mesenteric defect also had a very small hole. The tinier the hole, why do people leave it open? Because they say a wider hole, sometimes the patient just gets symptomatic, but the bowel does not get ischemic. In a smaller hole, the chances of ischemia is very high. So that's the reason. No? Okay. Can I play or no play? Well, if you want to watch the video, I guess I can pass it to you personally. I think in the interest of time, I can't do this. It's not working. Sorry? Oh, you're welcome. I'll be happy to entertain you with a cup of tea. Thank you. Sorry about that. Really, I can't.
Sorry about that. Thank you, Dr. Shabir. So we're just right in time for our lunch, but then we have to open our the floor for forum for questions and answers. And we may ask the audience if there's any questions that will clarify or inquire about the procedures that were presented.
Dr. Reza, you want to make a comment? Please come ahead.
I just thought I'd open the comments. One thing I sort of taught myself through the years is a bypass patient, a Roux-en-Y bypass patient, if they complain, it's serious. A Roux-en-Y bypass patient should not have pain. They should not have tachycardia. They should not anything, any variation from a very, very simple course post Roux-en-Y gastric bypass. It sounds like trouble. And one of our colleagues said that an early laparoscopy, that is the best advice. I mean, if you have time, yeah, you got time for a CT scan. You can basically, you either have a problem with your lumen, inside the lumen or outside the lumen. So it's the answer is there. You got to go and have a look. The holes are there. Just got to go and have a look. One thing I wanted to ask the panel and all the experts is the JJ bleed. Have you had experience with JJ bleed? Because I mean, with the GJ bleed, gastrojejunnal anastomotic bleeds, you know, we go endoscopically and inject it or put a clip on it. Have you had, because I have had some experience, I just want to see if someone can share some wisdom from the jejunal bleeds.
So I've personally had a jejunal bleed, used an enteroscope and secured it hemo through endoclips, and it went well. But you need an enteroscope. You can't reach there with a normal OGD endoscopy. You need the extra long, or you use a pizza enteroscope, which is almost the size of OGD, and you can reach that anastomosis.
I guess we did the same thing, and I agree with that. The other thing that it does, because it's such, I don't know, depending on what the lengths of your loops are, the weight of the blood cause a practical obstruction. So you are dealing with an obstruction and a bleed at the same time, technically. So yeah, very good idea for the endoscope. That's how we got to this.
Yeah. And generally prefer to do them under general anesthesia. It's less discomforting because once you insufflate with blood already in there, they feel quite a fair bit of discomfort. And it's easy for you, if there's anything, you can just convert and do anything you wish.
Yeah, I sort of get the same surgical team involved. Yeah. We do a laparoscopy to help the passage of the endoscope. And with the only person we add to the team is the interventional gastroenterologist, a colleague, then we will help him get the endoscope quickly to the point. Good idea.
Thanks. Well, we would like to call upon one by one the speakers. First of all, Dr. Edward Oliveros, our president. Please come. Seki. Simon, I think Simon is gone for the board meeting. Sutep, time for photograph. Come before we go to board meeting. Thank you. Then Praveen Raj.
one's for you. Thank you.
Thank you very much. We bring the session to a close. Thanks very much.
Yeah, yeah. I'm always ready. It should be. I got all that.
Hello, and welcome to the Luncheon Symposium by Medtronic. Today we're going to speak about social media. And if you guys don't already have your phones out and aren't tweeting about it or aren't TikToking about it, then it's better that you start doing that very soon. So just as a show of hands, how many people use social media here? Not so many. Surprising. I'm seeing a whole younger lot, millennial people out over here, but not too many people. How many people use social media for marketing their services in terms of bariatric surgery? So not many. All right. And how many people use in terms of outreach to patients, in terms of patient education? And for learning platforms where you want to learn yourself, how many people use social media? All right, okay. So I'd like to invite my esteemed speakers for this meeting. Firstly, Professor Sang-Hoon Kim. I'm from Korea. And Professor Mustafa Muhammad from Malaysia. Yes. Afterwards. Yeah. So I'll just, can we have this presentation on? I'll just start it off before I get my esteemed speakers to speak. So firstly, I thought this is a great topic, and when Linda and I discussed it, we thought, how do we discuss the relevance of social media? Well, social media networks are all around us, and we might want to admit to it, we might not want to admit to it, but it's a mode of connecting people. And there are global networks, which we all do know about, which have all become famous now in terms of Twitter because of its buyout or non-buyout and various other things about taking syncs to the Twitter headquarters. Then social media networks in terms of physical connectivity, like for disease specific, there are bariatric groups, there are transplant groups, there are diabetes groups, and then health related forums, which are mainly for weight loss, like healthcare forums, health industry forums, medical networks for non-professionals, which they can go to in terms of, so all this is social media, whether we might want to look at it or not. And then medical networks of professionals like ECAD, RC Derms for the skin specialists and various other things. Scientific networks like Biomed Experts, ResearchGate, all this is basically social media. So for all of you who didn't raise your hands, then that means you're doing none of all this. And scientific networks like databases like PubMed and various other things. This is just so that you know the growth. We all speak about the growth of bariatric surgery in our particular countries. Just look at the growth of social media. It was founded in 2004, Facebook, and it's got monthly active users of 2.94 billion. So all of those people who think Facebook is going down and Meta is coming up, get rid of those thoughts. It's still a huge giant out over there, which we can't ignore. Its annual revenue is just in terms of crores. You can just keep counting the number of zeros. In terms of Insta that Facebook has bought over, it is meant more for the 18 to 34 population. It started in 2010, a 1 billion active user profile, 47.6 billion is its revenue. YouTube, 2005, 2.6 billion active user profile, 28.8 billion is its. WhatsApp, again, all these three things actually belong to Facebook. So you can just imagine their reach. I believe social media and bariatric surgery should be used mainly for these three things. Educational purposes, both for professionals to increase their knowledge and for improvement their own abilities. For the general population and patient engagement, in terms of marketing, professionals, so groups, hospitals can use it, and for an individual for marketing, which I think we'll soon see. There's papers written and publications written on in obesity surgery, on the use of social media. Medical centers mainly use it. Medical services for their promotion, and eventually to link to other resources and various other things. Research, a few percentage of people use it in terms of it for research. If you look at the amount of use of social media, you'll see that medical centers and healthcare professionals are using it more. It should be used more for research, but lesser number of people use it for research. The impact of social media, this is a publication from Raul Rosenthal's group, and he says that private pediatric organizations were more prevalent on social media than the academic institutions, which ideally should be the norm. There is one thing I wanted to bring to your notice. IBC started as a closed group of users of only friends. And today it's become such a giant that they have their own conferences. So social media and its impact is something that we should ignore only at our own peril. IFSO, I think we've got our own virtual academies on group, but I think there's a lot more catching up that needs to be done on the social media front as far as IFSO goes. And we need to get there. ASMBS again has started, but if you look at the number of active users, it's far, far lesser than the number of total membership. So I think it's time that organizations and groups look out at the use of social media and how to use it. SWAD as a journal is out there. Then what in terms of medical tourism? Well, there was this publication written by Chetan Parmar, and we were all part of it. And what they've realized is that cost is the one that is driving patients. Now, if cost is something which is on your side and you can do cheaper bariatric surgeries, it's time that you go out and tell people that this is what is available and what you can do. Well, there are lots of misgivings and policies of social media, mainly for doctors saying social media is not important for us because we are surgeons, we are big guys, right? Why do we need social media to even tell people how good we are? We just need to let our work speak for itself. Well, it's time that if you're really good at what you do, it's time to let people know what good you do so that people can actually reach out to you. Social media won't help my SEO ratings. Well, what is SEO? For people who are unaware, it's search engine optimization. And today, if you want to be out there in terms of ranking, we rank things, right? If you want to go to a restaurant, we rank things, we go to Google ratings and various other things. So it's time that if you put out stuff there, your rating will go up rather than the bad stuff. Yes, some bad stuff is put out by people, but the good stuff will far outburden the bad stuff. Then posting on Facebook can drive patients. That's a policy. Yes, you post on Facebook, but don't think it's going to drive your patients. And one thing is important that whenever you post, please, please, please be careful to maintain patient identity and privacy, because otherwise HIPAA guidelines will get onto you and you'll be in deep trouble. Well, for all those who believe that social media is a passing trend, well, it might not have a direct relevance to your return on investment. You put in X amount of dollars and that much should come back. No, but in the long term, it will make your presence felt. It'll make you look like the safe, effective surgeon that you are and get you more and more patients. This is something I wanted to put out. We had Diwali in India, and I don't know how many of you know this, but this is the new Ravan. All of us are on our phones. We're either looking at Facebook, Twitter, Insta, various other things. So if you want to ignore it, well, you can't. I'm just going to end you by one person who I think does a pretty decent job in terms of her own marketing, and that's Renu Rajan from Malaysia. And this is something that she put out which caught my eye. And so I just play it for you. Can I play this video? How do I play this video? Renu put this out to bring out stigma. And the video play? Yeah. So if you're as good looking as that, and if you can dance as well as that, then I bet you'll get enough of viewers and patients. I don't know whether it can translate to enhancing your skill set as a bariatric surgeon. But yes, I think this is a good message she's put out. She said that stigma against bariatric surgery has to go out. And this is in Malaysian. So for all of those who know Malay, they would be able to interpret this. There is subheadings in English. Please go out and see this. I'll open this out now and invite Professor Sang-Hoon Kim to give us his take on how social media impacts in terms of Korea. TikTok, if you have not heard of it, I just spoke to CC Wang yesterday. He said there are centers doing more than 1,000 bariatric procedures only because of the impact of TikTok has had on their practice. So, Sang. Okay, so Professor Hoon Kim is, sorry. All right, okay. He's from the Kyunghee University of School of Medicine. He's completed his master's degree in medicine from the same university. He's done a PhD course of medicine from the same university. A fellowship in weight loss and metabolic surgery from the Yotsuya Medical Cube, from Kazu's group, associate professor in bariatric surgery department from the Songchang University of Seoul, affiliated to the Bariatric Surgery Center, Department of Surgery, Songchang University Hospital, Seoul. Professor Kim, please.
Yeah, thank you, Dr. Murphy, and also the IFSO APC Congress President, Dr. Oliveros and Melton. It's a great honor to present at this wonderful conference, IFSO APC. Today, I'll talk about the pros and cons of the role of social media in decreasing the stigma of obesity and increasing practice of bariatric surgery in Korea. In this presentation, I show how digital marketing has been executed in Korea, especially over the last 3 years after national health insurance coverage. There has been many social media activities from Korean Society of Metabolic and Bariatric Surgery called KSMBS, and co-work with Medtronic and hospitals, healthcare providers, and doctors. The insurance coverage of bariatric and metabolic surgery in 2019 was actively advertised and covered by a lot of newspaper and mass media with the efforts of KSMBS. If you Google this subject, you will find 69 related newspapers in many social medias. And it was also broadcasted by all the major broadcasting stations. They helped the immediate increase in number of surgeries in 2019. After insurance coverage, KSMBS has been actively trying to share accurate information on bariatric metabolic surgery through various media. This is a YouTube channel by the KSMBS, and there are 10 episodes featuring many renowned surgeons, including the current president of KSMBS, Dr. Sang-Gon Lee. The total view was around 20,000. KSMBS also co-worked with SBS, a major broadcasting station in Korea, to open medical channel for more exposure of bariatric and metabolic surgery. This is provided information in card forms for the general public. KSMBS produced a mobile self-diagnostic test to determine the risk of obesity according to the participants' daily lifestyle through the OX quiz as a part of a campaign to improve awareness of morbid obesity and bariatric surgery. KSMBS also cooperated with Medtronic to share the actual stories of patients who had undergone bariatric and metabolic surgery on YouTube. These episodes shared with stigma that they had experienced before surgery and also their quality of life after surgery. Many morbidly obese people were able to relate to their experience, but the total view was not that many. We have been trying to co-work with endocrinologists, physicians, and other specialists through YouTube to talk about the importance of treatment of obesity. We intentionally tried to work with doctors practicing outside of Seoul, the capital of Korea, to lessen the centralized pattern of patients seeking treatment only in Seoul. There has also been a rapid increase in number of morbidly obese people in younger generation. So, in order to fascinate the younger generation, a famous cartoonist was recruited to raise the awareness of bariatric metabolic surgery. The webtoon was uploaded on Instagram as well. Many hospitals have developed websites and YouTube channels to advertise BMS centers and raise awareness of morbid obesity. Our hospital has been operating our website from 2015, and there are about 20 YouTube videos on our channel. There are also online communities run by doctors who are patients who are sharing information, recipes, and experience. One of the most popular online communities has more than 3,000 members, and there are more than 100 postings per day. There are also blogs written by doctors to share research and essays on their own experience with BMS. Many patients read these blogs before they decide on hospital or surgeon. Many surgeons are putting effort into participating in local broadcasts, national broadcasts, or YouTube, etc., to share accurate information on bariatric metabolic surgery. I will discuss the pros and cons of the role of social media. This shows the increasing interest and exposure of metabolic surgery and bariatric surgery and morbid obesity before and after 2019. This survey was carried out by Medtronic. You can see the evident increase in total exposure and interest about severe obesity and metabolic and bariatric surgery. However, after the 5 times increase in number of surgeries in 2019, there has not been much change in number of surgeries over the following years. This implies that the social media activity and news exposure may have not had enough effect than expected. More than activity on morbid obesity, there seems to be a need to raise awareness of morbid obesity as a disease first. In Korea, there are surgeons certified by KSMBS in each region, and there are about 10 100 doctors. By introducing bariatric metabolic surgeons outside of Seoul via social media, this has helped patients to seek treatment from regional hospitals and surgeons closer to them. However, this is still a trend of centralization to Seoul. More than 80% of the total operations are performed in or nearby Seoul, and over 20% of total operations are still performed in one hospital. This may be due to the easy transportation within the country, and also because of the younger age of patients who are depend on social media. This trend may progress to doctor shopping and increase medical expenses. This shows the related keywords to morbid obesity on the most commonly used portal in Korea. Unfortunately, bariatric metabolic surgery is only the 7th to 10th mentioned related keywords to morbid obesity and treatment. And diet supplement, herbal medicine, or liposuction comes up before bariatric metabolic surgery. This means that more people will search for herbal medicine, liposuction, diet, and exercise for the treatment of morbid obesity than bariatric metabolic surgery. It takes a lot of effort and time for doctors to operate various social media. Recently in Korea, the quality of life of surgeons is very low, and the rewards for their efforts are small. So the resident application rate for general surgery is declined every year. Therefore, it is not easy to operate social media as the loading for the patient care is increasing. Bariatric metabolic surgery is a long journey requiring a multimodal approach for the best outcomes. Dietary counseling and mental health support are important factors in this journey. Advertisements and social media exposure about the positive outcomes alone make patients believe that bariatric metabolic surgery may be an easy fix for their problems. And this misunderstanding may eventually lead to weight regain. In summary, social media may be able to increase the total number of surgeries with accurate information and raising awareness of morbid obesity as a disease. But it will take an immense amount of time and effort. The reliability of information provided through a social media is an important key point, and we should take care to share honest data instead of simply advertising. Thank you for your attention.
Thank you, Professor Kim. Next speaker is going to be Mustafa. Mustafa's from Malaysia. So Mustafa completed surgical training in Malaysia at the National University of Malaysia for upper GI and bariatric surgery, with special interest in minimal access surgery. He performed more than 3,000 bariatric surgeries to date. He's a gold medalist on one creative endoscopist method that is published in the Journal of Royal College of Surgeons as a new innovative technique. Again, a member of various Malaysian societies, a member of IFSO and SELSMA. I've seen Mustafa operate. He's a great surgeon, and today he's going to speak to us about how he markets his services. Mustafa.
Okay, thank you very much, Dr. Lagdawala. First of all, good afternoon, and thank you very much for IFSO for having me here talking about topic out of the scopes. Okay, let's have something a bit of what we call some scientific off. Let's say now the problem when you come for all these conferences, all what you are looking for is what you are sharing your scientific things. But you keep in your mind, end of the day, if you come out from here, you get a bit of good knowledge, a good experience, you get to socialize with doctors, but who you are, you need to brand yourself. Not everybody can be like Mufi Lagdawala, not everybody CK Huang. Those people, they've been known, they have 100,000 of cases they've done. So how can you be somebody like them? How can you be somebody who can share your experience? How can you grow up? In a sense, you will be one of those good doctors who can actually really help. Now, social media is not about catching your phone, is not about like playing the TikTok, not about only seeing what's happening in the world, but it's at the same time, it can be very educational. It can, which I disagree somehow with the ROI, actually return on investment. 85% of my return of my work is actually from social media. So basically it have good thing that you share your knowledge, you introduce things to people, and at the same time, you can make also some money from that. Now, tell me how many in any country, you have a lot of people who are skeptical about bariatric surgery. A lot of people, they are going for the non-surgical or a different type, but we know those type of people, they know they need a true help. And this is actually where basically you need to educate them. So it's not merely only about like introducing yourself, but it does have a lot of good return to you. Okay, I just want to introduce myself. I'm originally from Iraq. I drove myself to Malaysia in 2007. And this is where I finished my education at the National University of Malaysia. This is currently, I'm not in the university anymore. This is my center. We are a center of gastroenterology and liver disease. We do basically mainly anything related to GIT from upper GI, lower GI, and bariatric. That this is my division. Okay, I just want to tell, I'm going to show my numbers, not to show off, but I just want to tell you how can I handle and where all those patients came from. So basically, our center, we do have all the subspecialties, endoscopy, hepatologists, because we have a lot of gastroenterologists, and we have upper GI, lower GI, and bariatric as well. I just want to share my numbers. I do basically around 800 to 900 cases per year, but basically this is the minimum that I do. I can do more than 1,000 per year. This is a single surgeon work. I work 5 days a week. So on basis of 5 to 6 cases for the last 4 years. I do all the time also, but I still in the very traditional, I do sleeve bypass, midi bypass, and revision types of surgeries. Okay. This is not for me to show number, but I just want to tell you what is all behind it. Okay, now when we talk about social media, regardless of any type of social media, it's just like the way you dress yourself, you dress the way you like. It's the same as social media. It's something that you have to understand. There are different types of social media that have a different impact as well on your job and business and everything. Just choose the right one. There are even in Medscape, which is basically evidence-based, that show you there are some individuals and doctors that are top 20 doctors they actually in on social media. I think everybody knows that Dr. Mike, he's a millionaire and he's an age of 32 and he's a physician, and basically all he does is actually what he is good in social media. So there is an ROI behind it. There is no way to say no ROI. I think I'm not going to go for this. There is a lot of pros and cons behind it. Advantage and disadvantage of social media, yes, that's true. But let's go beyond that. I think this study already just, Prof. Lagdawala, he just showed this. But I want to show you is actually between all what is shown, whether it is on Facebook or even on Twitter, this is show you that majority of people that are actually using this type for advertising, they are either from medical centers or healthcare. So if you are not one of them, you consider yourself you are lacking behind. So it's time for you to think differently. Okay, so how the bariatric surgeon should be look like? Okay, you have to represent yourself. You cannot be like somebody like merely like you name your bariatric surgeon like you are somebody do. You have to represent yourself from the way you look like, from the way how you talk. from the way actually how to do things. This is not cheap. People, they need to know who you are. Now we know the impact of of obesity, and a lot of talk about how to fight against obesity. That doesn't come by for you is stay in your comfort zone. Now, is this considered enough, or do you think this is your maximum capability? You think doing surgery is enough for you to fight against the obesity? Then you are not right. You need to do something beyond that. Yeah, definitely you are a good surgeon as a surgeon, but what beyond that? What about education of people? What are the other people to let them know what is all obesity and the impact? This is where basically you have to, okay, so what the bariatric surgeon they have to do? I think this is everybody comfort zone. Surgeons, they like to be in the operation theater and they like to operate. And don't tell me I have to meet this press guy. Don't tell me, oh, this is a company rep want to talk to me. Don't tell me I want to talk. I don't have time for this. I'm busy. I have surgery. Yeah, that's true. But you have to understand. You have to brand yourself. You have to maintain yourself. So it's time for you to walk off and go out for a different world. So you have to. We are here in this conference actually to get benefit and get other people benefits as well. Okay, so I just want to share with you what we've done all these years and what we've done our social media on our level in Malaysia. So basically, we try to approach the insurance company to try to get something for the bariatric surgery. We apply, we are already approved. We have a fintech program, which is basically a medical loan program. We create a whole program and a bargain prices surgery. And I'm gonna go later for my own brand. Basically, we've done a lot of education programs, include people like actually, they are from training, dancing and everything. And you can see me here, I'm wearing my Indian suit, the one I bought it from India last time. Okay, we went all the way to the Arab countries to advertise for it. This is where basically we talk about health tourism. We went to Brunei. We have a lot of patients for Brunei. This is our reunion with a Bruneian patient. We went to Indonesia. They have this Kagumi society where basically there are all the obese people there. And we got a lot of, Indonesia is a very big market as well. Tuvalu, which is, if you don't know, it is an island just next to Fiji. This is actually the Minister of Health. Okay, the body build of the people that are look like that. And we have a lot of appearance on TV, local Malaysian TV, different type of TV. And this is actually, we have a lot of we brought all the bloggers, actors and singers, all the influencers, because those people, they have a different impact on the society. You need to understand your society very well. Actually, in Malaysia, they have a very good response to the social media. So it can be like very good and can be very bad as well. So that's why when you have a good influencer, those people actually that can help you a lot. We have a lot of with the local European society in Malaysia. We have a lot of appearance on the Arabic magazines as well. I've done a lot of cooking with some of celebrity chefs. She is actually a known person that have a lot of recipes. So we put an input from the diet point of view. You are not a surgeon only. You can be a nutritionist, dietitian, but people, they want to see you outside there, how you look like. Something different than being in the operation theater. This is actually this is the son of the Sultan, one of Sultan Kedah, one of our states in Malaysia. So we did a launching for the healthy type of life in KL Free Day. So this is actually for people, education and everything. We give talk there. I appear myself on what is my daily activity life. We appear on what you call passion magazines. Okay, now this is what we are going to beyond doing that. So now I'm building what we call M brand. M brand is my name brand. So what is under that M brand? So first we have this is M Zone, which is a community health studio. So basically we do a lot of events. I do training for my patients. A lot of those people that are normal people and students then actually celebrate even my birthday day with them. This is actually their own arrangement, not my arrangement. Okay, even Deepavali, we wear and dress like the Indian culture. So the patient, you have a connection with them. You are not somebody to operate on. You have to do something beyond that. M-Hope program is a purely charity program. Basically, we able to get something around a donation from some of the institutes. We do a free surgery from the surgeon and assistant and the hospital for very poor people. So we're able to secure almost every month, for a certain type of patients. And this is also a joint venture program with one of the company as well. M Diet is basically a diet which I designed basically to help the patient have a different type of protein content away from soy protein, have a good cultural bacteria. You can be from every direction. This is actually in social media. You should have some sort of good followers, and I have running my social media in English, in Malay, and in Arabic as well. So I have people who are running this, but the content all have to come from me. Keep in your mind to be on the safe side. We don't post, we repost. Don't break the patient confidential. We don't ever post. You cannot just simply take a video of a patient and you just post there also, but that is actually, that you are not doctor anymore. So keep yourself very professional, right? We got a lot of good relation with the patient. They give you gifts, they give you food, they give you everything. Go to this didn't come from only like doing good. You have to have a very good background also. These are the people that actually we mingle with them, we learn from them. Prof. Shayan Shah also, he's somebody who came to our side and he already changed our stigmata for the operation. These are all the pioneers. You can see them. We see them there. We do something special for them. But basically, this is the time when you are a surgeon. When you are like try to control yourself, like and I have a good experience, it's time for you to do something differently. You cannot grow on social media only. Our team, we have a very big team, but basically single surgeon, single anesthetist, and I have only a trainee bariatric nurses. I don't have doctors who help me in that. We do nursing training program. We do training for John Hospital. This is a military hospital, and we do a lot of not only for bariatric, we do for them also for hernia and anti-reflux surgery as well. This is where basically you have to understand it's never been like doing surgery alone. It's have to be a combination of everything, every part of you people they want to know, right? Now, this is our proposed future bariatric academy, which is basically, hopefully we can get some accreditation from all the center, whether it's from India or Taiwan. And that will be our training program for people to help them to do a perfect surgery. Simple tool, you need to be carrying this everywhere you go. I carry my phone, I have my good audio system with me, a good stabilizer, you have to get a perfect videos. These are the things that give you a different quality. You have to appear by a good look as well. We do like good quality of surgery as well. So how to emphasize on the quality of surgery, this is where basically you have to do it right and you have to pass it. So basically emphasize on quality and share. Teach people actually make you like a different. These are some of the celebrities patients that we've done in Malaysia, a very famous singer. She's an Indonesian actress. This is a comedian guy. And this one of my very good old patient who had a mini bypass surgery. And for that, I would like, thank you very much.
Thank you. Thank you, Mustafa. If I can have you sitting as well, if you can come here. I'll just open this up for the floor now. I'm seeing people from different parts of the world. So I'll start. Can you have a mic there, please? Mic in front. Yeah. I started off with Prof. Waleed Bukhari. He's from Saudi. Waleed, my question to you is, I do know social media is used very actively in Saudi Arabia for marketing. You are one of the best surgeons that there is in Saudi and Middle East. You're from old school as well. Do you use social media for your own set of marketing? Can I have the mics, please? There? You can use.
To tell you the truth, I never use social media per se. You know, you've been in Jeddah before, you've been with us in Riyadh, you've been with us in Dammam. I hate to brag, but my name is what you call it brand, is a brand name. Bukhari is a brand name in Saudi Arabia. I am the address for difficult cases, for serious revisional surgeries. And I noticed the big dip down from doing 1,500 cases a year, which I used to do as a single surgeon, as you know, down to 800 cases a year when I let the train of social media pass me. The other problem we have is hackers. I had an Instagram, which I set up, you know, Noha, my secretary, set up, and she comes in the operating room. And I had more than 8,000 films where I talk to medical doctors, mainly young group of surgeons. I had followers, more than 8,000 from all over the world in 4 months period. A hacker came in and he took away everything. You know, it's not only, I don't know anything about the media or social media, but he deleted my Instagram post. Okay. And I thought he's going to ask for money. He never showed up. Then started again, had another 3,000 cases over a period. And of course, program questioning and answering about bariatric surgery complications, what the fad about bariatric surgery happened. Again, another hacker or the same hacker deleted the area. So I decided not to go into that field. And I'm just depending on my name, working. But, there's something to know. We can hear from the panel. What would they do in such a case?
So for someone of your experience, I understand you don't use marketing because you are a brand itself. But do you think you could, like I showed you before, as in terms of education for some of the younger surgeons, would you still attempt, despite all the hacking, to go out on the social media platforms with bad cases?
Definitely. I think, we went to a meeting in Riyadh with Dr. What's his name? In the university, King Khalid University, in the Saudi surgical meeting. And I went there when the hacker came in and took my site. All the young surgeons came, Dr. Bukhari, why did you stop showing films? Why did you, students and doctors, junior doctors, middle level doctors, surgeons, we learn from those films more than we learn from our professors. I would never, if I am sure that I will not be hacked again, I will go again in social media.
Thank you. Yes, Reza. Reza, since you raised your hand, I was going to come to you anyways. But what about Australia? Do you guys use it?
Look, I just wanted to share the other side of the equation with you. Yes, we do use social media in Australia. And I just want to share a very small story on social media that happened to myself. And that's one of the interesting side of it. We started using social media 10 years ago. And I got a busy practice. I do average about 1,200 cases a year and not counting the balloons. Could be up to 1,500 with them. So about 10 years ago, a very unhappy sleeve patient who had a bit of an argument with my dietitian about what she was having after the sleeve. She started a page and she called the page on the Facebook, Dr. Reza Adib's sleeve patients. And then she started writing very derogatory things about her experience. So I rang my defense organization and I said, what should I do? They said, do you think most patients think you're good? I said, I think so. So she said, just sit tight. So other patients starting to write things on that page on top of what she had written, and more came and more pages on top of comments, people joined that and they started talking to each other. And within 3 months, her comment was completely buried. More people were joining. That page had more hits than our website and our Facebook page and everything all together. And we started getting more referrals from that page than anything else. So this is a bizarre experience that I've had. But the answer to you, Mofi, is yes. I absolutely. I mean, it's a very rare situation. Walid's situation is where he is W icon of Saudi. He doesn't need to. I mean, I was very impressed with what you did, Mustafa. Very impressed. But Walid is the W of, it's almost like a W hotel that we have here. He's the W. He doesn't need to. And the other thing I want to tell you that you spend amazing amount of energy. I think the organic ranking is the way to go. If you look up any bariatric procedure in my state, it's a big state. It's almost half the size of India, Queensland. Somehow I have not spent a single dollar on advertising, but most people get encouraged to get a feedback to the social media. And organically, if you look for any procedure, if it's not an ad, my unit comes first. You're you're the first one. So this is my experience. Let it grow organically. But if you have time and energy, I raise my hat to Mustafa.
No, thank you. What you said, Reza, is quite correct. And I don't know how many of y'all, the show of hands, have had a bad patient write something bad about you on social media if you're using it. Bad comments posted against you on social media. All right. So, I mean, you're going to get the good with the bad, but what Reza said is very correct. The more your ratings go up, it's only because I SEO, like I showed you. And exactly the same thing happened with me. The good guys really fought with that bad guy and said, you please don't talk. And she tried to promote another surgeon, funnily. And they really went and hit that poor surgeon for no fault of his, just to try and promote me. But I think if you've got good stuff going, I think then you're pretty okay. From Philippines, who's here? Shell, do you all use social media? Could you get a mic, please?
Hi. Yes, I do use social media.
And do you find it very helpful in Philippines? What is the best form of social media you all use?
I think right now, what's very common locally is still the Facebook. Instagram is also becoming very common, also TikTok. And a lot of people also use YouTube. But personally, because I don't have a social media manager, I just have to manage and juggle everything that I have on hand as a surgeon, apart from my other life, the other part of me, house mom and everything else in between. So it's kind of difficult for me personally to manage it myself and post things. But what I do find that it does become very helpful, especially if you post things that are like organs, intra-abdominal organs. That would get a lot of hits. If I post my face or if I post some information, some infographic, it's not going to get a lot of hits. But I think it depends on the demographics and who has come across your posts per se. Also, if you get, tags and other stuff, they would also see it. Most of my posts would be seen by my local circle of friends, the local people, and then they would actually promote it to other friends as well. So that's how it goes.
So you think it doesn't gross people out? Because I've sometimes heard patients say, please don't put these gory pictures of organs you remove, because we get totally grossed out by that.
So far, I have not had that comment. I had one comment that they thought I had a social media manager because it actually gathered a lot of clicks. But it was actually a picture of the sleeve gastrectomy specimen and the gallbladder.
That we saw Mustafa really do a great job with, right? He put a circle of hope around with the sleeve gastrectomy organs that he's removed.
Yeah, mostly I would get more hits if I put in gory pictures, and then social media would automatically blur it out because it's not very child friendly or very friendly to the non-medical field.
Since we're in Philippines, anyone else from Philippines? Paulo, I catch you before you run away. What do you use social media? And do you also put up all these gory pictures that Michelle does?
No, I don't. Actually, I have abstained myself from social media.
You're one of the younger lot.
Huh?
You don't have W written all over you.
No.
So why wouldn't you use social media?
For me, I think when regards to, in the marketing sense, yes, you can use it. It's very effective and very, but for me, I'm more attuned on trying to stay out of it because I don't know. I'm having a hard time handling these kind of things. Keeping myself, keeping updates, keeping like this. And I believe if you're gonna look for social media, you'll have to have a team on that, I suppose, to handle it. Because
yeah.
if you're
I
gonna
think
control it personally, yeah,
I mean, it's a big factor. It takes a lot of effort and time. You have to think of the content. You have to edit your pictures. You have to think of what captions to write down. So
yes,
I think for us younger generation who are working by ourselves individually without a team to manage it, it takes a lot of effort on our part, especially if we have to juggle several duties at hand.
But I think, when you're gonna engage in social media, it takes a lot of, I mean, it's like a reality show. You're gonna show aspects of you you'd like people to see, and people might see negative things about it as well. You need to be able to handle it. For me, no.
Okay.
Yeah.
We've got two very busy and very older gen surgeons. Prof Lee, I've seen him post a lot on social media of late. Prof Lee, I want to ask you, why did you start writing on social media and stuff like that? Yeah, Prof Lee? You are very busy, but you started using a lot of social media. Why?
Try to get younger.
Okay, do you think it's helpful in terms of your outreach for bariatric medical tourism, because you travel quite a lot?
Definitely. I see so many successful, yes, like, yeah, my father is one of the successor. I see so many young surgeons successful on it. Yes. So I think it's a trend of the future.
Antonio, you again, you, Waleed, Vijay, are guys who are been there on it. Do you use social media?
Well, we have some concern there in Spain or using social media. We really use, but the most important point is by word of mouth. The word of mouth is going to be the most important. To have some meeting with your patients. And then to have some attention to a small group of your patients. They can spread the word much better than the social media themselves, because in some sense, going to be some concern regarding, using that in a proper way. I don't know.
Do you think that maybe some of the negative comments you get against Sadi, which is not necessarily true, would become less if you posted a little bit more on social media?
I don't think, non-medical people can, appreciate, the real value, the problem. It's much better than the patient operated by Sadis, talking to another patient, that they are doing much better. You're going to be convinced, even the patient are convincing the surgeons about the Sadi procedure in some scenario. You know what I mean? So I think, it's not a very safe, in my humble opinion, a scenario for us. But, I have some concern.
Kwang Wei, Singapore, what's the scene? And you've done worn both the hats, government as well as private. Do you think you need social media in private more than you do it in government, or what do you use? And one more thing I want to ask you, because you come back from the multidisciplinary approach at the end. There are lots of groups. There is a sleeve gastrectomy group, there is a gastric bypass group, and various other things. Do you think that these groups talk common sense, because they just ramble around? So would you?
I think I'm the wrong person. Disclosure, I'm not on social media. So should I call it? I mean, maybe you should get if you're from Singapore. But I mean, my thoughts in general, same thing. I feel that because social media, you need to keep up with updated information. That's my sense of it. And to me, I think it's a very personality thing, and hence by choice. It sounds like that. So if I feel that that's the way I want to communicate with people and keep posting and keep updating, then I think it's a good thing. But I think what I'm concerned about with social media is stigma. We may end up being too weight focused or treatment focused, but we really forget that, for me, like you say, MDT, we are treating obesity. So I don't, whatever treatment is good, but at the end of the day, if we address obesity, and that's where MDTs come in, that's the right messaging to go out. So sometimes the concerns about social media is the messaging. Yeah.
Rajesh, you wanted to say something before we wrap up.
Hi, sir. I'm Rajesh from India. Basically, apart from working with you in a 5-star hospital at Mumbai, my main practice is in peripheral area, in a rural area of India. And in general, not bariatric, but I operate 80 to 100 laparoscopic procedures in a year. Because of social media, I get patients from all over cities to my rural center, because I have robot as well. This is one part. And second part is YouTube is again social media, and you operate and you post your posts. So many young surgeons get inspired with you and learn the procedure with this social media. Most of the time in almost all weekend, I'm operating somewhere demonstrating surgeries of hernia in some part of the country. And that is the one area where you get yourself up in your colleagues because of social media.
Thank you. I'll end by giving a last comment to Mustafa to begin with, and then Professor Kim.
Okay, I think this is turned to be a contradicting session, same like we are talking to the type of surgery. Again, I think this is a matter of your interest and your commitment. It is a commitment. But just like this, if you put yourself in a certain level, you want to serve your mission, that is actually your choice. If you are in the university, totally different if you are in the private. In the private, you have to maintain to a certain level. But once you enter into that track, it is a commitment and you have to really go into it. But talking about it, once you go into the social media and you are a social media freak person, you will see things in a different way. You will get a different view for things. You have an impact. You can actually impact people. You can convey the message. I just mentioned I'm in IFSO, but IFSO, I just want to tell my patient, I'm changing. I'm getting some more experience for you. For my patient, they like that. So there is a different aspect. It's not like to show off that you are in Filipino or attending or whatever you are wearing. So they have a different prospect behind it. And talking about like Dr. Walid and what you face, I don't know, this is like, I think the first time, because like in Malaysia, we have a special authority, MCMC, that even when you post, everything have to be under control. And the last words, if you are worried about people who give you negative comments, make the people not like you, they have to love you. Those people who are gonna protect you on the social media. Thank you.
Yeah, actually, I'm a beginner of social media, so I have learned from Dr. Papa and Mufi and all audience. Thank you very much.
Thank you. I'd like to thank Medtronic for giving us this opportunity. I'd like to thank both my speakers, Mustafa and Kim, and thank you all for being here at lunch, and you really have added value to this whole thing. Thank you once again. Thank you.
Okay. Good afternoon, everyone. So let's proceed to our next session. I'm Dr. Michelle Lim, bariatric surgery from Philippines, and I would like to introduce my co-chair and our first speaker, Dr. Wei J. Li. He is a professor of surgery at the China Medical University Hsinchu Hospital, National Taiwan University, and National Chun Kong University. He is the superintendent of the Bariatric Metabolic Surgery Center, BenQ Hospital, Suzhou, China, the Chief Bariatric and Metabolic Surgical Center at the Central General Hospital in Taipei, and is a consultant at the Minsheng General Hospital, Taoyuan, Taiwan, the chair of the Senior Advisory Board of the IFSO APC, and a promoter of the Asia Pacific Metabolic and Bariatric Surgical Society, and a promoter of the Taiwan Society for Metabolic and Bariatric Surgery. Ladies and gentlemen, Dr. Wei J. Li.
Good afternoon, ladies and gentlemen. Thank you, Michelle, for nice words. And I'm so happy to become face and face again after 3 years in IFSO APC. So I think the symposium is focused on one osmosis gastric bypass, probably the most updated recognized procedure. So I will try to introduce the history in the next 15 minutes. Yes. So we all know the procedure is starting from 1990. At that time, I think the RIGB replaced the VBG as the major operations. Then in 1994, Whitgrove performed the first laparoscopic RIGB, and we know it's very difficult and cause a lot of high complication rate and many complications we don't know before. Then in 1994, Luttridge invented this procedure in an emergency trauma case, and he called it mini gastric bypass and report the series first in 2001. And because he's doing a lot of commercial advisement to accumulate a lot of case and create some complication, so there's a lot of issue conflict in states. And finally, this procedure was sentenced to death by SNDS. Unfortunately, you know, because of literature, some surgeons outside of American start to perform this procedure. The most famous one should be the Spain Carbagia group. They changed the name, modified the technique to call it one osmosis gastric bypass, and first published in 2004, then in 2005. When we look at the technique, yes, they use a little shorter gastric tube and make a vertical anastomosis, side-to-side anastomosis, and call is to avoid the bile reflux, and call this procedure one anastomosis gastric bypass. And our group in Taiwan also report the first series in 2004. That's used as a mini gastric bypass as a revision surgery for VBG. Then we reported our first randomized trial because we want to really look at from a scientific basis. And probably you already know, after this randomized trial, this procedure start to be being performed in many countries, and many good results, over 1,000 cases in several centers in different countries confirm the procedure, and if so, approve the procedure. Then in 2020, the second randomized trial coming from France, the Omega trial. I think this trial provides more evidence to showing OAGB is not inferior to the RIGB. And we also report our 20 years experience in 2021. So this year, I think ASMA is finally approved the procedure, and this is a great support of this procedure. Then the second, we look at the evolution of the technique. I think from original MGB is a loop anastomosis, gradually to the one anastomosis. Then we call it recently as the OAGB in situ because we do some modification in further. So look at the past 20 years. In the first 5 years, we do NGB like the original technique,
and use the 5-pole methods. Then in the next 5 years, we try to adjust the limb because we are facing the BMI from 35 up to 80 or 70. We use the fixed limb length. It sounds not a reasonable idea. So, and we also use a Getry tube because the sleep concept, we need to control the size of Getry tube. And also we find this procedure is good in diabetes remission in the second 5 years period. Then the third 5 years, we improve our technique by reinforcement, stabilizing suture, and technically proximal limb higher, and move our osmosis to posterior wall, and also use reduced pole technique in this procedure. Then in the last 5 years, we start to realize the small bowel varies quite different in different patients. So when we tailor our limb, we also need to make sure how much we left behind. So this is the evolution of the technique in my past 20 years. And now we look at the evidence of this procedure up to now. I think the most of the evidence support this is a low risk operation, of course. 2 randomized trials all show the same result. And in our series, we can see the complication rate at the beginning is 1 to 2% major complication rate. It's already half of the standard Roux-en-Y gastric bypass. And for now, we can doing the major complication rate less than 0.5% in the recent 5 years. And to furthermore, in recent 3 years, we're doing a OAGB in 0 complication rate up to now. So this procedure can be done in quite safe situation. And it's a better weight loss especially compared to Roux-en-Y gastric bypass. This is our 15 years result. The Roux-en-Y gastric bypass had a similar weight loss comparing to the sleep, but the OAGB always have around 10% better total weight loss comparing to the previous 2 procedure up to 15 years. And also in the supermobile obesity, it provided a better weight loss comparing to Roux-en-Y and the sleep gastrectomy in meta-analysis. And the third advantage is less intestine obstruction. I think the jejunal osmosis is always the Achilles of the Roux-en-Y gastric bypass. So you averagely expect a 4% in the lifetime of the RI patient to have intestine obstruction problem. So it's always a cause of chronic abdominal pain and some patient in years because we manage the small bowel. And more importantly, you can see the recent report about the mortality, cardiovascular mortality comparing the sleep and Roux-en-Y gastric bypass. Sleep has only a marginal effect comparing to a control. And the significance is quite significant in a gastric bypass procedure. The gastric bypass win the sleep in diabetes, cardiovascular mortality, and the chronic kidney disease instance. However, the Roux-en-Y gastric bypass has a more complication in the intestine, so the patient require more endoscope comparing to the sleep. So in between this, OAGB probably can have a better performance than this high complication problem. So the fourth is the better diabetes remission in the OAGB. When we look at the sleep and the gastric bypass patient, on every patient category, we divide the patient according to our ABCD score. You can see a gastric bypass always had a better diabetes remission than the sleep gastrectomy. When we specifically look at the OAGB and versus the RIGB, OAGB again had a better diabetes remission compared to the RIGB. And this advantage is especially in a low BMI patient. When we categorize a patient according to a BMI, we can see the significance coming at the BMI lower than 30. So this is better for metabolic surgery. And if we categorize a patient by ABCD score, as mentioned in the early morning Kasama's lecture, we can see in a low ABCD score patient, we need a bypass procedure with a long BP limb. This is a model analysis to analyze the different procedure according to ABCD score. You can see in good ABCD score, the
diabetes remission is always higher in different procedure, but across the ABCD5, you can see a drop of the efficacy of all the procedure, especially the sleep gastrectomy. So the bypass procedure probably is a choice of treatment in those patients with diabetes. Of course, OAGB has its controversial and a disadvantage. The first, of course, is the issue of bioreflux. But we think bioreflux most of them can be avoided if you modify your technique and you keep the foot string smoothly going to the efferent loop and anchoring high the efferent loop. Most of the bioreflux can be prevented. In our series, the overall revision rate is 5%, and you can see most of the revision in the first 5 years up to 11.5%. In recent series, I just mentioned the revision rate is less than 1%. And most of the revision is due to malnutrition. Actually, only 22 patients is due to reflux, and half of them is due to bioreflux. Another disadvantage is long-term malnutrition. This is a point we cannot be avoided. So the first is anemia incidence will increase from around 6% to post-operative around 30%. But look at the sleep, blue-eye gastric bypass, all have a similar question. So this is one of the side effects we need to take care of the patient. The second is vitamin D deficiency. You can see 20% of the patient had this problem before surgery, but after surgery, OAGB has the highest incidence of secondary hyperparathyroidism. That means some malnutrition, vitamin D or calcium deficiency. And for RUI is around 1/3 of the patient. And there's quite less in other restrictive procedure. So this is the point we need especially take care of our patient. Another is the protein deficiency. Before surgery, 0.5% had this problem due to the problem is the albuminuria or liver cirrhosis. But after operation, it's about 2% of patients will have a protein deficiency. And the highest is, of course, OAGB is around 2.8%. That's why we have a protein deficiency so high in our data. That's because we tailor our limb. Because as I mentioned, we want to treat different BMI category. So we had a good result if we tailor the limb longer in supermorbid obesity. But on the contrary, we forgot the small bowel. Some patients had a short bowel. So in our study, around 10% of the patients have a short bowel, small bowel length 6 meters. This group of patients will have a protein deficiency if you extend the BP limb. The series you can see in other series, when you use a routinely longer BP limb to 2.5%, you had a better hypertension, diabetes remission rate, but you paid a lot of price in protein deficiency. The incidence increased dramatically because we see the bowel length. So 10% of the patient probably have a protein deficiency if you extend the BP limb. So in our series, 19 patients have a severe protein deficiency. We need to go to revision of the patient, and we can find they all have a short bowel length, and the common channel become less than 3 meters. So we change our policies since 2014. We measure all the small bowel and make sure our common channel between 4 to 6 meters. Then we can find we really decrease the malnutrition complication. Not only anemia you can decrease, also the secondary parathyroidism you can decrease. And especially for the hypoalbuminemia, you can decrease the incidence from 2.8% down to 1.5%. So you can dramatically reduce the incidence of malnutrition if you routinely measure the small bowel and know how much you left. However, the last disadvantage is not avoidable in any gastric bypass procedure. That is the gastric cancer risk in some area with high risk. So the only solution, I think, is the sleep plus procedure if we can consider. In this morning, we had a good symposium about this procedure. My personal belief is we can consider sleep plus a bipartitional. Use a single osmosis technique we use in one osmosis gastric bypass. That is a longitudinal osmosis on posterior wall.
probably we can have a advantage of this and avoid the side effect of this procedure. So what about the future? I think since the ASMBS approved the procedure, I believe the procedure will continue growth in our surgical landfill. And this is the data from China. They start to do the from 2019, and the case number increased also quite rapidly. The NCS, before the recognized this year, they already have a 0.7% the case that in 2020 statistic. So we expect a rapid growing also in state. So in the last, I was showing our most update reduced pore transumbilic two-side technique we routinely use for our RIGB patient, and we can also use in our OAGB technique. So let's make a procedure less invasive and with the same result. So from the first cut, we can use the technique from umbilics. It is a very good angle to perform the sleeve gastrectomy as well as OAGB, and create a long gastric tube all along the posterior wall is very important to lysis all the adhesion. So you can control your gastric tube not distort and symmetric on the anterior and the posterior wall. We still use 36 to 38 Puji. And the technique, I think, is quite similar to the sleeve gastrectomy. Once you have the first two cuts and all the way to the EC junction. Our technique is still to routinely dissection the fat pad because we need to control the gastric tube fit. So this is to create the last hole to perform the last file. And we leave 1 to 2 centimeters away from the EC junction. And in our technique, we still routinely protect the stable line, use a 0.0 legs suture all the way down. I think this can avoid about 1% the leakage rate and the bleeding instance. So we still use this technique. And the anastomosis created on the posterior wall of the gastric tube. And we measure all the small bowel and we make around 30% bypass, make sure the common length is enough. Then we do the anastomosis. The size is exactly controlled around 3 centimeters to 4 centimeters. I think most of the mechanism of this procedure is coming from restriction from the gastric tube rather than anastomosis. This is a quite different concept from the lower gastric bypass. In lower gastric bypass, anastomosis size is very important to maintain a sustainable weight loss. Then after anchoring the proximal loop, we fix the gastroenterostomy back to the entrance. That is where you cut the gastric tube, you put it back to the normal anatomy. So this is a final job. So ladies and gentlemen, my conclusion about the past 20 years, what we learned is OAGB now is the ideal bariatric metabolic surgery after 20 years evolution. And I believe it will replace IGB in a significant portion soon. Thank you very much.
Okay, thank you very much, Dr. Wei Jie. Does anyone have any questions so far? Yes, Doctor?
Thank you, Dr. Prof. In our experience, we started one anastomosis gastric bypass after biliopancreatic divergence Scopinaro technique. We started in 2009. We start with the same standard, 200. But after maybe 100, 200 cases, we adjust the biliary limb according to the patient, not the BMI and the 6. Nowadays, we don't go beyond 200 whatsoever. And it started 150 for diabetes and 160, 65 for female, 170 to 180 male according to BMI. Our revision almost due to gastric ulcer 1 or 2 cases, but we didn't have problem with the biliary reflux. very, very minimum, symptomatic, not even if we have that, we just divert the bile down to 60 centimeter. Our result, weight loss is excellent, quality of life is very good. This operation accepted by our community so much. At the beginning, when I offered them this operation, all ran away in 10 years back. Nowadays, they come to the clinic and asking for this procedure instead of sleep. So as you mentioned, it is very good operation, getting more popular in our country and with a very good result until now. Thank you.
Thank you for your experience. Yes, I think most of surgeons have his own preference. My preference is this procedure. The main reason is it's reversible, because in this morning, I think the one slide showing what is ideal bariatric surgery. Yes. Now we have so powerful drugs. Then we needed to think about, do we need to cut the stomach for a patient if it's really necessary? This is a non-reversible procedure. So this is a philosophy, yes. So I personally like this procedure. Most of the reason is it's reversible, yes. So.
Okay, thank you. No other questions? If not, thank you, Dr. Wei JD. And for our next speaker, we have Dr. Peng Zhang.
Hello.
I think Professor Zhang is from the friendship of Beijing, and he is a director of the metabolic surgical unit, and he cannot present on site, so his lecture was given us online. So please play the video. Thank you.
To join you guys. Hello, everyone. My name is Peng Zhang from Beijing, China. I'm sorry I'm not able to come here to join you guys due to the travel restrictions in our hospital. Thanks again for the invitation from the Congress. So today I'm going to talk about development of national quality training and accreditation programs for OAGB. So this is the background of OAGB. The OAGB was original from the 1967 Professor Mason's group gastric bypass. In 1997, Professor Rutledge developed a procedure called mini gastric bypass. And in 2002, Professor Garcia Caballero modified the mini gastric bypass to make it as a one osmosis gastric bypass. The IFSO has published a few versions of the position statement on OAGB. The most recent one was the 2021 version that mentioned that OAGB as an approved identifier for this procedure, and this outcome from OAGB are promising, at least equivalent to other procedures. And further, as a primary surgery, OAGB has better weight loss and comorbidity reduction and fewer complications, and also perform as a revision of procedure, which is also give an outstanding outcome. And it looks like bioreflux does not seem to be a major concern, and still long-term nutritional deficiency is a concern. So patients need to be monitored in the long-term follow-up, strongly encouraged. And in the ASMBS review article published in the 2018, mentioned that OAGB has a relative short operative time and a low complication rate and excellent weight loss outcome. But evidence level is low, including most cases were retrospective and a lack of long-term follow-up. And long-term nutritional deficiency and long-term carcinogenic effects still concerns. And only prospective studies with long-term follow-up can alleviate these concerns. And we all know that earlier this year, in May 2022, USMBS finally endorsed OEGB as an approved procedure. Based on our Greater China Bariatric Metabolic Surgery database, the number of OEGB occupied about 2.2% of all procedures in 2019, and the 1.7 in 2020. In 2021, about 3.5% of procedures were OEGB. We also acknowledge that there are some concerns remaining, including the specifications of surgery design, for instance, pouch size, length of BP length, and also the size of the gastrointestinal stoma. And long-term safety concern need to be addressed, including nutritional deficiency and bile reflux. And also we need to consider how to position OEGB, including patient selection of also choice of procedures. And we still have some questions to be answered, including the following. Number one is bile reflux a real concern? And then the ideal length of BP length, and what's the ideal pouch size and the ideal size of gastrojejunal stoma. And also we need to answer the question whether OEGB is better for type 2 diabetes remission than other procedures. So we are now drafting our national position statement on the OEGB. And first, we try to standardize OEGB procedures in China. In this statement, we mentioned that BP length should be 200 centimeter if the total bowel length goes over 500 centimeter. And if the total length is less than 500 centimeter, we should keep at least a common channel of 300 centimeters. And when we use a linear stapler for the gastrojejunal anastomosis, the diameter should be 3 centimeter, and also use a 36 French gastric tube. And also we try to standardize the OEGB training. We developed a structure training project we call National Capability Development Project in the infrastructure of Chinese College of Metabolic and Bariatric Surgeons. Actually, I'm the treasurer and the secretary for this organization. We developed an official video textbook. We developed a didactic training, tissue lab, cadaver lab, and also the OSCE's exam, and then the certificate criteria. So this agenda and pictures from all our training. And also we try to develop our nationwide quality accreditation system. This system is under discussion now, including the 8 dimensions. The first standard is whether the program gets support from the hospital academy or not. So we divide all centers into 3 categories, including participating centers, accredited centers, and a center of excellence. So the first standard is academic support. This standard is including surgical practice and the volume. And then the third standard is surgical team and the multidisciplinary team. And then the fourth standard, including facility, equipment, and instruments for the bariatric surgeries. And then the standard number 5, including the appropriate SOPs, clinical pathways, and the checklists. The number 6, including the data collection and the report. Then we also require personnel training and continued medical education. And for the Center of Excellence, we also require these centers need to have academic research program. And besides that, we also develop data registry system, and we call that Greater China Metabolic and Bariatric Surgery Database, GCBMD. We encourage each center to report their clinical data to our database, including patient information and operation information, and also short-term and long-term clinical outcomes, especially adverse events. And currently, the database was started in January 2018. Currently, there are 21 out of 31 provinces in China, and also 78 centers join this database. We published the annual reports starting from 2018, 2019, 2020, and 2021. And this annual report has become the top 10 scientific achievements of medical area, and it's only one awarded in the surgical field. Besides that, we also know that a trial is very important, especially randomized control trial, which give us the highest level of evidence. So there are currently about 10 RCT published on the OEGB. There are only 2 studies compare OEGB versus the benchmark procedure Roux-en-Y gastric bypass, including the 2019 Omega trial and the 2005 Professor WGD's trial. So the WGD's trial, which was published on Annals of Surgery in 2005, they compared the Roux-en-Y gastric bypass versus mini gastric bypass for the treatment of morbid obesity. It's a prospective randomized control trial. The conclusion is that both procedures are effective for obesity with similar results for the resolution of metabolic syndrome and the improvement of quality of life. And sounds like OEGB is a simpler and a safer procedure that has no disadvantage compared with Roux-en-Y gastric bypass and 2 years follow-up. And then literally, in France, they did a trial compare 2 procedures called Omega trial, which published on the Lancet on 2019. The conclusion from that multi-center trial was OEGB is not inferior to Roux-en-Y gastric bypass regarding weight loss and metabolic improvement at 2 years after surgery. But OEGB has had higher incidences of diarrhea, steatorrhea, and nutritional adverse event, and suggesting that still a malabsorptive effect. And even those two trials were designed for the weight loss, but we see some information that probably OEGB is better than the Roux-en-Y gastric bypass for the type 2 diabetes remission. So this gives us some opportunity to do some more RCTs on OEGB, compare OEGB versus Roux-en-Y gastric bypass. The first reason that Professor Lee's study could now be renewed after 17 years because that was published 17 years ago. We now have some updated surgical techniques, going to do that trial in the fashion of multi-center. And also we can update the hypothesis focus on the type 2 diabetes cure rate instead of the weight loss. And also Omega trial can be supplemented with the new trial can focus on the diabetes treatment as primary endpoint and focus on low BMI obese patients. And we know that Omega trial was a non-inferiority trial, so we can do another superiority trial. So we designed a trial called One Osmosis versus Roux-en-Y gastric bypass for diabetes remission, which is a prospective multicentric randomized superiority trial. We call that ORDER trial, ORDER, ORDER trial. So there are 2 groups. Each group had going to have 124 patients. So the hypothesis of the trial is that OEGB is superior to Roux-en-Y gastric bypass in type 2 diabetes remission. And the primary endpoint, we not use the weight loss, but we use a successful rate of biochemical resolution of diabetes at 12 months as measured by HbA1c less than 6% and fasting plasma glucose less than 5.6 millimolar per liter without any diabetes medications. And this is going to be a superiority trial, and the margin is 5%. So we in the Beijing French hospital is a leading center for this trial. So we also have 10 centers from mainland China, Hong Kong, Taipei, and also Singapore. We invite a few senior consultants, including Professor Scott Shikara from Harvard University and president of IFSO, and Professor Maud Rabbi from Lyon, France. She's a PI of the Omega trial, and also Professor Steve Gramble from Duke University. He's a professor of biostatistics, and also Professor Wei-Jie Li for this trial as a consultants. And this after rounds and rounds of discussion on the protocol, we finally finalized the protocol and published on the BMJ Open just a few months ago, and also registered this trial in the clinicaltrial.gov. And we already started enroll patients. Besides that, we also we do other trials for for instance like the bariatric surgery, including Steve, gastric bypass, OEGB for NAFO, fatty liver disease. And it's also multi-center trials. I'm going to publish the result very soon, so we know how OEGB's outcome on the fatty liver disease. So this comes to my summary. Not only in China, but globally, the number of OEGB will continue escalating. And we need evidence-based standardization, including the procedure design, training, accreditation, and also we need to collect more evidence by the data registry, not only the short-term outcome, especially we need some long-term outcome over 5 years. And also we need to collect more evidence, high-quality evidence by doing clinical trials in order to optimize the procedure and in order to better position OEGB in the arena of the metabolic and bariatric surgery. All right, thank you so much. This is my talk. Look forward to see you soon offline, very soon. Take care.
Okay, thank you very much. But since Dr. Zhang is not here, we might not be able to entertain questions, but we'll move on to our next speaker, Dr. Mohit Bhandari. Oh, Dr. Peng Zhang is here.
Yeah, I'm online. Hi.
Does anyone have any questions? Thank you, Dr. Zhang, for that wonderful presentation.
Thank you.
Okay. Okay, so we'll move on to our next speaker, Dr. Mohit Bhandari. Can we have the CV, please? Okay, so Dr. Bhandari is the founder and the director, chief surgeon of the Mohawk Bariatrics and Robotics, the pro-chancellor at the SAIMS University. He has the rare distinction of performing the highest number of bariatric and metabolic procedures in the Asia-Pacific region. And he has currently done more than 18,000 procedures and is the pioneer in the start of the robotic surgery in the country and was the first surgeon to perform the robotic duodenal switch. He is also in the Asian subcontinent. So everyone, Dr. Bhandari.
Thank you so much for this very kind introduction. Can I have my slides, please? Slides. Okay, so this is interesting. Professor Wei-Jie Li wanted to talk about one of the most controversial issues as to how to decide whether we want to do a conventional gastric bypass or we would want to do a one anastomosis gastric bypass and how to select the patient. These are my disclosures. I worked with Professor Kobe. He was consulting me. This point, I'm working with Professor Gelbao Neto, and we developed a very good department of bariatric endoscopy. So if you want to learn that specialty, do come to Indore in India. We do a lot of these training programs. This is my case mix disclosure. We have done close to 18,000 bariatric procedures. I have very good amount of experience with sleeves, bypasses, and one anastomosis. So I think I would do justice to this particular topic as to how I choose a sleeve, how bypass, and how one anastomosis gastric bypass. And I'll simplify it for all of you. But before we talk about that, this is what I want all of you to know. What are the advantages of the two procedures and how we determine what to do. But this is very important. I saw Professor Wei-Jie Li's beautiful video of mini gastric bypass. Now, necessarily, I may not do a mini gastric bypass like Professor Vijay Lee does. It might be an entirely different surgery. And when we compare my surgical procedure, or maybe somebody sitting in the hall with Professor Vijay Lee's, these two may turn out to be two entirely different procedures. So how do we compare them? So the first and the most important thing is that we need some technical standards. So if I'm trying to compare a study, or I'm trying to compare two procedures between two different centers, I need some technical standards as to how I am performing them, what sort of limb lengths I have, what's the volume of my pouch. And we did all that exercise long back, and there were a lot of these, and we published this. So when I'm talking about the gastric bypass, we are talking about a very specific entity where the experts have said, okay, this is what is the technical gastric bypass means. And when we talk about one anastomosis, we are talking about that's the pouch volumes, that's the anastomosis, here is the limb length. And now let's compare it between different surgeons. So this is a standard Roux-en-Y gastric bypass. You see 120 centimeter of a roux limb, around 80 centimeter of a biliopancreatic limb, 2 centimeters, 1 to 2, depending upon different surgeons in the hall, of a gastroenterostomy. And if we see a mini gastric bypass or a one anastomosis, whatever you call it, it's a 15 to 18 centimeters of a pouch length. And we have necessarily standardized it. It's voted by across 40 experts who did mini gastric bypass or one anastomosis, that 180 centimeters is that safe limb length, which all of the surgeons should be doing, around 4 centimeter of gastroenterostomy. So when we compare these two procedures, we find that one anastomosis gastric bypass has that advantage to provide to your patient of being a non-obstructive sort of a restriction. Whereas Roux-en-Y, I would still say it's a restrictive operation. I never put it into the category of malabsorptive operations, because we already see that 80 centimeters of a BP limb, it's not malabsorptive. Most of our patients have constipation after a Roux-en-Y gastric bypass. So these are the two different procedures we are trying to compare. Now, how to choose as to what procedure should be offered to which patient? Let's first understand one procedure is purely based on the concept of a non-restrictive obstruction. The other procedure is pure restriction. So please do not consider a gastric bypass as a malabsorptive procedure. Now, let's talk about the power of OAGB. It's short learning curve, high efficacy, easily reversed or revised. These are different publications done by different gentlemen. Very low risk operation, good resolution of comorbidities, high level of patient satisfaction, very negligible internal hernia. It not say that there are no internal hernias. And almost all the series published by Vijay Lee, Carbajo, Musella, or Jammu says that they have good results, and when they compared it to a gastric bypass. Now, when you see a procedure so similar to gastric bypass, how do you choose between the two procedures? I mean, everything about the procedure is good, except for the concerns about very high incidence of marginal ulcers, malnutrition, gastroesophageal reflux causing cancers, dumping syndrome, diarrhea, and steatorrhea. Now, how do we choose? So we devised a very simple algorithm with Professor Phoebe. This algorithm was devised because when at our center we were performing all the three procedures, a sleeve, a bypass, and a one anastomosis, everybody who came to our center as an observer asked us this question: why do you do all these three procedures? That was the first question. And the second question was, how do you decide as to when you would offer a sleeve, when you would offer a bypass, and when a mini gastric bypass? And the third question, whether the surgeon chooses the procedure or the patient chooses the procedure. So I have the answer for all of you, very simplified way. We're going to do a one anastomosis gastric bypass when the duration of diabetes is more than 5 years. Our hemoglobin A1C is more than 8. A poor stimulated C-peptide, and patient is on mandatory usage of insulin. Makes a very good case for a one anastomosis gastric bypass. We do it at almost all ages, particularly when the BMI is more than 50. Very, very high risk patient who requires short anesthesia time. We published our anesthesia time for mini gastric bypass is 38 minutes on an average across 4,000 cases, which includes the skin closure. So that's a big advantage. Very easy to perform, best tolerated by non-vegetarian patients. But yes, a caveat here, gastroesophageal reflux disease and liver cirrhosis are very gross contraindications for us. And I think it should be for everybody in the hall to perform a one anastomosis gastric bypass. The patient should be very inclined to come to you for a follow-up. because it's a malabsorptive procedure at the end of the day with a BP limb of 180 centimeters to anybody in the hall doing more than 200 also. And they should be able to afford the cost of the supplements. I know when I talk about this in the Western world, they don't agree with me, but in India and specifically in Asia, we should always ask the patients, can you afford the cost of the supplements? It's a very practical point. So these are when you would perform a OAGB or a mini gastric bypass. Now, when do you do RYGB? I was hearing to Professor Vijay Lee's lecture, and I think yes, it's going to become an extinct entity in times to come. But the RYGB still has its own set of problems. There are internal hernias, GJ side stenosis, because we trying to make it more and more and more restrictive. And if you put a band, obviously there are band related complications which we have reported. So this is our algorithm to perform a conventional gastric bypass. Now, what are the, again, can be done on all ages. Now for diabetes, we sort of decided that anybody having a duration of diabetes less than 5 years with a good stimulated C-peptide, not on insulin, and hemoglobin A1C less than 8, gets a gastric bypass at our center. So pretty much simplified it. Patients who have gastroesophageal reflux disease, absolutely a gastric bypass. It's gold standard for patients with hiatus hernia. We would like to ban all our gastric bypasses because I have a lot of data that they work much better at 5 years as compared to the non-banded ones. And vegetarian patients. So this is what I tried to simplify it, narrowed it down to answer the question which Professor Lee wanted me to answer. When do you do a gastric bypass? When do you do a mini gastric bypass? Anybody with bad diabetes and no GERD gets a mini gastric bypass. Reasonably controlled diabetes, GERD gets a gastric bypass. It's a very simplified way. I know, should you be doing a bariatric operation because that's what your patient wants? I would say absolutely no. Absolutely no. Try and put this algorithm in front of your patient. It's very logical. Why do you want to do a hiatus hernia? Why do you want to repair, operate a patient with a large hiatus hernia with a mini gastric bypass? I mean, when you have a Roux-en-Y gastric bypass available, I mean, this is what my answer would be. And so we developed this algorithm as to how we're going to offer the procedures to our patients. I've already said, this is our own, you can decide it on your own, but this makes logical sense to us. Less duration of diabetes, GERD or hiatus hernia, vegetarian patients should not be smokers because they have higher incidence of marginal ulcers, can have a history of alcohol intake with gastric bypass, does not matter. Have NASH at surgery or no cirrhosis, likely to come back for follow-up and as a revision procedure. Similarly, for mini gastric bypass, again, all this, very, very important factors to consider, and then only you should offer that procedure to your patient. So this is what we published, the 5 years data at our center. When we compared Roux-en-Y with one anastomosis gastric bypass, again, every paper you will read would say mini gastric bypass is great, but has high incidence of nutritional deficiencies. Now, if you have the kind of appetite to manage your patient with nutritional deficiencies, go ahead and do this procedure with obviously strict contraindication should be followed. Again, the same result, same sort of outcome, better diabetes resolution, better weight loss, but somewhat more nutritional deficiencies. That's the data from our center, over 4,000 cases. Again, the real winner or the true winner here is one anastomosis. Less amount of weight regain over a period of time. You see less than 50% of patients with less than 50% of weight loss at 5 years at 21% in a non-banded gastric bypass. That's a big conclusion, coming from this paper. And mini gastric bypass, just 5.8%. So that's pretty much giving you the message that over a long period of time, mini gastric bypass maintains that weight loss as compared to a non-banded gastric bypass. Again, almost similar comorbidities resolution. I would not say too much of a difference, but all the reds in the entire block in a busy slide would tell you much more deficiencies, much more anemia in one anastomosis as compared to gastric bypass. These are the series. My results are comparable to everybody published across the world. I'm not going to go into the busy slide, but I would conclude by saying both the procedures are good. Choose an algorithm for your center, how you want to manage, what's your social profile, what's the affordability and follow-up rate of your patient, and then you can follow. This is my guide. I'll put it on the WhatsApp group as to how we choose for sleeve, how we choose for bypass. You can also take a photograph if you want to. and how we choose for the one anastomosis and revision operation. So I'll share it on the WhatsApp group. Thank you so much.
Okay, thank you very much, Dr. Bandari. So anyone has any questions?
Thank you.
Can I ask you one of question?
Yeah,
Mohit,
yeah.
congratulations for your very informative lecture. I admire you have done so much work, but you make things a little complicated. You may raise a band rule on why gastric bypass. Do you really think it's necessary for, and what kind of situation you do a banded rule and why?
So I don't think a conventional Roux-en-Y gastric bypass is a very good operation in terms of weight loss maintenance. We have a lot of weight regain, and the data shows that it's 21% patients with less than 50% of excess weight loss at 5 years. And we published that data in SORD. I don't think it's a good operation if you have almost 25 to 30% of your patients coming back with that much amount of weight regain. I never find it with mini gastric bypass. Now, why do I add a band? Because it prolongs my weight loss maintenance. But yes, band would add a little bit more reflux, a little bit more complications like band erosion and several of them, which if I can manage, because we have a composite setup which has bariatric endoscopy and a lot of experience, but yeah, it's not good for surgeons who do not have that kind of backup. I agree with you.
Well, congratulations on great numbers, and you write very well and you present very well. You mentioned that people have to afford your procedure and where you operate. Sorry, I have to bring this back to its home. So you do a procedure that takes 1 gun and 4 reloads, $2,000 or whatever rupees are, and then you add a tiny zip tie for another $2,000. Do you think that makes dollar and cents sense?
See, the problem here is that weight loss maintenance is the issue. And if we do not have weight loss maintenance without putting in a band, these patients, they go in for a revision and spend much more amount of money, later on. Yes, the cost of supplements would be much less as compared to what you are talking about. But there are 2 different issues. Cost of supplements for patients who have done mini gastric bypass versus cost of getting another surgery done, because you have had a weight regain with conventional gastric bypass, are 2 different issues according to me. I put in a band on a gastric bypass, and I would prefer to do it because my data suggests that these patients, they maintain their weight. We have 10 years data now, so I'm more confident there. If the patient would say, no, I don't want a band, and the patient does not have a reflux or no liver disease, I would definitely go ahead and do a mini gastric bypass and say that don't put in a band, don't get a foreign body in, don't add that extra cost, get in a mini gastric bypass and you can save that cost. Absolutely. But if I have a patient who has liver disease, if I have a patient who has severe GERD, I would not do a mini gastric bypass on that patient. GERD and severe liver disease had me in a very tight spot couple of times. 3 of my patients who had mini gastric bypass with severe liver disease have landed up at large liver transplant centers for this problem, and they blamed it onto me. It gave a bad name to me despite doing a very good job. I had to reverse those patients free of cost and send them back for a liver transplant. So my message is that there is some learning out of these 18,000 cases. The wisdom is that mini gastric bypass is a fantastic procedure. Choose it wisely. Choose it wisely. You don't offer it to patients with GERD because they already have that bile coming in the esophagus, and you make it, you make it more problematic by, offering that to them. And don't do it on patients with liver disease. Rest all, you can do whatever you want to, because these are the 2 things where I'm extremely scared. And my own data from others. But rest, I agree with you. There's no need to put in a band. If the patient wants long-term weight loss, go in and do a mini gastric bypass. Thank you.
Okay, thank you very much, Mohit. Yes, we are a little run out of time, so I'm happy to introduce our next speaker. He's a giant star in metabolic surgery, Antonis Torres from Spain. And I really don't need to talk too much about you. Everybody knows you. Antonio is a professor of surgery in Campus University Medical Hospital, and he had been our president of IFSO and also the chairman of IFSO Board of Trustee. And he also involved in the event of the SADI procedure. So today we are very happy to invite Torres to talk about the comparison of OAGV and the SADI procedure. Torres.
So good afternoon, and first of all, I'd like to thank Professor CC1 as president of the IFSO APC chapter, and of course, Dr. Eduardo Oliveros for having me here and giving me the opportunity of sharing with you my thought about that. Also, the chairman, Dr. Wei Li, and the co-chairman, Michelle Liu, for having me here. So my topic is to talk in this country or area of the world, pushing for one anastomosis gastric bypass, to compare with studies. Okay, so this is my disclosure, and then disclosure of what we perform in our department there in Spain. Here you can see we do everything except one anastomosis gastric bypass. What is the reason? Because we consider it's more physiological to do the anastomosis a little lower. That's all. Summarizing my approach to the procedure. But anyway, let's go through the importance of preserving the pyrus. I think many years ago, 10 years ago, this guy, Mr. Roslin in New York, he said, the preservation of the pyrus valve would prevent dumping, and it may be a better physiological alternative for bariatric surgical procedure. And I agree with this statement made 10 years ago. Of course, here you can see the different pyrus preserving procedure, mainly of them. Here you can see the SADIs, the standard SADIs, as we mentioned this morning during the Dr. Kasama presentation. I would say the ASEAN SADIs. It means, a proximal duodenojejunal anastomosis. So the pyrus is important because it's the body's natural blow valve coming from the stomach to the duodenum. By keeping the pyrus preserve the dumping without any doubt. May also prevent other nutritional abnormality. We have to be aware that the proximal portion of the duodenum we can absorb calcium and iron. It's going to be important to maintain this part. Also may lead to better long-term weight loss. And sleep is working. All we agree here that many patients having sleep they are doing very well. Why to destroy it? I don't see the reasons. Because having the pyrus, you can preserve a partial, secretion of the chloric acid, pepsin, gastrin, intrinsic factor, and improve the absorption. As I mentioned, calcium, iron, and other things. Now, of course, we don't have very reflux because naturally, if we preserve this area, antro pylori, if some bile comes to the antrum will expel the bile as in our normal stomach. And, avoiding and excluding the proximal duodenum is also important from the many physiological functions, and mainly regarding the bile acid recirculation. Here you can see different options, the increasing the reabsorption of bile acid, being less time in the intestine, going to be faster, and a different composition, and the remaining bile acid, and of course, some changes in the microbiome can also influences, the function of this procedure. So answering the question asked, why pyrus preserving is important. Regarding the surgical technical option, some people, many people, some concern about, the duodenal dissection. Here you can see the differences between the duodenal switch, the standard one duodenal switch, and SADI are similar regarding gastrectomy, duodenal division, the gastric edge. The only difference we have to have a one-way duodenoileostomy. And we don't see the need of doing this one way because it was created by divert the bile in the old time for preventing or for treating the untractable duodenal ulcer. There is no other reason for performing a one-way in a duodenal switch. It was an historical approach from Tom de Mister in the US many years ago. And regarding the differences between the studies and the one anastomosis gastric bypass, here you can see the difference. Regarding the Buji performed the sleeve gastrectomy, we use a wider Buji than the one anastomosis gastric bypass. Regarding the length of the proximal lisocene bypass, only depending in the studies, depending on the length of the common channel, excuse me, I'm going to be between 150 to 300 in the standard, in inverted commas, one anastomosis gastric bypass. Regarding the left common channel, it's going to be important to be aware of that. It's going to be very important, that we know, the length of the common channel in the studies. We can extend 300, 350. I'm going to be depending in the one anastomosis gastric bypass, except in the situation that you measure all the bowel all the patients who were commenting this morning. The category, this procedure can be considered a percentile taking into account having a longer common channel hyperabsorptive procedure and non-malabsorptive. I think we have to delete of our brain the term malabsorptive. We are not doing performing any anastomosis so close to the ileocecal valve. And again, the clinical outcome, is similar to the BPDDS, a very superior to the runway I were commenting today. So regarding the technical point of the study procedure, here you can see, as I mentioned, we have to be aware, perform a sleeve gastrectomy over a Buji of 54, 18 millimeters, 1/8, and then, to perform the anastomosis. We started in 2007 performing the anastomosis 200, but we realized they're going to be too hyperabsorptive. This is the reason we changed our standard length of the common channel now is 250. Even more, we are now performing anastomosis to 300 in lower BMI patient and metabolic patient. But again, to reinforce the idea that not adding at the same time, a huge restriction and malabsorption. And here you can see, how we can, let me put the click here. I can, I don't see, it's gonna be, can I put I don't think I can do, oh yeah, I know, I see it there. Okay, I can see now, good. That is the way we dissect the duodenum. I think and any of you can be afraid about that. Here you can see how it's a very democratic dissection. Here you can see the gastrointestinal artery beating here, and you have to create a space to go downwards as much as possible. If you can maintain this duodenum, why not do that, the anastomosis here instead of upwards? We maintain not only the blood supply of the lesser curvature here to the right gastric artery, but also the vagus nerve preservation of the lesser curvature. And probably we don't know yet how important is the preservation of the vagus nerve. Is the hidden weakness in this scenario, because the vagus nerve connecting our brain with the bowel, something has to be a role on that. And there you can see, in this way, we are preserving, this this gastrointestinal artery. Of course, we don't divide it. We also are preserving as much duodenum, 3-4 centimeters of duodenum. And of course, we are preserving, as I mentioned, the vagal innervation of the lesser curvature. And here you can see some clip, regarding how we perform our sleeve gastrectomy using this Buji, going very close to the Buji. It's the same that you're using 34 French Buji and you go a little far away. And then, we perform our sleeve gastrectomy. We divide the duodenum. And, after dividing the duodenum, we perform, we will say, a very tension-free duodeno-ileal anastomosis. We can do hands-on, 2 layers, you can do a stapler, you can do robotic, you can do a very democratic way. It's a very nice, very feasible approach. And again, I think, very much more physiology. Okay. Going to the weight loss, I think, both procedures do a very nice weight loss. Let me share with you our last revision, 10 years of result. We recently publishing obesity surgery of this procedure. We started 2007. I mean, we have a huge experience. Here you can see the same weight loss, 78%, regarding the total weight loss, around 34% with a very nice BMI. And here you can see the number that this guy has published many years ago in 1998 regarding, the standard Roux-en-Y duodenal switch and how we can overimpose our result. Here you can see the weight loss in our 10-year result. 5 years weight loss, 38%, with a percentage of failure of 5.7. It means not getting 50% of the weight loss. 10 years, there's a little worse, 34 total weight loss, and percentage of failure of 11.6. 10-year result with the follow-up, I mean, about 78% of our patients. We know what happened in 79 every 100 patients. It's going to be very important to point out, to underline this important. Regarding the comorbidities, for example, the type 2 diabetes is going to be very nice, very similar to the, we say with long anastomosis gastric bypass, but here you can see our result, 5-year result. Here you can see how we have our patients were very metabolic. We have 40% of our patients were, under insulin before surgery. Then we have 5 years with no treatment, 76, 10 years, 61, with oral medication, 27, 10 years, 17, 5 years, and with insulin, 11%, 10 years, coming from 41%. Going to be very nice, but not only the quantity of how we control or studies or one anastomosis bypass controls type 2 diabetes. It's the way they control, preserving, this area, this antropyloric area, and and not, this is the wrong way, but it's the same with the one anastomosis gastric bypass. We are having less glucose variability. In this paper, it was published in 2000, I'm sorry, I did in the wrong way. I don't know what I did. Okay. In this paper, we have a look to the glucose variability. We compare 12 patients after Roux-en-Y and 12 patients after SADIC procedure. 5 years after the operation, having both groups, all the 24 patients, total control of the diabetes with a total remission. And here you can see if we submit the patient to a continuous glucose monitorization during 1 week with the device in the patient, we realize that the number of patients or the number of period of glucose level less than 70 is worse in the Roux-en-Y compared with the SADIC procedure. And the number of episodes of a normal glucose level was much better in the SADIC compared with the Roux-en-Y patient. And the number of episodes of hyperglycemic with a glucose level higher than 140 was worse in the Roux-en-Y compared with the SADIC. So you not only control the type 2 diabetes, the way we do that. This procedure without having the antropyloric area go up and down, up and down, up and down. And in the SADIC, on the contrary, the more stable. What about the complication? For sure, SADIC have been published in many papers just now that the anastomotic leak is less than 1%. There is no anastomotic ulcer at all, no bile reflux, no internal herniation, and no stenosis of the anastomosis. On the contrary, this is the paper we published in SOAR, in the multi-center study, having more than 1,500 patients. So regarding this complication, we have to admit that, comparing with the anastomosis gastric bypass, both procedures are reproducible, but, in the one anastomosis bypass, there is no pylorus preserving, can be some dumping syndrome, some hypoglycemic, hyperinsulinemic, biliary reflux, gastric cancer, minor ulcer, that kind of thing doesn't happen in the one anastomosis in a SADIC procedure. Regarding the dumping, the number are not very clear in the literature, but of course, if we don't preserve, this area, we can have it. There's no doubt. It's less physiological, I would say, at the beginning. Regarding marginal ulcer, there are some paper, the patient are there, if you are, putting in contact stomach and bowel and small bowel, we can have this opportunity. Again, preserving this area, this antropyloric area, we can have some bile here, but if you preserving the innervation and the blood supply of this part, the antro will expel the bile there again. Of course, the preservation is going to be important. I'm going to point out, it's not only important to preserve the duodenum, it's also important to preserve a little bit of antro for maintaining the functionality of this area. We have studied the disease in biliary reflux, comparing in after failure sleep studies procedure with one anastomotic path with our colleagues from Germany, from Dr. Martin Busin and the Professor Reiser. And we included in this study 42 patients in each arm, a very, all the demographic data are going to be very similar. And regarding the weight loss, going to be very similar, a little bit in favor of 3 years after the operation to the study, but no statistical difference. But the most important point we observed was regarding the adverse event of the patient. Again, the viral reflux, symptomatic viral reflux, 5% in SADIS patient, 26% in one anastomotic bypass patient. So, and another point, the quality of life. I must remind you that the obese patient, they like to eat. It's a very short sentence, but it's very important. So if you maintain as much stomach in the functionally, going to be much better for the patient. Here you can see a style regarding the quality of life. This data is coming from the Cornell University, Alphonse Pons, Michel Gagné, showing 9 years result regarding studying, some quality of life score. This is the F36. And here you can see how before surgery and then after 9 years, how, the duodenal switch patient at the end, SADIS is a modification of the duodenal switch, how regarding physical function, physical role, the body pain, general health, vitality, the social function, emotional rate, and so on. And also they study another quality score, life score, again, physical self-esteem, sexual life, public sphere, work in total before surgery, before the duodenal switch, and then in a physical way 9 years after the operation. So in the end, the SADIS procedure, I think we don't have to have fear about duodenal dissection. And I think, in my humble opinion, we have to have fear about this anastomosis that you saw during the video clips I already showed to you. And well, we are going to have a restart our biannual meeting in Madrid, next March, 1 to 3 Madrid. I know Spain is very far away from here, but if you want to go here, you will be more than welcome over there. Thank you very much for your kind attention.
Thank you very much, Dr. Torres, for that very informative talk. Does anyone have any questions?
I know I have a question. Yes, I agree with you. Your study looks like a very good procedure, but most of the advantage of Pyrus preserve is skeptic. So do you think there's evidence or comparison to really prove the value of Pyrus preserve? Yes, because in whip operation, the Pyrus preserve also bring more disadvantage in technique or short term. Yes. So do you think the Pyrus preserve is really matter?
The iron, you mean? The iron?
Iron.
Iron. Yeah, I agree with your talk, regarding the most important, nutritional problem we saw was the pseudo hyperparathyroidism. This is the reason we increased during our experience, the doses of calcium and vitamin D was almost double. But regarding the iron, of course, it's going to be important, to maintain as much duodenum as we can, because in this portion of the duodenum, iron will be absorbed. But anyway, we still have to supplement the patient, with iron. And again, in this surgical approach, in every bariatric procedure, I think we must follow our patient. The excuse of not performing one procedure because you are known to follow the patient is a huge mistake. You know what I mean? I'm doing sleep because my patient don't need any follow-up. I disagree completely with this. Or, to perform a wrong way because the patient without follow-up is doing well. I disagree with that. I agree with you that those patients we have to take care of what we learned in the past. Regarding the micronutrient issue, we already increased the doses of calcium, vitamin D, and zinc. The zinc also we saw in the long term are going to be a very, not important, but very significant deficiency long term. Thank you.
Thank you, Dr. Torres. Okay, in the interest of time, I think we'll have our last speaker, Dr. Ken Loy. Okay, so Dr. Ken Loy is from St. George Obesity University in Kogara, Australia, has achieved accreditation as a master surgeon in metabolic and bariatric surgery. He is an upper GI and bariatric surgeon and director of St. George Obesity Surgery in Sydney, and is the past chair of the RACS NSW and current treasurer of the IFSO APC. Dr. Ken Loy.
Thanks, Michelle. Got to update you. Yeah, I give my treasury job away. So I'm the president-elect, but it doesn't matter because we're all friends here. The most important thing is hopefully you guys are enjoying the conference. I knew when I do this, we're going to run out of time. And I think everyone's will be dying for coffee. So, and the talk is very puzzling for me as well, myself. The only thing I think I haven't do is I'm not operating as fast as Mohit. I'm doing everything those things that I can do, and my practice still evolving, even though I'm sort of getting older. So one thing you learn from the wisdom of getting older is you're getting slower. You have time to think, and you also learn from your mistakes. So those mistakes, I think, are the one that why we are here, that we want to share with you. In fact, the first OHGB I seen is Professor Lee when I was a young guy in Taipei 2006 when you're running your workshop. So this is not a new operation. So all of a sudden, why is it becoming so popular? At that time, you got a lap band fever. And then after the lap band fever finished, you got a sleep fever. Now, the OHGB suddenly become that. So I feel that it's like, you know, you've got the young boy band coming out. And when they get older, so this is the last concert that I went to see. So if you think about surgery, it's like going to a concert. The moment you buy a ticket, you're going to enjoy it. The moment you're operating on a patient or you agree to operating on a patient, then, or you choose to go to that concert, you're going to know what you're going in for. So all the talks actually has been given. So I'm just going to give you that. If you're also old enough to read literature, you can always pick fault on any single article and argue against or for it. So there's no correct answer you can hear. But I guess, you know, looking at things is that, would you get single anastomosis bypass on revision surgery straight up as an operation because you got a handful of, you know, band patients that you want to convert them? Well, 20% of mobility to us is probably a little bit too much I can take, because, you know, the moment that it's like, if you go to a concert, they don't do a sound check on the stage, you're going to have a problem. You're going to run into issues that your client or your concert goer is not going to enjoy your concert. So I think, you know, you got to pick your fight just like everyone is. And even though the show is good weight loss, I think there is enough evidence that you've seen that there are meta-analysis that are searching that they try to establish when you're going to see patients with GERD and etc. Because GERD seems to be the hottest topic now because of the amount of sleep we do. And nature-wise in Asian Pacific, we do see a lot of patients with reflux as well. So this operation is getting more popular in Middle East. Does it apply to us? Is it going to be a big volume for us? And the title here is Teamwork is Dreamwork. So I think surgeons have to be less self-centric. I think you got to think of either other patients or other people in your team that will suffer. So every time I do a bypass or, you know, or maybe a mini bypass or even a SARDI, I'm going to think that, well, my nutritionist is going to suffer because, you know, they're going to have more work to do and you're going to take care of the patient afterwards. So it depends on how complicated you want your life is. If you've got a big team like Mohit, then maybe you can do it. But, you know, if you're only a one-man person that is doing it, maybe not. So the de novo GERD, it is a problem, right? So, you know, you don't pick that patient with big hiatus hernia as you're summarizing from it. And so I think there are enough also evidence about comparing limb link, etc. as well. The Tehran people, even with them, try to compare that and showing that after 1 year, they almost as effective. So does limb link matter? It matters in a whole. It doesn't matter in that 20 centimeter difference, but it's matter as a percentage. So that's why the encouraging thing is nowadays, if you want to do a bypass, you need to estimate at least the total lymph link so you don't run into problem. So effectiveness, yes, but one thing I think about effectiveness is Antonio mentioned a very important thing about quality of life, because I think a lot of times is we do the surgery, you don't see the patient afterwards, and then you get a phone call or your nurse get a phone call about, oh, this is troubling and this is a problem. So you got to deal with the problem afterwards. So when you do your surgery, you think about what might happen next at your best of your ability, not just because my hero do this operation, my mentor do this, I must do this, because it may not apply to your practice and your cohort of patients. So there are enough evidence saying that, yes, the diabetic revolution is better. And we've seen that already. I'm going to skip through that so we can get a coffee. Mohit tell us that. And the comparison study is seen that all the time. It's a great study. I think when you're comparing long-term as well, the data doesn't lie, because long-term result is probably the one that you want to see as well. So clearly there's a difference. So why is it still only getting not popular? Stigma. I think we talk about stigma. You know, obesity is a stigma. Surgery got a stigma as well. This operation had a bad stigma to start with. So when we first start doing it, we've seen, you know, Rutledge, who is flamboyant and definitely different time doing this surgery. And then I've seen Professor Lee researching it. You know, this is like the polar end to end of spectrum. So that's probably maybe hold up the development of OHEB. And that's why now is the prime time. Am I a fan of the surgery? Well, you know, I think you couldn't be a fan of any single surgery, because you've got to have different way to treat your different patient, because you don't know what your patient is seeing next. So you try to guess what you can do, but the main thing is do no harm, I think. So comparison wise, compare and one anastomosis to Roux-en-Y gastric bypass, yes, bowel reflux. But then again, I think when you look at it properly, it may not be that significant. And there are studies also showing that, you know, even with small number, the problem is that once you had a procedure that is popular and you can try to apply to all different situations, and I think it's different. A primary one single anastomosis bypass is different from when you're converting that from a sleeve, because I think when you're converting it for weight regain and sleep, you are dealing with a different cohort of patient. The shape of the sleeve is different. The functionality is different. The way you're doing it, the risk of complications and the risk of non-compliance, et cetera, et cetera, et cetera. So I think you cannot just simply applying one thing to all of your practice. So you try and you can be successful if you want to, but that was quite surprisingly, major complication is quite high. So I think because you're dealing with a different stomach tube, and I strongly believe that the stomach tube is thicker, the patient are less compliant, and you're dealing with probably patients that are also maybe have underlying other issues that you don't actually learn. So you need to listen to your team if that is a suitable thing for you. And interestingly also, my friend Michael Booth in New Zealand, they're using the ring. And another thing that I think the puzzling thing is, you want to keep adding things on. I think the ring is a great idea. He's already tried it, but there's a number of explantation and the number of people taking PPI are quite high. So that eating into the quality of life, your study, you know, I think the ring itself, although give you durable results. So it's like when I'm seeing that concert, when you see fire, you know, it's very exciting. It's very hot. It gives you more excitement. But, you know, you see how far the team members standing, only the drummers in the middle. So, you know, he's the one that feeling the heat. So you know, we enjoy the concert. It's very exciting, you know, but don't just do that for the excitement. You know, you got to think whether you can pull it off safely or not. And interestingly, the same number of patients. So the overall complications, I think, is number-wise, is accumulatively. The longer you have the ring, the longer you're going to have problem. I personally not against the ring because I know the data on, you know, ring the gastric bypass and etc. But I think you got to pick your fight. Start throwing in things into the persons. You know, you got durable results, you got great numbers, and it all come back to one thing. every single row go back to Professor Lee, because I think, if you, not that we follow the worshipping what he did, but when you look at it from scientifically, but that only also applying on probably predominantly Asian population. So in country where I live in Australia, we've seen a lot of Caucasian patients, and we only have limited number of Chinese patients, and we have a lot of Middle East patients as well. So, I begin to mix based on what the data sufficient for you. And Mohit started coming up because you have the volume and you had the using it as a revision. I was going to ask him about whether he feel different than a primary surgery, but I didn't get a chance. We'll probably have to talk about it in tea time. So when you use it as revision surgery, I think you're going to cope with more weight regain, and you're going to have more chances of ulceration, because the shape of your sleeve where you constructed is different than a primary sleeve that you've seen Vijay constructed. So not to bore you with all the data because we're cutting it out. And I think, it's showing you that it is durable, long-term, short-term, but I think you can see also all the studies show almost equivalent or, resolution of comorbidity. And most of the study itself is only 1 year. So unless you prepare to be a surgeon for 5 years and retire, you got to think about if the patient going to come back to you, what you're going to do next. So big numbers, and they show that it's safe, but it's only 1 year. So I think, you've got to also look at that and give it a bit of time, listen to what other people say. Don't rush to be the first one that do it. And it rounding thing up to telling us that with the data itself, this is my ex-dietitian who runs study comparing actually, sleeve versus bypass surgery. It's not my patient. She went to different centers now. And they show that with the dietitians that they cope with is more amount of nutritional and possibly quality of life issues. So I think depends on where you're aiming at. For me, I think you've got to remember is teamwork. So I'm going to close it up and telling you guys that for my conclusion in my practice and level 4 evidence is, if you think about this type of operation, is why you want to do it. So, you got to give yourself reason why. And every time I think is important. So I got to show time up. So that's good. Perfect. So how you want to do it and how do you do it? You look at people that do it before and you try to replicate, if possibility, narrow tube instead, longer, starting from the antrum, that sort of things. And then when you want to do it is whether you want to do it or you want to do a sleeve first to start with, or you want to straight away go for it. So a lot depending on us, we say when the patient can follow up or not, but you hope the patient follow you up forever, but nothing is forever. They probably end up seeing another surgeon getting a revision. So I hope you enjoy, but you know what? The most important thing about concert is who you're going with. So I think that is actually the most important thing. So I hope that you enjoy the teamwork, because to be honest, I think surgery is about teamwork. That's why we are here for. And thank you very much for listening to this talk.
Okay, thank you very much, Dr. Loy. Any questions from the audience? Okay, if not, I think we can close. And may I call on the speakers to come up to the stage so that I can present to you your certificates.
And yes, Anthony and Mohit, is it? Come up stage, we need to present. And thank you, Ken, for save our time. I'm sorry we start late, so I think we're still in time to close the section.
Hi, Dr. Peng. It's so sad that you couldn't be
Hello.
here with us, but we would like also to present you with this certificate. And we hope to see you in the next face-to-face Congress.
Thank you so much. Look forward to see you soon.
Can we have some audio for Dr. Tang?
Thank you.
Okay, thank you, Dr. Tang.
Good afternoon. A quick announcement for our social dinner tonight. The meeting time is 5:30 outside the function hall. We cannot meet at the lobby. So 5:30 we meet here outside, and then 6 p.m. the boss will pick us up going to the dinner place at Intramuros. You will find your dinner ticket at the back of your badge. Put your name at the back of the ticket. No ticket, no entry. And this will also serve as our raffle for the raffle tonight. Please put your name at the back. Thank you.
announcements. For those who wants refreshments and cold drinks, they are available at the exhibitors hall. Thank you.
In Brisbane, Australia. Brisbane. Hello. How you doing? Yeah. You wanna start? You wanna start? Yeah, they will introduce the
Yeah.
first, yeah. So, and then we started, just started. Reza.
No, could you give us if you want the video to start, so I will ask my
Colleague to start.
yes,
Okay, I'll just say, can you start? Yeah, yeah, yeah. Reza? Yeah. Go outside and say, can everyone come in? I just do that, yeah. You can come to watch. Some more people, exactly. So. I'm patient Manila. When it all same groups, occasional bariatric. Division bariatric, occasional bariatric. I do both GIs, upper and lower, yes, both and lower. Is a laparoscopic lower surgery very popular? There's a lot actually. But more on about the coronation. So usually practice here as a general surgeon most of the time. So you only focus on bariatric? Yes, I started I trained in Australia between 94 and 99. But in 2000, I went to Edinburgh and London for 4 years, which was mostly HPD after GR. But the last year was all bariatrics. When I came to Australia, I initially did mix, like my first 7 years, mix of bariatrics and upper GR and HPD. I did a lot of different sections. Wow. And yeah, I did laparoscopic sections. And so, but then slowly that went down and bariatrics. Now I know about probably anything between 1200 and 1500 bariatric cases. And I just forgot I forgot the river and the other is called the bariatric. Yeah, so you must be operating every day. Yeah, I consult Monday and Wednesday morning, and rest of the week. Well, I don't operate weekends. The rest of the week I operate, and on Fridays I operate in parallel. And I have fellow. No, just assistants. Yeah. I don't know. It's all part of the practice. Yeah. So I was telling Waleed that on one Friday, between 12 sleep after, but only do sleep on Friday because it's easier for them to send home the next day. I think by up to 12 because the students finish by 2 o'clock. Yeah, really fast. We have a team that is doing that all the time. Oh, really? Yeah. I think what we went to get them. Ring the bell. Want to start? What we would like to have
let them all in and let them- Running out of time. Anyway, I think it's the last session. Kaya nga eh. Sabi ko, ayun yun.
Hello, everybody, and welcome to the last session. I guess everyone's waiting to party later. So this one is on revisional surgery, and we had hoped there'd be more people because we've got some of the best experts in the field out over here showing you some technical videos. We're going to start off with my co-chair, Reza. Reza is going to show you the revision of fundoplication to RYGB. Reza Adib is a well-known face in the field of bariatric surgery in Asia Pacific. He's the chair and of Center of Excellence in Metabolic and Bariatric Surgery at the Wesley Hospital, Brisbane, Australia. A member of the board of the OSANs, and he's studying in Australia, England, Scotland, France. Where have you not studied? Today, he's for more than 12,000 procedures. So please take it away. Yeah, thank you, Reza.
Thank you. I'd like to thank the organizing committee to invite me. It's my first experience in Manila, and I just love the place. I guess the thing about revisional surgery is that we eventually, all of us will have to deal with it at some stage, unless we have someone we don't like and we refer them to the person that we don't like. I run a bariatric practice that is around about anything between 12 and 1,400 cases a year. It's a busy practice. And a fair bit of my work recently has been revisional surgery. The other thing about my city in Brisbane is there is a lot of interest in anti-reflux surgery. One of our teaching hospitals, Princess Alexandra, just they published 8,000 cases of fundoplications. So statistically, Australians, 1 in 10 of them is morbidly obese. So you can imagine there's 800 out of those 8,000 that was morbidly obese while they were getting their operation. So there is a lot of revisions to be done eventually down the track for those of them who fit the criteria. I'll start. Can you run the video? I'll just chat as we're running the video. I've done about 33 of these. The highest papers are about 130 from multi-centers. So, oh, am I running the video from here? Sorry. Okay, I'll just get straight into it. Sorry, this video has been changed from a few formats, so the colors are not all that good. I always say in a revisional surgery, it's like moving in a very dark room. You go and put your hand somewhere that is safe. That's why I always say identify something that gives you stability. I like to start by the right crus. I identify the right crus somehow, and if you identify that, and then you can identify the esophagus. Once you identify esophagus, you keep away from the esophagus. Most importantly, get information what kind of a wrap this patient has had. There are so different types, especially where we come from. One of the hospitals likes to do a toupee fundoplication. They take a bit posteriorly. They do multiple sutures. The other one, plus the people in Adelaide, they love their anterior fundoplications. So it's so crucial for us to know what we're dealing with and trying to then undo very methodically. At every minute of the procedure, I want to know where my esophagus is, keep it on my side, because the idea of the procedure is to undo the wrap and bring at least 2, 3, maybe even 4 centimeters of intra-abdominal esophagus. I do undoing of the wrap with a combination of sharp dissection. And if you see that the wrap is disappearing posteriorly, you don't need to pull too hard, and you don't need to I don't try too hard to get to completely undo it, because once I get under into the lesser sac, starting making my pouch, I get a better view of that posterior part of the wrap. But the whole idea is that we can work in a broad space and try to sort of define the anatomy at every stage. We want to know what we're actually getting. It's very easy to lift off the pancreas, like when you're trying to get into that lesser, because you never know what they've used in the previous operation. So it's very important for us to have a approach a bit from the left side until we have secured the left cruise, a bit from the right side, above the right cruise, and eventually we'll try to get inside the pouch, start making the pouch. This part of the operation was very elegantly shown by Simon this morning. It's exactly the same thing, knowing that you could be lifting the pancreas up with yourself, you could be lifting the splenic artery. So we got a less sac approach to the posterior portion of the wrap. I should have called it of the pouch, of the wrap. And eventually, once we have a better position of where we can actually identify the left cruise from this side, and we can starting to see the posterior part of that pouch there, then safely we can fire one more stapler. I usually fire the staplers over 34 French bougie. You can actually see I have dissected wider, but I'm sticking right onto my 34 bougie and try to stay as tight as possible. All of that needs to be dissected out. So, like I said, we don't have to pull very hard from one end. I'll try to sort of eventually identify my left cruise in order to completely bring every part of that fundus back to where it belongs. And once I identify the left cruise from underneath, then I could just complete the procedure by firing the next round of the. As you can see, the posterior part of that wrap is now being identified and freed up. And now we're starting to see the left cruise. At every stage, my esophagus safely in my opposite hand. So I know exactly, I'm not pulling on the esophagus. I know that if it's a very frail person with a very atherosclerotic aorta, it's sitting right underneath there. Sometimes if you go through fibers of the left cruise, you just have to be careful what you're actually getting yourself. The other thing is where I come from, a lot of people have used a lot of mesh. So you have to very early in the pace identify, has this patient had a mesh or not? So at every stage, I stay fairly as firm as I can on a 34 French bougie. This is a second case. I'll just go straight. See, this is an anterior fundoplication. This is a few of surgeons in Australia followed one of our very good surgeons, Jacob, we know in Adelaide, that he published very well on anterior fundoplication. In this case, again, I've found my right cruise, staying very tight on my right cruise, getting into that avascular, hopefully, space and defining the anterior sutures. I know that in an anterior fundoplication, the most right-hand side of the sutures incorporate the esophagus. So I tried very hard to stay away from damaging the esophagus. Eventually, I get myself all the way around the clockwork at the top. Again, at every point, seeing where the esophagus is, trying to dissect at least a few centimeters of intra-abdominal esophagus. And the rest is more or less what we did before. You want to see where your left cruise is. You've decided you've dissected your right cruise. You want to see where your left cruise is. And at every stage, I'm holding the what they call the clockwork or the esophagus in my left hand, pulling it away from where my energy source is applying its evil. So at this stage, obviously we are starting to see a bit of that cruise. It's better not to expose any raw and red muscle. I expose a tiny bit of it at that, which is a bit technical fault. And once you can actually see that now my wrap is now undone, I am starting to see esophagus at the onto the right side, and I'm starting to see a bit of the phrenosophageal ligament or what's left of it that we are dissecting. If the hiatus looks very damaged and very sclerotic, and if it really looks like it's not going to be a good hiatus just to be repaired, I selectively use a mesh, a BioA, an absorbable mesh. As you can see, again, I'm trying to identify the lesser sac. Once I'm completely in the lesser sac, I don't fire ever blindly, because I've seen people getting themselves into the pancreatic tissue by accidentally lifting the pancreas. The rest is exactly like the last case, very methodically, knowing where your left gastric artery is, because a lot of the big fundoplication, the left gastric artery could have been moved and could have sort of you basically need to know where it is. Again, I'm looking for my left crus at this stage, trying to get all of that fundus into the left side so I can fire the rest of the staplers into making the pouch. Look, it's crucially important to understand that this procedure is being done for a benign condition. So no heroics. I have been getting a couple of pneumothoraces, which usually, by the help of your anesthetists at the end of the procedure can be, you never need to have chest drains for it. So I'm repairing my hiatus. In this case, this hiatus was really, as you can see, it was very hard. And this repair was just basically trying to set the scene up for using a mesh. You can see the length of intra-abdominal esophagus. If you agree with me, about 3 centimeters. I'm using a BioA mesh. Sometimes I use the BioA mesh, the bigger part of the BioA mesh posteriorly, sometimes anteriorly. So that big sort of a tunnel-like, I have been using that posteriorly recently. I think it actually gives it a better angle. I use glue. There are different types of glue. There's glue brand, or there is a fixate sort of a glue. I prefer not to stitch. I have seen tacks and stitches going into the pericardium. I do a 100 by 100 limbs, very standard. I usually put a stitch. As you can see, the top of my alimentary tract, foolproof. I usually have a stitch, and that stitch is my guide where my alimentary limb is. You can actually see, just technically, I'm just saying that I use that corner stitch to pull this. I use lubricant on my staplers. Lubricant is a very good thing to let your stapler glide in. And it's good to use, I close the mesenteric space in every case. I try not to put the mesenteric closure spaces on the serosa and get as close as possible, but not on the serosa. Just the case that we saw this morning. Colleagues presented with that very acute angle. Gastrojejunostomy, I use 2/3 of a 30mm stapler. Again, everybody else showed that. I got that. See that corner suture? I'm pulling it down with a completely lubed stapler. And then I use the corner suture to tie it to what's coming from the top. Always close the Peterson space. Same thing with the V-lock. In a very circular fashion. I almost use what the gynecologists use as a locked stitch, because this V-lock just creates a bit of a barbed wire for the small bowel not to get through it. So that's what I do. We have had good results. I mean, this was a video session. I didn't want to show the outcomes, but the overall outcomes, we've had one where I put my corner stitch to pull the rulum up. We had a serosal puncture to the point that my contrast swallow the next day showed a small leak there. But the leak was not from the anastomosis, it was from where I was pulling the suture. So I went and put a stitch in it. And apart from that, we haven't had small bowel obstructions from these guys. And a couple of cases of post-operative, one case of aspiration and one case of late bronchopneumonia. And these are our results. Thank you.
Thank you, Professor Reza. For our next presenter,
You want to do the next one? No. Yeah.
You want, he's asking, would you like people to ask question now or in the end?
We take it in the end.
In the end, okay.
There are all the, we can have a discussion among them.
Okay.
Okay, for our next presenter, to talk on 5 surgeries and counting on the same patient, when will you say no more? So
Okay, so.
may I present to you the founder and director,
I
chief
would-
surgeon?
Thank you. Thank you for the introduction. Oh, you want me to?
Okay,
I'll
you
just
can
start.
proceed.
Let's not waste time. Yeah. So thank you, Mufi, for modifying. I should be thankful to you for modifying the topic of this presentation to a more interesting one. Any which ways, these are my disclosures. I would come straight away to the point. So, we are doing, if we operate more volumes, we face more revisions and more complications. And anybody who says that, I've crossed that learning curve beyond which I'm not facing complications, I think it's the biggest truth on the earth. Let's talk about something which I do very frequently, the banded sleeves. Now, we all know why do we band a sleeve? The concept came from some of the publications by Professor Luke Lemons, my friend Konrad from Germany, and several others who said that the concept of putting a band around a sleeve can enhance weight loss. Now, whether believe it or not, but what's they propose. But what do we do if the band erodes? And then there are further complications. So this particular patient, we did operate 5 times. Now, what happened to those 5 times, I'm going to discuss. But these are the questions, just keep in mind. You band a sleeve, the band erodes after a year. You remove the band and the sleeve leaks. Then you convert that sleeve into a Roux-en-Y configuration, which ends up having severe dumping and diarrhea. And then, despite all the medical management of that persistent diarrhea, you have to resort to a surgical management. This is a common story which can also happen with you if you have done a sleeve and that sleeve has leaked, and then that leaked sleeve keep on giving you a lot of operations and a lot of work. You keep on working, you put in a stand, you go back and do a surgery. That surgery leaks, you do a feeding jejunostomy. The feeding jejunostomy leaks, you go on. So, a sleeve kit, it's a very good surgery. It can give you not only a lot of revisions, but also a lot of complications. Now, here is this particular case. I'll go through the video, but this is the story. We did a lab banded sleeve gastrectomy 2019. At that time, Dr. Phoebe was at my center. And I think, I don't know, I distinctly remember this case done by me. And the band erodes immediately, not took 2 years to erode, 6 months. I would say it's quite early in the phase of a banded sleeve. I've usually seen revisions happening 3-4 years later. But this was like 6 months. Patient comes to us with a band erosion, and that after diagnosing the band erosion, I could not remove it endoscopically, so I removed it laparoscopically. Now, the sleeve leaked after I removed the band, so we came in for the 3rd surgery, where we have to convert that entire configuration into a Roux-en-Y esophagojejunostomy. Why? Because eroded band gave a lot of fibrosis, which made very difficult for us to preserve a little bit of pouch for the patient. So we had to go up. Then the patient came back with intractable diarrhea, weakness, and dumping. Then another modification of this surgery from esophagojejunostomy to a laparoscopic remnant stomach jejunostomy. And then now, even then, the problem of diarrhea doesn't resolve, the patient dumps. So now the 5th surgery. So let me start through the video because this is interesting. I don't want to keep all of you waiting for any information. So this is a patient who had already done a banded sleeve. I'm not going to show you the banded sleeve. There's nothing interesting there. So I just cut short the video here. So after the banded sleeve, we go inside with an endoscope. So the patient presents to us with continuous vomiting, regurgitation, pain in the abdomen. So when we go inside, what do we see? Now, if I can just take you to this, what is this? Okay, let's stop here. Which is this band? This band is the band which is prepared from the original concept of Phoebe ring. So you can have a silicone tubing, use a proline suture and prepare the band. So this is one of those bands which we prepared on the table, and this got eroded. I'm not saying that the bands which are prepared or which are pre-sterile, prefabricated are not having erosions. They do have erosions. This might have a little more incidence of erosion. Everything rest all fine. There was nothing there inside. Now, the problem with me is that when tried to remove this band by endoscopy, it was not possible. It's a very thick thing. And usually I would get the proline suture so I can cut it here. The proline suture, it's a partially eroded band. So I did not have the comfort of sort of removing the band endoscopically, because neither the proline suture was inside and the tubing was very thick. So we don't have that kind of scissors. I don't believe in lithotripters to remove these kind of bands. They are very effective on the adjustable gastric bands, but not these bands. So I went inside. The patient was very sure, I do not want a gastric bypass configuration now. Doc, just go in and remove my band if it is eroded. Now, when I removed the eroded band, so this you can see, I just went inside and pulled this entire thing out. And now you can see the proline suture there. So this, I just cut this. If this would have been inside, I would have removed it. And after cutting it, I sort of saw that there may be a persistent defect there. So what we did was, let's try and put in an endoscope. So we put in an endoscope, but it did not show any leak. But then what we did, we repaired that particular defect, which was created because of the harmonic shears. And, I just said, okay, that's fine. We have done the repair. Let's blow the entire area and check if the repair is successful. So you can see that there is absolutely no leak there on the endoscopy. I could pass in the scope, blow in a lot of air. I did not see anything, any air coming out of it. And most times you would not have such a beautiful blow in of the stomach if you have a leak which is persistent there. So we were fine. What wrong we did, I'm going to discuss and I'm going to ask the audience, but yeah, that's what we did. Now we enter inside, just 2 days inside the hospital. Patient comes, this is just 48 hours after we removed the band by laparoscopy. The patient was inside the hospital only, luckily, because he came to us from outside. So his trains were booked later on. So he went for everybody who comes to our place goes out and move in the city, and then they came back with severe abdominal pain. We thought, yeah, maybe that, and we were correct that this was a leak. So now this is a sleeve leak, which is there because of a removed band, maybe that area which eroded leaked. Now, what do we do at this stage? So the first idea was to put in a band of, a stent, which is a fully covered metallic stent. That could have been the first thing, but I thought maybe let's go and give this patient a chance. Let's do a single stage procedure where you put in a stent, wait for 5 to 7 weeks, remove the stent and see if that part is healed. Let's go and convert this into a esophagogynostomy. Yes, a little heroic on my part. I'm comfortable doing a esophagogynostomy more than I'm comfortable dealing with those stent strictures and stent complications. So I went ahead, and this is the third thing, the third surgery. At this stage, the only thing I did was remove all that material which is necrosed or leaked, go above the left gastric artery and dissect that area above the left gastric artery, try and dissect into the hiatus, get the esophagus down. We may get some amount of pouch there, but the fibrosis was because of 2 reasons. First, the difficulty was because of 2 reasons. The first one being the fibrosis, which the band as a foreign body caused for me, destroyed the whole pouch for me. And the second was this leak. I ended up doing a esophagogynostomy because you can see there is nothing out there. So I was not very sure if I do it with a pouch, which is as bad in tissue morphology as this, I'm going to gain anything. So I went it inside the crus, dissected the crus, brought down the esophagus. First on the left side, everything looked very difficult at that stage, but we had to do something about it because we were not prepared to put in a stent, neither we nor the patient. So decided let's go ahead and dissect the hiatus there. There's a plane of virgin area which gives you a little bit of hope, and remove all this, do a total gastrectomy and remove all this, and then do a complete gastrectomy with a esophagogynostomy with a Roux-en-Y configuration. So here you can see that that was the area of the leak, which you can see in the endoscope, completely resected that area, went inside, and then my aim was to get in at least 3 to 4 centimeters of esophagus down. This is the virgin area, so I was more confident here. Let's do it. I mean, that's the disadvantage of doing this is you have a patient who will regain all his weight. Because you do a esophagogynostomy, they regain all the weight virtually after like 2 or 3 years. And the positive part of it is when you are amidst a storm, let's try and do things which are in the virgin plane, and let's do simple things. So here I came in, a lot of dissection there, but yes, I was lucky to get in the esophagus, completely transected it. After I had a 4 centimeters length. So yes, this is the plane I got and I transected it. So you can see there is absolutely no pouch I have there. And I was not prepared because that pouch was fibrosed, it was leaked, it had a lot of pus in there. And to do anastomosis with that sort of anatomy is not something I would have liked. Now, obviously, when you have this sort of anatomy, Orville device is always effective. I very rarely use an Orville device or a circular stapler, but here was a case which made a good case for me because you have a very short length of esophagus. Most of it is like, trying to recede into the thorax, and then we remove this entire specimen. So again, that was not easy. Please imagine that we had a lot of fibrotic area there, which had to be removed. Not easy. So this is the area which leaked and which got fibrosis due to the bang. Now what you have is the remnant there. And even the remnant, because of the leak and because of the fibrosis, had ischemia. So we had to remove the part of the remnant. So you can see I just have 5 to 6 centimeters remaining from the pylorus. If I have to do anything in future, who knows? So just the antrum remaining, and then I have this esophagus now. And let me go ahead and do a esophagogynostomy. Yes, I did the same. We did a esophagogynostomy, and at this time we use a circular stapler. The patient did pretty well after this surgery. He was eating well, gained a lot of weight, but now the problem was completely different. He suffered from what we called as a post-gastrectomy syndrome. Vitamin B12, calcium, iron, everything was low. He was eating very well, but severe diarrhea and severe episodes of hypoglycemia. We put in a chip where we do a continuous ambulatory glucose monitoring, and it shows, my personal take is that if you have a patient who has this kind of an anatomy and is showing lows of 45 milligram per deciliter of blood glucose levels 4 to 5 times in a day, and it's going way below, patients having symptoms, call them back and do something about the dumping and hypoglycemia. So, I mean, this is just a Roux-en-Y configuration and doing esophagogynostomy, nothing special in this surgery. But now this patient came to me with a lot of diarrhea, a lot of dumping, a lot of hypoglycemia episodes, and some episodes where he would pass out while driving and things like that, had met with 2 or 3 accidents. Now my job was to deal with that sort of a problem. So I did everything. Modifying his diet, everybody says, oh, give him very low carbs, very high proteins. No, it did not work. Subcutaneous and injectable glucagon, yes, I did that. No, it did not work. Even I discussed with some of the endocrinologists, and once they are exhausted with acarbose and several other things, they say, okay, try incretin-based therapy. It delays gastric emptying. There's no stomach pouch out there to delay the gastric emptying. There's no pylorus out there. You take the advantage of a GLP-1. Now the patient is admitted severe weakness, intractable loose motions, BMI 22.8, and we do this contrast study. Everything is normal there. There's nothing which is there apart from a mild fatty hepatomegaly. And we have this configuration which a large hiatus there. But now our job is to fix his dumping somehow, by surgical measure, because everything non-surgical did not work. Now, at this stage, my question to the audience is what we could have done here. I mean, I discussed with Dr. Phoebe. Dr. Phoebe said, let's do one thing. Let's take the loop and anastomose it with the remnant. So you need the pylorus. Dr. Bhandari, you need the pylorus here, because if you do not have the pylorus, you're going to have the same thing. Antonio, you understand why we need a pylorus, things like that. So I said, okay, Antonio will be very happy today. So we sort of connected the jejunum to the remnant. So the part of the food can pass to the remnant via the pylorus, and the patient can have some less of a very high osmolar food going directly into the jejunum, releasing that high amount of glucose, thereby causing a lot of, they were increasing the episodes of hypoglycemia. So at that time, I asked Dr. Kobe, why not do complete division of that thing and just connect the remnant to the esophagus? Said, no, leave it for the next time. So we just did, dissected the remnant. And if you remember from the past surgery, I was lucky to have a little bit of remnant there, like around 6 centimeters of a cuff with the pylorus there. So we dissected it entirely, and that's the pylorus. So we had this remnant coming in. We had this jejunum coming in from the esophagus. I just did a connection, simple surgery. We did not waste too much of time. Went inside, did a side-to-side anastomosis. So that's the remnant I've made a hole into. And that's my jejunum, which is coming from that's the root limb of my jejunum going to the esophagus at the top. So my intention here is that the food comes into the jejunum, but a part of it drops down, but a bulk of it goes into the remnant there through the pylorus, because that's a larger diameter. That's a 4.5 to 6 centimeters. So my hypothesis was, and our thinking was that this food comes in, almost 60% goes into the remnant and 20-30 goes into the jejunum directly. So thank you. This is really helpful. So that was my thought. That was the thought process going through me. And me and Dr. Phoebe and everybody, we drew a lot of diagrams. That time Manuel was also there. So he said, let's do an endoscopy and check that you have both these areas working in for you. I can go in with a scope into the jejunum, and then I can go into the pylorus, and we can check if this pylorus is functional or not, because we have a lot of neuroparesis there. These remnant smooth muscles, when they are kept alone, they don't work. And when you connect them to the routine anatomy, most times it's an obstructed system. So we went inside. This is Manuel doing an endoscopy. He said, I'll make sure for you that we go in, specifically we go into the pylorus and check if the pylorus is working on. That's the jejunal area. I was very sure there's no problem there, you can see. But let's go into this area. That's our area where we want the food to go, just like we do it in a transit bipartition. We want the food to go through the pylorus at least 30-40%, and the remaining, even if it dumps, we have less dumping, we have less episodes of hypoglycemia, we have less deficiencies. And you can see this is the duodenum. So we could easily go inside. But now what? This patient even did not have any resolution of his diarrhea or dumping episodes even after this surgery. And now, for the 5th surgery, he did not come to me, but he went to some other surgeon, and the other surgeon called me that I don't know what to do. I mean, you're just playing around with this patient like that. You tell me what to do. And I don't have the video, but the 5th surgery, what he did was he completely divided the jejunum there so that nothing goes into the jejunum. And the food now came into the pylorus, and now the entire thing has resolved completely. The dumping has resolved completely. Yeah. No, I did not. No. I'll again show you the video. So you can see the endoscopy. No. This is different. So this is okay. So please see, it's not completely divided. You can see in the endoscopy, we are going through both the channels. See there. So we maintain both the channels through the jejunum and through this. So you can see this. I'll just pause the anatomy here. So that area here and this. So you can go into both the channels, and this. So now what we did was we completely divided this entire thing here. Let's solve the problem. So the problem which was happening is this. The food coming into this part of the jejunum was causing a lot of dumping. And so the food has to go through the pylorus. The moment you have this path here, this path, the one which is here, this is the duodenum, you have absolutely no problem. My only concern with this sort of anatomy is that when we join this anatomy 2-3 years later, this is obstructed system. I've seen, yeah, okay. Yeah. Okay.
So you will have long blind loop.
Absolutely.
You will have a new problem,
we are-
bacterial
we are-
overgrowth and area.
We are waiting for a sixth one, so I don't know.
Okay. Great job. Thank you.
But
Mohit, what you've done is something that is being done by the gastric cancers in Korea. Yeah,
in
and
fact, I had to resort to a lot of my cancer friends, and they say we suffer from post-gastrectomy syndrome very, very often. And this
Yeah,
is
so-
usually, yeah, Professor Torres.
and they don't have enough of length to
Yeah,
go up.
to go
They're
up.
using this jejunal loop and using it as a conduit.
Absolutely.
Yeah.
But we, in this case, yes.
Congratulations, Mohit, extraordinary, case, showing us how important is the pyruvate preservation. This is the old Merendino approach, to interpose one jejunal loop, was ideally identified for the cardiac tumor, to do a thin position of the bowel loop between the esophagus and the stomach. But anyway, the concern, the only concern in this kind of reconstruction is the length of the interposed jejunal. You know what I mean? Is it so short that the problem theoretically is the girl, but in this patient, the priority is to solve her problem. I think you did an extraordinary job, and the only thing is the first time, the third or the fourth operation, I don't remember, going to be to divide, to do what you did the last one, because it's the, because if the Dumpling syndrome is due to the a quick emptying of the food, if you maintain the two ways, this is the happening. You have to convert properly the idea. And the concern, the long term is to have enough length of the interposed jejunal bowel to avoid GERD problems.
Yeah. I think just the question is that if you're talking about a very good length, it is 50 centimeters, what data suggests. In this particular case, we never had that kind of a length. So yeah, that's a problem. Professor Torres, my take from this particular case would be that we should try and use the remnant if we have a situation where we have to get back to the normal anatomy, because Roux-en-Y configurations in obese patients, I don't know how many of us have done many Roux-en-Y esophagogynostomies after sleeve leaks, but to all those patients we do, first of all, they regain all their weight. Like this patient is gaining weight rapidly, despite having all diarrhea and dumping. He's eating a lot.
Yeah.
Number one. So if we do what you say, that we use the remnant anatomy, we do not have that much weight regain because you have a pylorus there, which sort of gives us satiety.
I think with this patient, the priority is to solve her problem, that the dumping and the worst, the terrible quality of life, It's preferably to have an obese patient, but with the higher quality of life that this patient has now. Congratulations.
Okay, Mohit, I think this case is very interesting and very, very important. Thank you, teach us medicine. But I think maybe the first time, the first operation, sleeve, just the sleeve, low bending, maybe this kind of
I'm not going to go into that question of whether to band a sleeve or not. I was not picking up this case, but Mufi wanted me to show something more exciting. So I was trying to show endoscopic sleeve revised to sleeve so that you all love me. But anyways,
Yeah.
I mean, don't band these sleeves. Don't band.
Yeah. That's very, very
No, you have to.
interesting.
Fine.
And the second time operation, just repair the hole and the drainage. No drainage the second time. So
So the problem was that if I remove the band, the choice would have been to repair the hole and convert it into a Roux-en-Y gastric bypass, so you have a low pressure zone. I had so much of fibrosis in that area, Professor Wan, that I was scared to fire another stapler on that fibrotic area of the band and do a Roux-en-Y at that stage. Number one. Number two, the patient said, if you can remove the band and come out, I'm fine. I don't want it to be converted to a bypass. So that's why I just removed the band and came out. Now, if I would have removed this endoscopically, this problem would not have occurred. This problem occurred because I dissected it laparoscopically and it created a hole there. Most endoscopic bands, if you would have heard during adjustable gastric banding eras, were removed and they did well because there was no fistula. Here I created one and then I repaired it. Even if I repaired it and did an endoscopy, there was one. That led to the problems. The message here is that if you are not able to remove these kind of bands by endoscopy and you do remove them by laparoscopy, try and convert them into a gastric bypass at the same stage. Because if you do that, what do you think, Professor Bonifacio?
One more question. Thank you. The third time operation, if don't resect the do the esophageal jejunal anastomosis, just repair and drainage, maybe the second time to maybe.
We may ask. I mean, I did, but you have to take into notice that I caused diarrhea, but I did save the life of the patient because.
Okay, thank you.
It's easier than, I think, Mohit, you have a question? Yes, Mohit, yeah, go ahead. Yeah.
Sorry,
You can see you got all the attention. I had trouble getting any audience. You got all they all come back for you.
First of all, congratulations for wonderful. This sort of surgery is my surgery.
I love it.
Yeah. Now, what I might have done different when I have dissected, when I had to dissect to bring out this big band, which is not normally the case with the Fobi band or minimizer band, I would have dissected the whole greater curvature again. And I would have exposed the hole in the stomach properly. And I would have refreshened it till I see spurters coming out. And then I had the choice either to close it if I have enough lumen, and that's gauged by a Silastic 40 French tube, or and you could close it primarily when you see that, or you could do a bridging bypass, a Roux-en-Y bridging bypass, and that eventually would close on its own. The food will take the normal passage, or you can later on close it. That is the only difference. But coming back to what you have done, you saved the life of the patient, and that's the most important.
And I'm so proud of the fact that I did.
Yeah, yeah.
It was heroic. And when I was doing this surgery, Professor Fogo, oh, you just believe in surgery. Let's put in a stent. I said, no, this is going to just spoil this. Let me do a esophagogynostomy.
I think on that note, we get the last question up to the stage. My very good friend, Walid Bukhari. Yeah. You're up next. Yeah, you're in the next presentation. Yeah. Okay, there's no doubt that you got the most attention. Okay, that was outstanding. Well done. Big round of applause.
Edward, I promised you the session. Now we are going to have something where Walid's going to present almost near impossible situation. So from what we've got seen with Mohit, now let's see what Walid has got. It's only going to get worse from here, guys. So buckle up and sit down.
Yeah. This is for now. If I knew I was next, Mohit, I would have made a longer question and I would have taken the podium. But anyway, thank you. I would like to thank the organizing committee on this wonderful invitation. I'd like to thank my brother Mufi. And there is a misunderstanding on my behalf because I was called first to show really catastrophic operations. And I prepared a case where 3 months after the surgery, patient had necrosis of the stomach. And then he was put after a sleeve, a metallic stent, and the stomach, 2/3 of it necrosed. And some surgeon used the lower surface of the left lobe to use it as coverage. Yes. And the patient came to me after all this. And to make it worse, they removed the stent before they sent him. So there was a hole inside the thorax somewhere, representing the lower 1/3 of the esophagus, and 3 centimeters. That was a case I was going to present. Then I talked to you, Mufi,
And you said, no, we want revisional surgery. So I made another 2 catastrophic cases for tomorrow. Anyway, this is what I meant, Mohit, by this is my sort of case. This is the hospital where I work. I had the privilege of having Mufi and other friends visiting me there. It's called the International Medical Center. It's a private hospital in Jeddah.
Looks like a
after I
palace.
retired. Now, this is a case disclosure. This is what we do mainly, and this is my statistics. And we used to do around 1,200 cases a year. It's gone down after COVID. Now we do around 600 to 800 cases a year. Indication for Roux-en-Y reversal to sleep. And our talk today is reversal of Roux-en-Y to sleep. I would like to claim that I was the first to reverse a Roux-en-Y bypass, which was considered as an irreversible surgery in the beginning of 2000. And, but I never published as usual. And it became usual to reverse Roux-en-Y surgery. Now, the idea came from a patient. The patient came and said, Walid, I want to be like my brother. You did a sleep for him, he lost weight, you did a Roux-en-Y bypass, I lost weight and I regained it. So if you can redo and change me to sleep, and I did that. But these are the causes of reversal. Of course, unsuccessful lost weight after Roux-en-Y bypass or regain. And there are so many reasons for that. I just want to get to the film because it's a video session. These are the things we do. Very important point is to do an angio-CT and make sure that the left gastric artery is patent. So if you have operated the patient and you know it's patent, you go ahead. You don't need to do a CT angio. But if a patient comes to you from outside, I think that's very important. Now, this is the procedure. And this is a patient who have had a Roux-en-Y bypass with a micro pouch. So that is not an almost impossible surgery. That's just a surgical technique, and that was again done 2009, I think. That was the first of our cases. Now we have done over 38 cases, and we have 5 years follow-up some of those cases, and they've shown more than 50% weight loss, maintained weight loss after 5 years. And with the appearance of semi-glutides, it's even now identifying exact anastomotic area is very, very important. Dissecting that away, exposing it, getting the 2 edges of the stomach. And that's a transverse oblique DLU, straight stapler. Making sure that good passage is maintained with a 36 French tube, elastic tube, closing the enterostomy. Of course, this patient with preoperative endoscopy showed no hiatus hernia, so no manipulation of the hiatus was necessary. now getting to reversing the jejunostomy. Funny enough, in the literature, there is not many publications to show the reversal from Roux-en-Y bypass to sleeve. But though 3 years follow-up in some of the studies, there were like 4 or 5 studies, first published in 2010 and 2014. And there were small number of cases, 2 cases, 1 case, 4 cases, showed some of those publications showed serious complication post-operatively. And it showed still 50 to 60% weight loss on those publications. Like Samper, Jack Hempens. And that's the normal reestablishing the functional anastomosis site. Very important, we found that to select those patients, of course, the patient come and ask for it. This is very important. This is what pushed us to do it. And there is not enough knowledge or publication or studies that have proven the viability and the goodwill of this procedure. But very important is to scrutinize the patient, make sure the reasons why he regained the weight after Roux-en-Y bypass are surpassed. And that will need a good psychologist specialized in eating disorder with courses before you undergo the surgery. And the other thing is a good nutritionist that will teach those patients. Yes? This is jejunostomy down. Why did I do it? I know you could bypass it, but I like to bring everything exactly as it was. Being a type A personality, even my wife wanted to divorce me for that, but what to do? No. And that's doing the sleeve. Using that dog ear, which will have no function, to support my stitches. I do something with all my sleeves. I always make sure that the hiatus is properly adjacent and closed, sometimes narrowed if it's wide. And then the upper 1/3 of the sleeve, that's normal sleeve. I would use the omentum to plastiate, and I use the colopancreaticocapsular ligament of a mean to fix the stomach in the intra-abdominal cavity. That way, we have really decreased the amount of reflux that patients suffer from. Even though a lot of people don't see that, but we're gonna publish our series soon. We're doing pH metries, we're doing manometry studies, and that is how it looks. You can see when the tube is coming in and coming out, the stomach doesn't move. It's fixed to the ligament. It does not go up in the thorax. Post-operative care, fluoroscopy first day, swallow test using water contrast in negative clear liquid diet for 3 days, followed by 5 days of thick diet. In total, 39 patients were reported. 5 series ever published, started 2010. We did the first case 2004. And you could see Semper, Dapri, Zurita, Campus, Collins, Jack Hempens. The revision expected. These are the revision surgical technique that, anyway, as we said here, complications, surgical techniques that can add to the complications, creation of gastrogastric anastomosis. And these are information obtained from those studies.
No leaks were observed by first removing the fundus with a staple technique and performing plication of the stomach distal to the gastrotomy to avoid ischemic areas lateral to the anastomosis. Severe nausea was also reported, can be explained by vagal denervation during the sleeve dissection or the sleeve itself causing the dumping. Reversal of Roux-en-Y bypass is indicated in selected cases, but can lead to weight gain, which makes certain patients to be hesitant to undergo reversal, although experiencing severe complication. Of course, these are the studies I'm going to run because we are short of time. Average weight loss in the 5 series, as I said, 50 to 60% excess weight loss over 3 years follow-up. Take-home message for the moment, my opinion, we have done 38 cases. We're coming out now after more than 5 years follow-up of all of them. Reversing bypass to sleeve is indicated. In indicated cases could be a method to be further researched as a standard method to treat those complications, weight regain and so on, dumping and so on after Roux-en-Y. One of them is weight regain, though it needs long learning curve, it needs experienced surgeons, and it needs meeting the proper decision and patient selection. Thank you very much.
Walid, we needed a picture of the patient next to his brother in the end. Very good, very good.
I think the operation is very good. I have two cases of this kind of operation. Yeah, but after 7 years later, all reflects in your experience after the operation. If the patient have the reflex, yeah.
What happened?
Reflex,
Reflex.
guard, yeah.
I think it's now for the last more than 6-7 years, and Mufi can witness to that. We have been using the colopancreatic capsular ligament to fix 2/3 of the stomach and use it to splint the stapler and invert the stapler line. And that on its own have minimized the bleeding, the leaks, and the slippage of the stomach upwards. Now, you know, and I know that having a good, strong crura with no hiatus and a stomach intra-abdominally lying, not sleeved, you still have different types of refluxes that can happen. So that minimizes the incidence of reflux. It doesn't prevent it. All right. So, I mean, 2 cases, you cannot judge. We've done 38 or 39 cases. Until today, I cannot judge. Our patients with sleeve, for sure, we have less % of reflux doing the cruroplasty and fixing the stomach downwards. But we still have patients who complain of reflux, and you do multiple endoscopies, you do the pH-metry, the manometry, according to Demister, they constitute something new of type of reflux, like neurogenic reflux. I don't know. You know, it needs to be further studied.
Thank you very much, Wali. We move to the next presentation by Dr. Conchuan Wang. He is the Vice President of the Jinjiang University Hospital and academic leader in bariatrics and professor of surgery.
Ladies and gentlemen, good afternoon. I think this session is very interesting. And my topic is, no, not this one. Another one. Oh. It most other one, yes, this one. This. Okay. Sorry. My topic is anatomical reconstruction of gastric bypass. So for what is the indication for reversal after gastric bypass? First is non-standard diabetes surgery. In China, some small hospital did this kind of operation, but now less and less. So for indication for bariatric surgery, this kind of patient maybe BMI is less than 27.5. So after operation, nutritional problem happen. And the secondly is hypoglycemia. Another one is patient is not able to adjust to life after surgery, the new lifestyle. So for reversal after RYGB in all experience, we have one case in the 960 cases, one patient. This guy is 17 years old, young man, and the BMI is 38.5. After RYGB, the outcome is very good, but they cannot eat like before the operation, and ask to revision surgery. So many times we talk about the complication, so we did it. And another kind of revision is non-standard OHB. Maybe not OHB, not some like RYG, some like OHB. This kind of operation is open surgery. Like this case is 41 years old, diabetes, BMI just 21, and they did the open gastric bypass. The operation, the gastric pouch is very big, and the BP line is very long. So after operation, more nutrition happen, diarrhea, pain, something, everything will be happen. So like this patient, BMI is less than 18. We can say is very bad fail. So we know this kind of operation, after operation, 7 patients die. This patient, we can say we did the revision. Because it's an open surgery, so we can see the adhesion. So for bariatric surgery, education is very, very important. So I can say this is gastric jugular anastomosis. We want to very carefully. So so for bariatric surgery, I think the indication is very important. Which patient need operation, which kind of operation, and the operation is, if it's standard, is very important. Because the patient the BMI is very low, so the visual operation is not very difficult. So we cut the anastomosis. And here have a jugular anastomosis. And maybe he will, the surgeon maybe think like this is good. So here we can see have an anastomosis. We need to cut, open it. So for gate bypass, we can go back. If sleeve, no way to go back. Here I can say this is a big pouch. So we're building the stomach. Here we use stable. The coach, we can let We need one more file. So for some patient, if the first time the operation, before the operation BMI is high, have bariatric surgery indication, we transfer to standard gastric bypass, not revision. No. Just use suture. Because this patient, we can't say the head hernia, they need to repair it.
Did you dissect the anterior part of the pharyngoesophageal ligament?
Okay, this is student. And then measure the small bore lungs. Okay. So this case, we can say the small intestine total lung is 600 centimeters. We can say the BP length is about 50% of small bore. After operation, this patient is okay. This kind of operation, we have 25 cases experience. 2 cases have the second time operation because the organ intestine and the most obstruction after surgery. So we need a right laparoscopic surgery. No other complication. So for this kind of patient, mainly is protein energy malnutrition. So we can conclusion. The revision of surgery of RYGB, OAGB is an operation in special circumstances. Thank you, everyone.
Thank you very much. For the interest of time, we would move to the next session by Chi Kun Wang and Ming Chi. Oh, okay, Matsinov fellow, yeah, that he's presenting on the behalf reoperation for gastroesophageal reflux disease after hiatal hernia mesh repair in sleeve gastrectomy patients.
Okay, thank you, Chairman, and thank you all the masters and great surgeons on the floor. Today our topic, talking about a topic that's not so deadly but really painful for our patients. It's about hiatal hernia. And it's the background of our patient. Is a young man with high BMI and we successfully do a sleeve and hiatal hernia repair for the first time. He got good weight loss, but however, the GERD happens 1 year after surgery. So she take a medication for therapy for around 1 year. So finally he could not tolerate it. So he asked us to do the surgery to solve this problem. But out of our inspection is that after the revision of what we need to do another one for the first GERD happened. So that's the first time in the 2018 we do the first sleeve with hiatal hernia repair for the patient. And interest in these 3 times operation just presented the migration or change in our practice to facing the hiatal hernia repair. Okay, this is the first one, operation. It's around less than 2 minutes video. In the beginning, when we do the hiatal hernia repair, we just open the cruise and do a repair from the lateral side. Because in the beginning we found when gastroenterologists tell us patient got hiatal hernia, usually they will have a very severe and a big hole inside. And in the beginning, the method after we do the sleeve gastrectomy, we use a non-absorbable acetone. Do a simple repair from the lateral side, try to make the hole smaller. So usually this kind of defect only require 1 or 2 sutures, and will be very sufficient to make this hole become smaller. And usually after the closure, we will use our OG tube to do a test to make sure the opening is not too narrow to prevent unnecessary Bonifacio in the future. But however, after 1 year, the operation, the GERD happens again. And we keep on doing the medication treatment and do the penoscope following. Patients still have very severe symptoms. At that time, we do the CAT scan to make sure what happened inside. And in the CAT scan, we found that there's an intrathoracic migration of gastric tube. So we could find in the CT. So therefore, we arrange a second operation for this patient. So same after the first operation, adhesion comes, and we could clearly see there's a defect with a sliding hiatal hernia on the anterior part of the esophagus. So again, when the second time operation, we have to face a lot of adhesion. The blue one is the previous acetone suture we made. It to make the posterior defect smaller, but seems did not help for the anterior defect. So at that time, we opened the right side cruise and approach the hiatus from the medial part. Release adhesion in the posterior part of the esophagus. As you can see a sac and a lot of adhesion inside. And because the inside you got aorta, so we need to carefully dissection during the operation. Usually we will do a 36-degree total release of the adhesion and try to make the lower esophagus be naked. And at that time, at that stage, we still use S-bone to do an interrupted suture to make the defect smaller. But because during this time, we found that there's some insufficiency about the anterior of the cruise. So at that time, we decide to put a mesh, bioabsorbable mesh, try to make the defect become stronger, more durable. So we pre-mesh and do a fixation and try to make these things being solved. Okay, this is the finish of the second operation. Okay, so unfortunately, 2 years later, we have to do operation again. Why? Because patients report us, after the second operation, he got more exercise. He tried to go to gym to do some heavy lifting exercise. And unfortunately, after 1 year, GERD happens again. And the poor response to the medical treatment. Again, we do the CAT scan. Again, intrathoracic migration happens. But this is the third time operation. After the mesh, I think all the surgeons know what's happened inside. These were very deathful adhesion. Actually, we spent around 2 hours to release all the adhesion in the lower esophagus side and the gastric tube. So I summarize it in 30 seconds, but actually it's really suffered. It's 2 hours dissection. And it's very hard to find a plan. And usually we use like a band to pull out our esophagus. And the same, we try to do the release of the adhesion and dip into the mediastinum. But this time we shift the policy, we use the non-absorbable relock and do a running sutures, try to make the defect smaller. But in this operation, actually we do a lot of things differently. We pay a lot of attention to get into the mediastinum, try to release the adhesion inside it, and very clearly pull down the esophagus down. So usually we will pull down esophagus, at least we could see around 4 to 5 centimeters in the thoracic cavity, in the abdominal cavity. And also in this time, after closure of the defect, we use the proline, try to do some fixation of the esophagus, try our best to make sure this gas tube could always remain inside the abdominal cavity. So that's the last part of this repair. We try to do some suture. Actually, we still wonder this kind of fixation will help or not. It still needs some time to make sure it works or not. But at least in the short term, in the recent visits of patient reported it really improves a lot. So okay, so in this video it's only maybe 2 minutes. But actually, it's really very, very stressful dissection in the operation. Okay. So let's talking about obesity, GERD, and hiatal hernia. As we know, obesity is already an independent risk factor for the GERD and hiatal hernia. It's like brother sisters operation. So half the patient got the hiatal hernia, and more than half patient have GERD, symptomatic GERD in the obese one. Although we got several kind of methods to deal with this kind of situation, like the primary closure, use the cruise closure, or maybe we could do the primary closure plus mesh, or even could do a knee sensitive or just shift operation to gastric bypass. The result seems good in the short term. Whatever is anterior repair, posterior repair, or we put mesh or not, it seems this kind of management do a lot help to the hiatal hernia and the GERD after the sleeve gastrectomy. But when we face the GERD after the primary sleeve, I think the thinking need to be, I think it need to be remodified. A lot of literature tell us the position of the gastroesophageal junctions may play a very important role in the severity of a GERD after the sleep gastrectomy. And also, when the patient have a hiatal hernia concomitant with the intrathoracic gastric migration, usually the severity of the disease will push patient asking for the surgical intervention. So when you go back to see the literature, a lot of studies tell us the position of gastroesophageal junction to a very good hint about the severity of the GERD disease. Just like that, as we as a dome as a marker, when the sphincter is higher, then that means the pressure the sphincter could provide would be lower. That means patient will got more time, got acid reflux, and cause more symptoms. And two mechanisms were being talking about for the migration of the GEJ. The one is a shortened esophagus. Most is coming from the permural esophagitis and fibrosis. I think this one is quite important in our patient because this kind of obese patient already got GERD for a long time. So I think, and in our experience, there's would a large adhesion inside the median sternum. And even after operation, this kind of pulsation seems not stop, it just becomes slowly. Another mechanism is about the elastic constriction of the esophageal muscles, especially longitudinal one. But whatever, this kind of things will promote the GEJ junction higher and higher. So currently in our center, our practice, when we're facing the hiatal hernia, we will do a fully dissection. We will make sure we could see the both left and the right side close. And we will definitely go inside the median center, try to make sure the lower part esophagus is being total 30 degrees freed and try to pull the esophagus down. Then make sure that will be part of the esophagus could be seen inside abdominal cavity. So like this, we will dissect hiatus from lateral side, then go into the medial side. Hand up the esophagus and do good additional lysis in the medial sternum. Then nowadays we try to use a VLOC to do a continuous running suture. We somehow find that maybe this kind of more balanced suture may be a choice, but we're still waiting for the result. So, okay, let's see now the principle when you're facing the hiatus hernia in our practice. So in the last of my presentation, what will our experience about that? I think to manage the hiatal hernia during the first operation is quite important. Once you need to get in the second time, third time, you make you in big trouble. And the hiatal hernia may happen again. Even you do a good repair, sometimes it still happens. And in our experience, we found where dissection in the median sternum, adhesions pull down the GEJ junction where it's quite important to make sure the symptom could be relieved after the operation. But when we review the literature, all the data only tell us the short-term result. So I think the first studies for which is the best practice for prevent or even treat the hiatal hernia is quite important in the future. Thank you.
Matt, great presentation. Just a question. The 3 times you operated, you didn't think in terms of converting to a Roux-en-Y gastric bypass?
Yes. Actually, in the second time, we're already talking about patient to this issue, but patient he don't want to do gastric bypass. Actually, we already do this kind of offer to him. So.
Okay, and anything, I know that CK, y'all were doing the cardiopexy through the ligamentum teres, that y'all tried something like that, or the links, any other inputs on that? Matt, you can answer. The links procedure or the ligamentum teres, either of the two. Did they work? Did they not work? That's just so that all of us can know.
In the previous, we do the cardiopexy fixation, but it still happens. Hernia still happens, so that's the reason we gradually change our policy to the VLOC suture. So I personally think fully pull down esophagus is quite important.
Yeah, I think Matt has do good presentation. We don't have links in Taiwan, so I cannot comment. but it's not a foreign body. Right now, after 20 years bariatric surgery life, I don't like foreign body at all. The second is about ligamental tears. In the beginning, we use that for hiatal hernia repair, then fix it. But we find that it still can have recurrence of hiatal hernia because of patient lose weight, they can weakness of diaphragm muscle. Then the migration can happen. So I think the first time full dissection go to up to the mediastinum and putting everything down. Then second, use right suture is very important. I think right now most surgeons use S1 sutures, but right now I use V-Lock 2.0, and I think the adhesion and the security of the suture is much better than the S1.
Reza, because we couldn't ask questions during your presentation, I saw you close anteriorly. Most of us, you saw CK and Matt close it posteriorly. What's your take on closing the crura anteriorly?
I basically look at see what how does the esophagus lying down. Like I do a lot of posterior closures as well. Yeah, if you're dissecting, most important part which I ask CC is make sure it's a 360 degree. You dissect it anteriorly and posteriorly. Bring as much esophagus into the abdominal cavity. Then see how is it lying. If it's lying a little bit, if it's dropping down, that means that you can close it posteriorly. I must say more than half of my cases are closed anteriorly and posteriorly. And see, as long as I'm not shredding red muscle. Yeah. Ashim. Oh, sorry.
Oh, Seki from Japan.
Seki.
And in your presentations, you at the time of that first operation, you did a minimal dissection and the cross the crura posteriorly. And your second and third operation, you dissect around the mediastinum aggressively higher, right? So it's your message is at the time of even at the time of that first crural repair, it's better for us to dissect around the mediastinum higher. It's your message. My understanding is correct.
Yes, I think the chronic inflammation coming from gut make the adhesion in the upper part. They will gradually pull everything up. So during the revisional surgery, you need to make sure you get in the release every adhesion and make it down. But I could not explain it in the second operation. We already do some part in and try to put it down and put mesh, but it still happens. It still happens. So I think it's really difficult to say. I could not make everything perfect and good.
Thank you very much. I would agree with what Seki has put and what Nathan has put down there. The principles of hiatal hernia repair, wherever they are for reflux diseases, first, you have adequate esophageal mobilization. Remember, the esophagus is not a straight highway that comes in from the inlet and goes out of the airway. It's actually curved like this. So when you mobilize it, you get an extra length that helps you give you that 3-4 centimeters of esophagus. Secondly, the esophagus is like a recoiled spring. The longitudinal muscles will always reduce the longitudinal length. So if you do not anchor your esophagus to the crura, it will always spring back into the mediastinum. 100%. I have done this, been there, done it, and it doesn't work. Even if you follow the newest way of doing hiatal hernia repairs, where people actually snug their repairs onto the esophagus, it still does not hold. It will ricochet back into the thing. Last but not least, Mufi asked for a comment of links. If you do it very early in a year or two after sleep, if patients develop reflux, it's a good procedure. Beyond that, don't attempt it. Your patients will come and kill you in Asia because they get these, the esophagus loses its motility to a certain degree. The links acts as an obstruction. Whatever little acid collects up there gives them huge amount of symptoms. Even though their LA grade B, C esophagitis is now A, but they remain symptomatic because of pooling of that acid, which doesn't clear, and they can be very badly symptomatic. Thank you.
Thank you. Walid?
Very quickly, I agree about the length and the motility of the esophagus, but the question is that we don't usually take care of is the length of the esophagus. So prior to surgery, I would measure the distance between the incisors and the Z line to know. because many times, especially with people with chronic history of reflux, they have shortened esophagus. And that might give you the direct idea either to do a collé, lengthening of the esophagus, and proper dissection around it, or go directly for Roux-en-Y.
I was just about to say, if CC's patient got a Roux-en-Y with BMI 21, yours should have got a Roux-en-Y with BMI 23. So one last question.
Sorry. Roux-en-Y, not necessarily to treat obesity, but to treat the reflux.
Absolutely correct.
This patient is a doctor, so he knows everything about gastric bypass. I recommend twice. In second operation, I told him he should have the bypass. He rejects. But because the CT scan showing there's migration, so pulling down esophagus definitely will help for the reflux better or even remission. But the third operation before that, he do a lot of weightlifting, muscle training. It might be the answer that why he contract again, then make the esophagus going up again, maybe, but we still don't know that. But this case gives us a very important hint that even we dissect very carefully, you see the video in the second operation, dissection is very full, we put the mesh, we fix the esophagus, do everything, it still migrates. So I think I tell the patient third times, if it happen again, sorry, bypass or go to the other doctors. Thank you.
Thank you very much. Our final presentation about Pavin. He has been introduced here before once. We go, for the interest of time, straight to the presentation.
Good evening, friends. I know we are waiting for the bus. We are hurrying up, so let me rush through. You can have the presentation on, so no more of introduction. I'll be talking on gastrobronchial fistula, but then overview on sleeve leak. Before I actually get into the gastrobronchial fistula, I will actually show you a small video to understand a concept before I actually get into the gastrobronchial fistula management, because this is something controversial we can have a debate on. So it's a 19-year-old female with a BMI of 39, 10 days post-operatively presents with high-grade fever. Ultrasound is normal, gastrographin is normal, but then the fever continues to be persistent. So we do a CT scan of the abdomen, and that showed an abscess near the sleeve. So we do a diagnostic laparoscopy, we drain, there was no obvious leak. So the abscess was drained, a drain was put in place, and we are out. So that was on the 12th post-operative day. 48 hours later, we see obvious saliva that's coming in the drain. So it's very obvious it is a sleeve leak. So this is when we get in. So this is not the actual video, but I'm trying to explain a concept based on which my subsequent discussion will go. So you see the drain. This is 48 hours after the abscess was drained. It was a virgin abdomen at that point of time, except for the abscess. But in 48 hours, you see so much of peritonism happening because from the sleeve leak. So what was a contained leak now has become a disseminated leak. You see a lot of abscess. You see a lot of inflamed tissues, fluid, etc. So we go on to dissect the omental attachments to the site of the potential sleeve leak. We're trying to identify the leak. So what we need to understand here is in 48 hours, which was a virgin abdomen, has so much of peritonism happening. So the more we delay further, it will become more and more difficult to get into the space to actually get there. So many times we may not be able to even get into the space, or we might make it more complicated. So what do we do? We continue a dissection, we look for the leak, and finally we find the leak. So which is at the top end of the stapler line, I mean, where a sleeve leak is supposed to be. So you see, we are starting to suture this leak. And normally, whenever surgeons find any holes, we try to close it as soon as we can. So this is done gently. Of course, this is an intermediate leak because we're seeing around 12th day. And this is going to be an inflamed tissue. So the question in your mind might be, will this closure actually take up? Will this give away or will this take up? So we continue with the same skepticism in mind. We continue to close the leak as good as we can do. maybe in 2 layers. It comes out well, no cut through of the tissues. We're able to close quite well. Normally our mind would say, yeah, I've done a good closure. Can I just close it, put in a drain? Can I come out? So this is what we all believe, or many surgeons who already manage sleeve leaks might believe in putting in a long stent to reduce the pressure in the sleeve. But then we have, I would be showing the protocol in our center. We want to decompress the sleeve to reduce the pressure in the sleeve, because even if subsequently the leak is going to happen, we will have a leak from a low pressure system and not from a high pressure system. So we simultaneously convert this into a Roux-en-Y gastric bypass. I think we had Mohit was showing about total gastrectomy and esophagojejunostomy, but this is a gastrojejunostomy done on the stomach. The principle is, because when we have a sleeve leak, it's a high pressure system. It is one of the unfavorable fistulas we can have. But now if this, after doing a gastrojejunostomy, even if the leak continues, this is a low pressure leak, which has a potential to leak to heal much better than a regular sleeve gastrectomy. So it is based on this principle that in a sleeve leak, decompression of the sleeve is very important. That is what the stenting is trying to achieve, what we are trying to achieve through the Roux-en-Y gastric bypass, and even the fistula jejunostomies that has been reported, it is trying to achieve the same principle. Because decompression reduces the gastric pressure, it allows for drainage, and it augments healing. Because that is the point of entire pressure where the sleeve is exhibit. So it just continues to leak and leak and leak. So when you're able to give a drainage procedure like a Roux-en-Y, the pressure is transmitted below, away from the site of leak. So that is the principle on which we treat. And based on our experience of sleeve leaks, we in fact publish an algorithm where most intermediate leaks, or whether it's type 1 or a type 2 leak, we prefer suture closure of the fistula along with simultaneous Roux-en-Y gastrojejunostomy as a principle, similar to the what we call the step down approach. Do the best, and then subsequently we can follow with other methods. So coming on to another patient, which is a 55-year-old female, 4 months post-operative with fever, with a left lower lobe pneumonia, who was treated and recovered. The left lower lobe pneumonia continues to be recurrent. So we do a CT with an oral contrast that says a contained leak extending to the diaphragm. I think most obviously the patient is reasonably well preserved. So we do a stenting, which is the mega stenting, the 25 centimeter long stent. We remove the stent and subsequently we repeat the CT. There is no signs of healing. There was an obvious gastrobronchial fistula. As you can see in this picture, the contrast extending all the way to a terminal bronchiole. So this was a gastrobronchial fistula that we had to operate. There was an option of another stenting, which we didn't want to do, but then we went on using a surgical approach. You can see there is no inflammation anywhere like in the previous video. This was only in the top part of the sleeve gastrectomy, where you saw the cavity that was extending from the sleeve all the way to the terminal bronchiole. Again, you continue your dissection. You see the the dematous area. You will come across, that's the granulation tissue of the tract that's extending from the sleeve all the way to the left crust to the diaphragm. So we continue to explore it further. So that's actually the leak in the stomach was actually a few millimeters in size. But then because of the high pressure system, it never continued to, this was almost 4 months after surgery. It just goes on and on through the left crust, all the way through the diaphragm to your terminal bronchiole. So we're now trying to mobilize, identify the sleeve separately, the tract. See, that is the hole through which the cavity continues. You saw the CT scan, you'll be able to relate going all the way above. So you need not have to worry about. So we don't have to worry about the cavity as such, because once the sleeve leak is contained, the cavity will resolve. The granulation tissue may take some time. So now we are trying to mobilize the sleeve, to find whether we can have a space from the sleeve. And then after doing an endoscopy, we find it was about 3 to 4 millimeter size. That is the size of the leak that we have, that we identified. But this small leak, because of the high pressure system, never closed. If this had been a gastric bypass or a TBGG or any other bypass procedure, this would have closed on its own. It's because it's a sleeve, a very high pressure system, that it was an unfavorable leak. It continued to leak and leak until it had a left lower lobe pneumonia that had to come to us. So now this leak is being now closed, similar to what I'd shown you in the previous video. Closure came out very well. Yes, again, one might be tempted to think the closure is coming out well. I think it's a good enough. This should probably take. Since this is a chronic leak, yes, the tissue is fibrous. It can definitely possibly close. But again, when a small leak can give so much of a damage, here again, the concept of decompression is very important whenever we address any sleeve leak. And again, similar to the previous patient, we simultaneously convert this into a Roux-en-Y gastric bypass, which converts the high pressure system to a low pressure system. Because at the end of the day, as we saw in Mohit's video, many times sleeves can make you lead 1 to 2 and 3 procedures on and on. So I think the first attempt should be the best attempt when we address a sleeve leak, because subsequently the chances go down, the patient might become debilitated, hyperalbuminemia, managing these patients will become even more difficult. So that's the completion of the sleeve gastrectomy. I just added a video after the discussion of Mohit. This was another similar case, which is a 35-year-old female. It's a very interesting case. Patient present was operated outside. Those two cases were out, but this was operated outside. Patient had a leak. The patient was managed with 2 times endoscopic stenting were done. The patient was fed up. The patient, when they presented to us, had a lower lobe consolidation with a cavity. So we basically did an endoscopic vacuum drainage of the collections. Bowel rest was given, sepsis control was done. So we wanted all the inflammation to settle before we actually go in. So this was a leak that was in the top end of the sleeve, but the sleeve was into the thoracic cavity. So it was in the chest and then it was draining out. This was quite a difficult surgery, took a very long time. As you expect, a lot of adhesions. Of the omentum to the abdominal wall. This is actually the first time we're going in as a surgery because only earlier endoscopic attempts were done. So because we use this endoscopic vacuum drainage to reduce all these abscess, the cavity, the drainage through the sleeve, through the leak, because it was quite a large leak at the top end of the sleeve and also on the lower part of the esophagus. The leak was actually from the lower end of the esophagus all the way to the upper part of the stomach. So it was quite a large leak. So we were able to drain the leak using an endoscopic vacuum drainage. About 5 to 10 millimeters of pressure on an interrupted basis was done using my endoscopist. So we were able to monitor the sepsis that was coming under control. So you see that tube that was inserted transnasally. So that is the tube that we were using for the endoscopic vacuum drainage to reduce the sepsis for the sepsis control. As you expect, it's a very difficult surgery. You see a lot of adhesions. So that we use that tube as a guide to actually find the leak also, because it was through the leak that the entire tube was coming. So now you see we are almost through the hiatus. We're able to identify the large leak. So once you see the leak, so we were prepared to do similar to what we did. Okay, let's close the leak. Let's do a Roux-en-Y gastric bypass. And I think we would be able to get along with this patient and then come on. So with that proactive mindset, we found the leak. We started closing the leak. We were very happy that we were able to close the hole. But I repeat, this was from the lower end of esophagus all the way to the stomach. But then when we did the endoscopy on table after this closure, so that's when it got tricky. This became a stricture. So there was actually, once you closed the leak, because it was the lower end of esophagus, it was a large leak. Once you closed, it became a narrow end. So the endoscopy was finding it difficult to go through. So we cannot leave that and just convert it to a Roux-en-Y gastric bypass because we are created a potential stricture at the top. So we had to do something else. So the 2 alternatives we had. One, thinking about a fistulojejunectomy. Can we do a fistulojejunectomy? But again, it was very narrow. We were not sure of the drainage as such. And if it is going to leak, etc., it is going to be more dreadful. The second option is going to be total gastrectomy and esophagojejunectomy. And we all know, I think we just saw a video from Mohit how esophagojejunectomy can become dreadful. So we thought, what else do we have in the armamentarium? Because these are the options: Roux-en-Y, fistulojejunectomy, or esophagojejunectomy. We tried something completely different. So what we did, we thought we will use the entire gastric pouch, what we have planned for Roux-en-Y gastric bypass, but extend the hole from the gastric pouch all the way to the fistula. So we'll have a large opening in the stomach. We will do a esophagogastrojejunectomy was the plan that we had. So we mobilized the lower end of esophagus completely. We transected the stomach, like what we'd have done using a stapler for the Roux-en-Y gastric bypass. So now we use this, we extended the gastrotomy all the way to the leak. Something like a stricturoplasty. So we want to use the leak and the opening in the stomach together as one single opening, because we want to prevent a narrowing at the same point. At the same time, we did not want to sacrifice the entire stomach also. We wanted to save the stomach because we know total gastrectomy is going to be a dreadful operation. But at the same time, we did not want to make a narrowing or a stricture. So we thought of doing an esophago-gastrojejunostomy, or you can otherwise call it esophago-fistulo-gastrojejunostomy. I know the terminology has become complicating, but then we made a divided the jejunum for a subsequent Roux-en-Y jejunostomy. So that alimentary limb is now taken up. So we make a jejunotomy. And now the extension of the entire stomach that we had done, the entire gastrotomy we had done. So we'd be using that to do a large opening of a esophago-gastrojejunostomy. Plan to discuss this video was not there. Then I thought, because we had a wonderful discussion going, maybe we can use it for a dinner discussion later. You see, that's the leak, the actual leak from the esophagus. We have the bougie as the guide to ensure we don't cause another narrowing, because to prevent narrowing was the primary principle that we're doing. Of course, we could have gone ahead with doing a total gastrectomy and esophagojejunostomy, which we didn't want to. We've used these kind of principles whenever we have just around the GE junctions, where it would cause narrowing of the tumor, where we have done similar kind of approaches to prevent a stricture at the esophageal level. I know my time's up, so let me rush through. Another layer. So now you see the completed esophago-gastrojejunostomy, and that's the hiatus that you can see. Of course, we do another layer over it. So the aim was to just go closer and do a gastrojejunostomy drainage procedure. But again, we always believe some kind of a drainage procedure has to be done. So that is from the distal part of the stomach. We remove a portion so the antrum is still retained. Of course, if we can use it for subsequently whenever we have to use that particular point. Yeah, and then the next part of it would be the jejunostomy, which is not needed. So doing a total gastrectomy and esophagojejunostomy is an extreme step. Yes, it's been reported, it's been done, but this is one of the possible techniques where you can possibly prevent doing a total gastrectomy and esophagojejunostomy, where we can avoid, because that's the last step that you have. And this really worked out well. The patient recovered well. The patient went back home. So to conclude, sleeve is definitely an easy procedure, but not simple. Complications can be grave. You need to have a high index of suspicion, and early diagnosis is very, very important. And early treatment could potentially lower morbidity and mortality. I think with regard to sleeve leaks, we do the best at the first time instead of waiting more and more, because it becomes very difficult, and that's when we end in mortalities. And I think in part of sleeve leak management, reducing the high pressure to a low pressure system is very important, but how we do it is a surgeon's choice, but that's part of the treatment of a sleeve leak. Thank you for your patient listening.
Thank you, Praveen. I think in the interest of time, if you agree, we should bring this session to a close, and thank everybody for their comments and great presence. Thank you.
I've got to give away the certificates. So please, can I invite on stage Raza's next to me, Waleed, Sisi, Matt? Can I also take the privilege of inviting Vijay? Vijay, can you please come up? So is anyone from the organizers? What, any housekeeping announcements where we have to meet? What? Yeah? 6 o'clock at the lobby? Okay, so I'm doing this on behalf of Edward, I guess. 6 o'clock outside. 6 o'clock outside. Okay. Prof Lee knows better. Follow Prof Lee.